looking into how to save it. So as far as this meeting, this is about the nursing homes and surveying and credentialing and our understaffing and things that we have on our surveying crew. And so we're just on a fact-finding mission like we have been before. Everything's on the table as far as solving these issues. They've been around for a while, and there aren't any easy answers, just like we found with about everything we worked at, but still no excuse for not incrementally working at trying to solve these problems. So with that, we're going to go ahead and thank you, staff and conferees. Thank you for being here. And with that, we're going to get an overview from Lacey. Lacey, you're up.
Good morning. I'm Lacey Hunter. I'm the Commissioner of Survey Certification and Credentialing for KDADS. Okay. We covered slide one, though. I'm slide one. Okay, so we're going to skip over to slide 4 to start. Okay, so in my role as the commissioner, I oversee several divisions. One of those divisions is licensure and certification. Our division not only licenses but certifies for CMS, but that does include a lot more than just that CMS certification. In fact, one of the #1 prerequisites to get certified by CMS is to have a state license. That state license is also under that same staff and purview. As the licensure and certification division, we approve the adult care home licenses. We then follow up under survey. We also are responsible for ensuring that anytime they have a change of administrator, a change of operator, a change in bed count, a change in required room use, all of those are going through me and my staff. Other things that same staff do is we operate the Civil Monetary Reinvestment Program. We are also doing the enforcement for any time there is a deficient practice found and enforcement remedies are required. We are also doing all of the initial change of ownership. Those are all going through my office. The next slide. This gives you all of the different divisions that we oversee under that adult care home. So that encompasses assisted living, adult daycare, boarding care home, home plus, nursing facilities for mental health, intermediate care facilities for the intellectually and developmentally disabled, and residential healthcare facilities. During the past fiscal year and this current fiscal year, this same staff was also charged with another responsibility, which is receiving all of the discharge notices that are initiated by the facility for what we would call the state licensed only segment of that group of homes you see up there, which would be assisted living, residential healthcare facilities, home plus, and adult daycare and boarding care home. I'm sorry. Next slide. Okay, so the survey division reviews for compliance adult care homes for state licensure and federal certification. So this is my field staff. This is my surveyors that are going out in the field looking at things. This is who we're talking about now. Those responsibilities are accomplished through the administrative review of applications for licensure and ongoing surveys conducted by teams of registered nurses or licensed practical nurses that ensure ongoing compliance with state regulations and federal certification requirements. One of the things we're going to talk about today is how I said registered nurses and licensed practical nurses in there. So I'll point it out there for you. The workload. So those staff, field staff, we're looking at in Kansas right now, we're sitting just over 300. We're at 303 nursing facilities in Kansas right now that are federally certified by CMS or by our state Medicaid agency. The federal government says that we must do a recertification survey or a full survey of those facilities no greater than every 15.9 months, with a monthly average of 12 months. We are currently, as a state, sitting at an average of 19.9 months. We are trying to work that down, but as we get into our topics today, we're going to talk about different ways that maybe we can work together to get that workload into the required parameters. The other workload, so when we're talking about our state licensed only survey staff, we're looking at around 525 facilities that they're overseeing across our state. Next is a map that depicts some of this information for the nursing facilities. This does not include those other state licensed only adult care home types on this map. This map is strictly nursing facilities. It does provide a lot of good information. One of the things to kind of note is the yellow ones with the red boxes. That means that there's no nursing facility at all found within that county. So those where we would find more of our dry areas for that level of care. I'll give you a minute to kind of look at this one. Okay, so the next one is one of our organizational charts. It's the one that's for my commission. I share this because now that we have talked about how many facilities those staff are overseeing and how far the state is, what's in each county, that kind of stuff. So when you're looking at this chart, the people colored in pink, those are your certification and enforcement staff. So they are doing anytime there is a initial license, a change of ownership, a amended change, all of those other changes we talked about, beds, administrator, required room use, all that stuff. They also do the enforcement, which is, so when we go out on surveys, if there is non-compliance found, there is at the federal level required enforcement remedies. I will cover that in presentation number 2. I am here for a while, just so you know. But they also are responsible for all that. They're also responsible for the continuing care retirement community program, as well as the responsibility of the state licensed only discharges that we're currently doing. The next color on the map is yellow. Yellow is our abuse, neglect, and exploitation hotline staff. So required by the federal government, we operate the abuse, neglect, and exploitation hotline for all healthcare facilities in Kansas. And that staff there in yellow is who you see as what we have available. Note, none of those 2 areas have vacancies. We are fully staffed and doing what we can with what we have. The next area is purple. Purple is our state licensed only staff. So they're the surveyors and the quality assurance individuals who are overseeing the survey processes for our assisted livings, residential health care, home plus, adult daycare, boarding care home. Those staff are all registered nurses or LPNs, and as you will see, we do have some vacancies within there. The next color on the map is green. Green is the administration or leadership kind of level of our survey unit. It starts with the assistant commissioner, Ms. Dawn Altus, and then we also have regional managers, and then we have quality assurance individuals. And then there's 2 other kind of leadership levels, which is the state MDS or minimum data set coordinator, which is Lori Malik, and then a state training coordinator, which is Jessica Patterson. Both of those are required, but they're kind of more seniority levels than our field staff for the nursing facilities. Okay, so next we're going to talk a little bit about training. So germane to nursing facilities, we are doing that work on behalf of the Centers for Medicare and Medicaid Services. They contract our state agency to be the state survey agency and hold facilities to the standards that they have outlined. In order to do that, they require any staff who's going to go out on survey in a nursing facility that is certified for Medicare or Medicaid to meet all of the following things I'm going to go through and pass them before they're ever allowed to go in and find a deficient practice on their own. So we're going to skip this one. We're going to go to this one. This kind of starts it. This slide here, it is very dry, but what I want you guys to understand is this is what when I hire someone to be a nurse, they're gonna come in, they're gonna have their normal state orientation training, which is a couple of days. They're gonna get their laptop, they're gonna learn how to do their timesheet, how to do a travel authorization, get their gas card, get their car, all that good stuff. That's gonna take a couple days. And then they're gonna start right in on this, because you can't pass go to start surveys until you pass all this stuff here. This slide here is just the prerequisites. This is for anyone who wants to survey for CMS, regardless of what you're surveying. So this is any of our life safety code surveyors, any of our acute continuing care surveyors. All of us are doing this. And as you can see, the duration is quite long. On the left-hand side, all of that is reading. I went out and looked at it. It's about 1,500 pages of reading. And it is not a page turner or a thriller for any stretch of the imagination. Unless you have a deep passion for regulation and oversight, then you might find it very, very good. The next part is specific to the long-term care survey process. So the one I said before, it covers every survey type. This is specific to those who are going to go in and survey for nursing facilities. Again, some of them are kind of short, some of them are the whole working day, some of them are several working days to get completed. It is a very in-depth process. It is a process that has been shortened by the federal government. So kind of a little bit before COVID, it wasn't really COVID driven, but the federal government switched from a in-person testing to an online testing and more of a self-paced learning model for the surveyor to go through the long-term care survey process. It was about a year, and it was a year if you were lucky and they were testing in Florida around the time. The tests were always, I think, in Florida. But you had to wait till there was a test, and you have to pass the test before you can go out on survey. So that being said, the federal government did shorten that. It's now internet-based, it's self-paced based. We've seen the process go from about a year to 6 months. Most of our staff are getting all this done, getting all their tests passed in about 6 months from the date of hire. That is still concerning to our federal government partners. I was just out in Utah talking with them, and they were very concerned to hear that it was still taking 6 months to get survey staff trained and through the doors. They thought that their changes would make it a lot shorter than that, so they are continuing to look at how they can shorten that process, but they are aware that it is still taking around 6 months for us to get our team ready to go out. So the next page is a continuation of it. So you are doing all of this. Again, we're talking, sometimes you can do a few of these in a workday, some of these are several working days over, all required before we can go out. You guys can go back and look at the topics later. They're pretty self-explanatory when we read the topic titles, but that gives you at least a decent idea of how much training goes into that surveyor before they're ever allowed to go out on their own and make an independent decision on whether or not a facility is in compliance. Prior to that, they do go out on surveys, but they're not allowed to make judgments or identify noncompliance. They're out with their preceptor. They do go out, though, as required as part of this training. I think it's in slide 1, actually. You have to do at least 2 observation surveys. But there is an extensive amount of studying that goes into these staff members before they're allowed to go into the nursing homes. Okay, so we've talked about what we do, how many of us there are, how many people we oversee, what it takes to go oversee them. Now we're going to talk about how I don't have enough people to do that and possible ways we could get more people to do that. Okay, so in efforts to get more survey staff, we worked with our Department of Administration to reduce the total number of vacancies we had for field survey staff and increase the remaining ones to a starting value that we thought would be more appealing to RNs and more closer to what they're getting paid out in that public sector. So we started with 51 and a half positions, so 51 full-time, 1 part-time position. 28 of those were vacant. After we talked with the DFA, after we wheeled and dealed, we got to an agreement of we were going to eliminate 15 of those, which gave there to be 13 remaining vacancies with a higher salary. So it was that the starting salary was $60,000 for all of those. But now we have the option of those 13 remaining to be $60,000 for someone who is not an RN, or up to $67,000 for those who are an RN. That is then increased by $2,000 when they pass all of that training you just saw. So you go up to 62 or you go up to 69, but they have to pass the training to get that bump in pay. They also have to pass the training within a couple of years, or we will reassign them to somewhere else within our agency. Okay. So CMS says that we can have several different types of people, but they do say that they feel that the survey process requires an appropriate background in health professions or health administration, in addition to basic investigation skills. But this is the list, this is the official list out of Chapter 4 of the State Operations Manual from CMS of who can be a surveyor. The last bullet on the last in, any other professional category used within the state merit system for health professions or health profession positions. That one we kind of call generalist. For the sake of the next couple of slides, that bullet becomes the word generalist, but that is what the official language is in the manual. To note, we do have, and we do talk with people in other states. I have a broad network of the me's of the other states, and we are hearing from Nebraska, Iowa, Missouri, their use of what we would call that generalist right there. They're also using what we've heard is licensed nursing home administrators, dietitians, social workers, licensed practical nurses, environmentalists, sanitarians. Okay, so here in Kansas, we have not bridged the gap to actually hire anyone who is not an RN or an LPN. And it is mainly for reasons of how they are classified as exempt or non-exempt. One of the issues that we are facing, and we have made a list of pros and cons, there is several pros. As you can see, the pros overwhelmingly outweigh the cons. Unfortunately, some of the cons are just big cons. So I'm going to focus a little bit more on that one, which is the generalist is not going to be a registered nurse, and neither is the LPN. And what we have hired some LPNs, and so they fall into that same category of the LPN is not exempt and the nurse is exempt. The survey process is a couple of days, if not a week, and it is often not right next door. So when we are looking at staff who are not exempt and held to 40 hours a week, or we're paying overtime, we're including their travel time to whatever home they're going to, the survey process, and their travel time home. They hit 40 hours before travel time home even comes, if they're going to stay for the entire survey process and do all the tasks that were assigned to them. That part will make a little more sense in my next presentation, actually. I go over the survey a little bit, but that then leads to, we have the registered nurse, who is the team lead, is the one required component of the survey team, who after a couple of weeks of getting 40 hours banked for your overtime as discretionary leave that you could use, you then go into getting time and a half. And it's not going to take long for someone who's, say, a CNA or a generalist or someone else to be making far more than that registered nurses when they're getting their overtime pay. The other part to that is overtime pay would require, I believe, an increase in our budget, because we're not currently budgeting for any type of overtime. Pros, though, I touch on them a little bit. I think it would give us a lot more flexibility in how we are doing our surveys. The survey team, if we're doing a recertification survey, does require one registered nurse. But that doesn't mean that everyone else could not be a nurse. So we could take the pool of nurses we have now and start creating several teams instead of the one team of all nurses as it is. The other thing that I think that would help with us is, I think it gives us a broader range of who we can look for if we're looking outside of nurses. even at the $67,000 mark, we're still struggling to recruit nurses when we're competing with the public sector. That is a lot higher. I think the other part would be is if we were able to have larger pools of survey teams, that then increases our ability to complete the workload. That then gets us back more towards that 15.9 goal that we're supposed to be at instead of the 19.9 that we are at. Yeah, I think that's probably, we'll go on to the next slide. This is just kind of a quick overview so you guys can kind of, if you want to go back and reference, this is my organizational charts of my certified nursing surveyors, so my nursing facility surveyors here. And this is the updated organizational charts, so it does not include the reductions that we talked about. As you will see, there are still a handful of vacancies in each region as we go through these. We did that on purpose so that as we are able to fill with hopefully this higher amount, we're still filling equitably across the state. That's it for this one. I have another one right after this.
Thank you for that. I'm sure there's a lot of questions. I know I have a bunch. Committee questions. Representative Orpeza.
Thank you, Mr. Chair. As you were going through your slides here, how much of this is done on the computer, like an iPad?
The survey process?
Yes.
It's entirely electronic.
Entirely electronic?
We
Okay.
switched to an electronic survey process in 2017. We were a test state to actually roll it out before a lot of other states.
Okay.
And it's an electronic system built by the federal government. So it's a application that is prompting my staff as they're going through the survey process, which we'll talk a little bit more. The first couple of slides of my next presentation walks you through what the days of a survey look like.
I have another, is that okay? Okay, thank you, Mr. Chair. So my next question is in regards to the gross pay, which is $67,000. What about driving around to these sites? Are the staff required to use their own car? Does that come from the state?
We manage a fleet and provide them a state car.
Okay, thank you.
Representative Bryce.
Thank you, Mr. Chairman. Thank you, Lacey. Just a quick question. The non-RNs who are hired, such as that are licensed or registered, like a medical doctor, a nutritionist, pharmacist, physical therapist, do they need to have current licensing or registration active to be hired, or can you hire retired people from these professions that aren't currently registered or certified or licensed?
I don't want to tell you incorrectly, so I will double check, but my knee-jerk reaction is yes, we could do that.
Okay, thank you. I just thought that might be something to help fill in the workforce. Thank you, Mr. Chair.
Senator Thompson.
Thank you, Mr. Chair. Thanks, Lacey. One quick question about the, if you were to expand that list of surveyor positions to some of these other disciplines, what's the process in that? Does it have to go through legislature to approve the expansion of those survey positions, or how does that, because you're listing some being used in other states that we are not using. I'm just kind of curious.
No, it does not. We could do it now. The reason we have paused is because we have hired LPNs and we have seen how it turns out when you have exempt versus non-exempt. And it goes down to even the relationship the team members get, because it's hard when you're the one person who has to stay over 40 hours and that survey has to be finished, or the two people and the LPN gets to leave at Wednesday and you're there till 8 o'clock on Thursday night. And the LPN's done for the whole week. So all of her work that she did is gonna have to be taken back to the office and written up. And she doesn't get to do that either. It's going to be someone else taking her observations and writing the actual deficiency. So we're losing firsthand writer.
I'm actually happy to hear that because I think, expanding some of these others would kind of dilute the pool on the expertise. So I appreciate that.
I will say, and I forgot to mention, if it's okay, we have had a really, really strong support from our HR department in trying to recruit. I know that we have staff out at career fairs weekly. We have little cards with a QR scan that you can do. Some of our staff get asked by people in the nursing home, and I will preface this, we are not poaching staff from nursing homes. We are not. But if we are ever approached about how to do this, we wanted our staff to be equipped with, this is how you could do it if you wanted. So we have a little pamphlet, and it's for anyone. We've also, at those career fairs, if people are interested, we are doing little mini interviews on the spot and getting them through the application process. As you are aware, for any state job, there's a few pieces of paper you have to fill out. So we try to help sure that they get all that in, that it's right, that they're squared away to get hired.
Representative Bueller.
Thank you, Mr. Chair, and thank you, Lacey. I'm curious, is the biggest issue with not using the generalist just the differences, as you mentioned, between exempt and non-exempt? So have any of the Lacey's in the other states figured out a way to crack that code? I'm just curious if they're able to get around or find a way to do that, because it seems like in any of these health and human services or social services things, that with the incredible lack of nursing across the state, anything that we could do not to tap into that pool, and assuming you can find the right people, that would be a good way to go. So I'm curious if the other states have found a way to actually use the generalist.
Sure. So in most other states, their RNs aren't exempt. So they're working with all non-exempt, and they're making those budgetary decisions to have overtime and stuff like that. But that's always been the way they have been. So they didn't have that hurdle of exempt versus non-exempt. In most of the other states, even their registered nurses for the survey portion are not exempt.
So if I may, I mean, that's the mechanics of the difference between exempt and non-exempt. So if there were some ways to work around that or change, there would be a way to potentially use the generalist. Okay, thank you. Thank you, Mr. Chair.
Thank you. Representative Reeves.
My questions are on the same lines, like what would it take in order to have everybody? Was it non-exempt?
I believe that's a decision that's held with the Department of Administration.
Okay.
Could you repeat that?
Oh, the Department of Administration makes those decisions.
Makes those decisions. So that's the reason. So piggybacking, that was one of my primary questions here is, so is that a legislative function? Is there something we can do, administrate in rules and regs? Or is that totally up to the Department of Administration?
Can I take that one back? I don't want to give you the wrong answer, but I don't know the answer right now.
If you could bring that back, and that's kind of the crutch of what we've been dealing with here is having 4 people that are exempt on a committee or non-exempt and doing, and not finishing their job. And it kind of rings hollow for me for when you say, oh, they don't get along. You know what I mean? You either do the job. I mean, I'm a private sector guy, but if you don't get along with your team, then you probably need to find another job. So that kind of rings a little bit hollow. But so that's the major reason for why we don't have non-exempt employees is the Department of Administration.
In my opinion, yeah.
Okay.
I think the team
Well,
dynamics
if
that
you'll
it
come back to
causes-
us with that, because I think that is critical for us to move forward in staffing is non-exempt employees. It just makes. Another question, okay, so on the training, is that annually or is that just when they're hired?
Upon hire, CMS did roll out a couple of years back annual training to make sure that everyone is up to date. I would actually have to defer to Dawn. Have they actually put that in? 3 hours. It's 3 hours of continuing training every year for our staff now.
But the original deal that you were talking about, all that 1,500 pages and all that is just to be hired?
To be certified in the long-term care survey process, yes.
Right. And then it takes 6 months and we pay them 6 months while they're taking that training?
Yep, and they're paid at that. So for the registered nurse right now, it would be they are getting paid $67,000, could go up to $69,000 if they pass. For the generalist, they would be at $58,000, go up to $60,000 if they passed.
And then, just to follow, how many people are there on a team?
Survey team depends, and it's actually in the state operations manual, but it depends on the amount of residents within the building. But regardless of how many residents in the building, a registered nurse is required for every team. So back to the dynamic things, the person that's stuck holding the bag is the registered nurses. And if they don't like their job and go get a new one, we're out of teams because they have to be a part of the team.
And how many people?
It depends on the, so a facility.
So just give
sorry.
us an idea then.
Oh,
There's-
in Kansas, we don't have any facilities that require more than 4 people on a survey team. You would have to get up to, I think, 175 beds to get up to 4 or 5 people. We don't have facilities that large here in Kansas.
So most of the time, a team is 2 people?
I would say most of the time it's 3 to 4. Where 3 is kind of the sweet spot for most of our homes, yeah.
Okay. And 1 RN?
Has to be, 1 RN has to be there, yes.
Okay. All right. Committee further. Representative Bueller and then.
Just one quick question, Lacey. I'm going back to, I don't know what slide it is, but you're talking about the federal requirements on how frequently and often we survey. So if the average is 15.9 months with a monthly average of 12 months, if the state of Kansas is at 19 months, as you indicated, is there a CMS penalty, or what happens when you're out of compliance? Because it would seem like we're out of compliance with that.
There can be. CMS could say, you know, you're not fulfilling the terms of our contract. We're going to recoup the money and fulfill the terms on our own. But we are not the only state in this situation, and they're also having a shortage of surveyors. So I don't think their ability to take back and do it on their own is there right now. And it's not something where any state has been penalized since COVID happened. Prior to COVID, states were being penalized. They were having states use some of their money to have a survey company come in, Health Management Solutions, or HMS. We actually had them here in 2017 and 2018. During that time, we successfully we were back down to, I think it was 15.8 months right before COVID hit is where we were at. But unfortunately, the survey process stopped for quite some time, and it stopped again this morning, so.
Thank you, Mr. Chair.
Representative Opeza.
Thank you, Mr. Chair. In regards to benefits besides salary, what does like paid time off look like?
It's an accrual basis, like for any state employee on that state scale.
You have to tell me how many hours is that?
I would have to look up the chart. I think it's if you're an employee for 1 to 5 years, it's a certain amount of hours you accrue every pay period. If you've been an employee for 5 to 10, it's a higher amount that you accrue. And you accrue paid time off and sick leave, both. And they're split out. But I would have to get the chart for you. I don't know off the top of my head like the different categories, but it's every state employee. That it's our employees don't have anything specific to them.
Okay, perfect, thank you.
Representative Pickard.
Thank you, Mr. Chair. Lacey over here. Hi. So are surveys done unannounced?
Yes, ma'am. And it's required that they're unannounced.
Okay. And so did I hear it right that it takes 3 to 5 days for an average survey?
Yeah. So one of the things that we did back in 2018 when HMS is out here is we started only doing the minimum amount of surveyors needed as outlined for that survey team size, so that we could have more teams. But then we also set in some policies for our staff that you have to be able to do your entire research survey by Wednesday, get back to the office, do your write-up Thursday, do your travel expenses, all of that stuff that you have to do just because you drove a state car and you spent state money. And then they work 4/10s. They're off Friday. But if they have to go past that 4th day, they have to call Dawn and give Dawn a very good reason as to why it took them longer than 4 days.
Thank you.
Committee, further questions? So will you be walking us through a survey at some point in time? I don't want to, is that next? Yep. Okay. Thank you.
Okay, we're gonna skip to 4, because I'm still me. That's the title page. Here's where we start. Okay, this is what the recertification survey process typically looks like. I'm sorry, I skipped a slide. I need to go back. Yes, okay. Day 1, we are entering the facility. We are posting on the door that there is a survey in process. We're going to take a tour of the kitchen. We're going to interview, and particularly interview direct care staff, observation of residents, interviews with residents and resident representatives, limited overview of records, dining observations, and requesting information from leadership. Staff go to the hotel, come back, next day, day 2, they complete the initial pool process, which is, so the initial pool is of all of the residents, the resident roster that was given by the facility to our team, that's put into the system, which is currently now, it's called iKeys. iKeys is an internet-based system. Before it was Aspen, but it is the long-term care survey process program that they enter all their information into. But that's gonna say, here's who we're looking at, and that's your initial pool of residents and staff that you're gonna be doing an in-depth review of. So then once you have that pool process, you're doing the interview, observation, limited record review, resident sample selection, and then you start really digging into the things that have been triggered on through that process in our system that say you need to go take a look at these things need to be looked at a little bit further. So then day 3, possibly day 4, is that third one there. We're continuing all of our in-depth surveys, mandatory facility tasks, which include a kitchen and dining observation, infection control, medication administration, medication storage, resident counsel, and then triggered facility tasks, and then potential citation review. Potential citation review is kind of where we're gathering all of the things that we've seen, and then how does what we've seen equate into noncompliance, and where is that noncompliance found within the law. Last day we're there, we do the exit conference. The exit conference consists of the nursing home administrator, the director of nursing, the resident council president, interested residents, and the ombudsman. They are not all present, they are all welcome to come, but not always there. The survey team will report potential findings at that time, but we do not identify the scope and severity of the noncompliance. We will identify related facts, but the survey team will not say the scope and severity of the concerns they've seen unless it's in immediate jeopardy. The findings at that exit interview and the conversations with our staff at that exit interview are preliminary. The statement of deficiencies is the official statement of citations found, and it is not issued at that time. It is issued up to 10 days later. We do also notify the ombudsman's office. The ombudsman has several regional ombudsmen, and so whatever region we're working in, we email them before we're headed out, and we ask them, hey, this is where we're headed. Have you been out there? Do you have any concerns? Those types of things we're trying to get with our ombudsman before we're headed out, so that we're making notes if we need to do any investigation because of feedback we've got from them. That's a day in the life of a surveyor. So after we leave, within 10 days by the federal government, if there is an opportunity to correct or their deficient practices are not harm level, substandard quality of care, or immediate jeopardy, we have 10 days to issue them the official statement of deficiencies. We also then, so the way the process works is we will issue you your statement of deficiencies. We request that you email us back as a receipt of it. Once you email us back, we then send you the resident and staff identifier list so that you as the facility could read the statement of deficiencies, which is a de-identified document, but you have the key to the document as the facility so that you can fill in the blanks and make corrections as necessary. Those things are all given 10 days after we exit. 10 days after they receive that, the facility has, within that window of the day they receive their statement of deficiencies, they have 10 days to request an informal dispute resolution, or an IDR. And they have that same time period to submit to us their plan of correction for any deficient practice found and cited on that statement of deficiencies. Once we have a plan of correction from the facility, we are reviewing that plan of correction, and then depending on what the deficient practice is, we have the flexibility to either do an on-site revisit to ensure compliance is found, or do a desk review to make sure compliance is found. And this SOM talks about if we have to go into more than 2 revisits, we have to get permission from CMS. It is rare that we are doing that many revisits, though. Okay, so next, a little bit about immediate
Hang on,
jeopardy.
could you repeat what you just said there about the permission from CMS?
I'm going to cover it a little bit more later.
Okay,
Can we,
okay.
So the next page talks a little bit more about immediate jeopardy. So a couple of years back, CMS, it's been more than that now, it's been probably 5. CMS came out with this template that you see here on the right-hand side. So it was a way for them to streamline and ensure immediate jeopardy is truly being identified. That being said, there is 3 components. So you have 3 sections. First section, our staff who's out there in the field has to find where their failure to meet compliance is. The second box, they have to explain the likelihood or serious of harm. So kind of some bullet points there. So staff are going to be filling this worksheet out. My survey staff are filling this worksheet out. They're going to be identifying what the likelihood of serious harm was or actual harm. And then the third part, they're going to identify that a need for immediate action is necessary to prevent the occurrence or reoccurrence of serious harm. Those are the 3 elements that must exist for an immediate jeopardy to exist. Beyond those 3 elements, this form must be filled out. This form is then sent on to Dawn and the rest of our leadership staff to review and confirm immediate jeopardy has been found. Once it has gone through that process, we then issue it to the facility and let them know that an immediate jeopardy has been found by giving them this template that was filled out, reviewed, and approved by my staff. Okay, so levels of citations, and I apologize, it's really small. I tried to make it as big as I could. This talks a little bit about, and we're gonna go into some more detail about enforcement remedies, citations. So what this depicts right here is the required enforcement actions by our partners at CMS when non-compliance is found at different levels within that chart. Kind of a note over to the side that I would like to point out. So within that little box over there on the right, it talks about how within 5 business days, we must forward it to CMS. And then it also talks about, regardless of whether or not me and my team take an enforcement action, if we choose to stay neutral, the CMS location must take these actions. All right, we're gonna talk a little bit more now about the different actions that happen. So we have a survey, we exited, we issued them the statement of deficiencies. You get to, depending on what those statement of deficiencies included, to the enforcement part now. So CMS has 3 levels or 3 categories of enforcement remedies. Category 1, CMS must select at least 1 category if there are isolated deficiencies that constitute no actual harm with a potential for more than minimal harm, but not immediate jeopardy, or is a pattern of deficiencies that constitutes no actual harm with a potential for more than minimal harm, but not immediate jeopardy. So then over kind of in the graphic there, you have the actual category remedies that you would have to pick at least one of these. Our CMS office would have to pick one of these. With Category 1 remedies, it is outlined that both the State Medicaid Agency and CMS have given us, as the state survey agency, authority to impose Category 1 remedies on their behalf. Next, Category 2. Category 2 is when the citations are a little bit more severe. It is when widespread deficiencies that constitute no actual harm with a potential for more than minimal harm but not immediate jeopardy or one or more deficiencies, regardless of scope, that constitute actual harm that is not immediate jeopardy. So again, the graphic on the side is the remedies that they must choose from if the facility is cited at those levels in scope and severity. There is kind of one caveat. So one of the actions that can be taken in here is a denial of payment for all Medicare and Medicaid admits, and that can only be imposed by CMS. Not even the state Medicaid agency can impose that one. I've done this job since 2017 and it's never been imposed. Level 3. So these are our most severe citations. Maybe? Okay. So again, level 3, our most severe citations that we're writing. So these are your actual harm, your immediate jeopardy, substandard quality of care, repeat, noncompliance. So temporary management, termination, or both must be selected when there are one or more deficiencies that constitute immediate jeopardy to resident health or safety. And there is some other categories, again, on the right. All of those, when you are at this level, you do lose the they must impose. So on the right-hand side, that's actually straight out of the Psalm. And so you'll notice on the first two, it says they must choose one from these categories. You lose that language in this one at the federal government level. So I think here where we're talking about if we're not doing termination, which is, I think, the ultimate enforcement, we're closing you down, we're shutting you down. Well, CMS is closing you down, shutting you down. But below that, we have temporary management. Temporary management is a category of remedies that we try very hard to encourage our regional office to utilize before they go to termination. It's been very successful, I feel like, in our state when we have been able to use those temporary managers to help coach people back into compliance and remain in compliance. And it keeps beds open and doors open in our state as opposed to that termination, which then you're closing your doors, everyone has to find a new home. And we want quality care given, and we want to make sure that we are providing opportunities for people to learn how to give that care. That being said, we are asking for them to provide that care with a manager in there who's watching it and making sure that until they're up to par, the residents are being taken care of to that level. Next slide. I'm going to go into a little bit more about the civil monetary penalties. This is by far the biggest or most used remedy by CMS. There is some lower category remedies that are always used as well, but depending on when you get back into compliance, most of the time those remedies are never effectuated. A civil monetary penalty is always due. So we're going to talk about them a little bit more. So CMS or the state Medicaid agency, not my staff, can impose two different types of civil monetary penalties. So it can be a per instance civil monetary penalty, or it can be a per day. An instance is a single deficiency identified by the tag number used as a reference on the Statement of Deficiencies, or CMS 2567, and in Appendix PP of the State Operations Manual. There can be more than one instance of noncompliance identified on a survey.
May I ask a question? Lacey, from a process standpoint, the informal dispute resolution, is that running in parallel while this is going on, or, okay, I'm just trying to make sure I understand the process. So while the survey is going on, if something's been found, you can immediately trigger, may immediately trigger that informal dispute.
The informal dispute is triggered on the day that you get your statement of deficiencies. So when you get the formal notice of noncompliance is the day your calendar for you have 10 days to request in a dispute resolution starts.
Okay. Okay. Thank you, Lacey. Thank you, Mr. Chair.
And to follow up on that, so when does this come, what we're looking at here on slide 11, when does that come into effect? After the informal dispute, or is this?
It depends. So these are issued by the CMS regional office out of Kansas City, and it depends on how far behind they are on their work. It can be anywhere from a month after the deficient practice was found to, I've seen, close to 2 years now before this letter is issued by our federal partners.
Wow. Please continue.
So you have per instance, then you get to per day. So per day is when there's noncompliance found, and they're going to issue you an amount that you will pay every day that you are out of compliance until you are back in full compliance. Oftentimes, when there is immediate jeopardy found, we are seeing that this per day is being utilized, and it's being utilized at a level of the days in which the facility was in immediate jeopardy. Their per day fine is 10,000 plus is what I'm seeing per day, until they have removed or abated the immediate jeopardy, but still remain out of compliance with all requirements. So then you get the time period that they've removed the immediacy of the jeopardy, but they're still out of compliance with all requirements. And then CMS is saying for those days, you're gonna pay a per day of somewhere between like $300 and $600. And you're gonna pay that for every day that you're out of compliance until you meet all requirements necessary for the conditions of participation with us. So the next slide is some examples. So kind of what we found, or what CMS found as the deficient practice, and then what the CMP was. So this first one, there's a housekeeper asked a resident for $300. The reporting mechanisms when fellow staff member heard of the $300 and then reporting it to their leadership were some of the failures that were found. And CMS fined that facility $3,627.25. Example number 2, so there was some resident-to-resident abuse that was going on for an extended period of time, involving 19 residents, and the facility received a civil monetary penalty of $43,660.50. So resident-to-resident abuse is probably some physical altercation, verbal altercation that has been escalated to a very large degree, but the third example we have is when the nurse on duty appeared to be impaired or under the use of a substance. The head nurse was notified. The facility did not do anything about it, and the nurse who was possibly under the influence was left as the charge nurse for close to 7 hours. The facility was fined $53,504.10. Okay. So one of the things that I believe you guys are charged to review is immediate jeopardy citations and the civil monetary penalties associated with them for the past 5 years. So that's what this section is going to go over here. So when noncompliance is found, CMS or the state Medicaid agency can issue between $3,050 and $10,000 per day if it's immediate jeopardy, between $50 and $3,000 per day if it's not immediate jeopardy, or a per instance fee of $1,000 to $10,000 for each deficiency. So those are the true parameters. The numbers I gave you earlier are what I'm actually seeing CMS issue to our state and to our facilities. So a CMP is a valuable enforcement tool because it can be imposed under certain circumstances for each day that a facility is out of compliance with participation requirements or for each instance of noncompliance. If imposed, a facility cannot avoid the remedy. The CMP may be imposed immediately or after the facility is given an opportunity to correct, and a revisit finds that the facility remains out of compliance. A civil monetary penalty is imposed sometimes by our partners at CMS when immediate jeopardy is found, and that's where you see that shortened time period in there. The imposition of civil monetary penalty does run in concurrent. So if you have requested an IDR, you still have to pay your penalty, and it's held in escrow until the results of that IDR happen. The survey cycle, the enforcement cycle, none of that is halted or altered because an IDR is requested. When CMS issues a civil monetary penalty over, I believe it's $12,000. I have to look at the right number, I apologize. You have the ability to do what's called an independent informal dispute resolution. And so the facility, once they have received their statement of deficiencies, every time they receive a statement of deficiencies from my staff, they're given their rights to request an informal dispute resolution. Anytime CMS issues that civil monetary penalty, they are issuing at that same time that facility's rights to an independent informal dispute resolution. Same timeline, the facility has 10 days from the receipt of that notice from CMS to request that independent informal dispute resolution. The other thing it kind of talks about down here is state Medicaid agencies and CMS locations are encouraged to develop methods to ensure that CMP amounts are applied consistently within the broad ranges identified at the federal laws. I think what we have seen is, so CMS locations have, since this was written, they were very, very regionalized, and CMS has since kind of changed to this idea of one CMS and ensuring that the actions taken by one regional office match those of another regional office, and making it so that there's continuity not across just the state, but across all states when it comes to actions taken by CMS. This is the chart. These are the actual numbers. These are the number of IJs for the past 5 years, broken down by the CMPs. So when you're looking at this, this is filtered to be only IJs on here. But so when you're looking at this, the first two columns is the total number of CMPs issued for IJ citations. The next two columns is the total amount that was issued to our state, or to facilities within our state for that year. And then the next two columns are the average amount that was issued to each facility for a per instance or a per diem CMP. And then the last column over there for that per day CMP, it's the average number of days that they're paying that per day before they're back in compliance. Just a little note, we're not done with calendar year 2025, so that's current through about last Wednesday. The next couple of slides are that same information in pictorial or graph form. So you can kind of see some trends. As you can see, 2023 spikes for this one. In the next one, it's 2024. And then in the last one, it's actually kind of I don't know. It doesn't spike like as it did the other two. So as drastically, I guess. Okay. The next little bit is just a little bit more on our abuse, neglect, and exploitation hotline. So in addition to all the things we've been talking about, we also run that hotline. That hotline is a 1-800 number that we have staffed 8 hours a day, 5 days a week. It is ran. The people who answer those phone calls are registered nurses as well. The reason that they are registered nurses is because they are taking any complaint that is called into that hotline and officially entering it into our complaint system that is oversaw by the federal government. The federal government was kind enough to allow that system to also let us enter stuff for our state licensed only stuff. That system also includes all of the facilities that my partners over at the Kansas Department of Health and Environment oversee for the acute and continuing care section. And all of those calls come to my staff. So once they get that, my staff is then looking at the State Operations Manual, Chapter 5, and they are triaging the information that's being given to them, or they're deciding this isn't our facility, this goes to another agency, that type of stuff. So the next, sorry, I got one more. So I just kind of talked about all this. The other things that, so once we receive a complaint, if it is for our team, if it's identified as an adult care home, we are entering and then triaging and then we are sending out to Dawn and to the regional managers so that when they are making their survey schedule, they know where to start incorporating. Every Monday, when our teams are heading out on survey, the regional managers are looking at what complaints came in from Friday to Sunday night, and if we need to start rerouting that survey team to go to an immediate jeopardy. Now the chart. So this is the workload. So these are calls. These are the amount of calls coming in that first column, and then of those, how they were triaged. So if it's an adult care home, we're gonna triage as IJ, non-IJ high, non-IJ medium, non-IJ low, or non-IJ administrative review, no action necessary. Those are all things that my staff are gonna take and then push that complaint down to the survey process and to our survey teams if it's an adult care home. If the call comes in and it's someone broke the law, we're gonna refer it to the local law enforcement. If it's Medicaid fraud, we're going to refer it to the Attorney General's office. If it is the emergency room down the road, we're gonna refer it to our friends over at KDHE. If it's a foster care home, we're gonna refer it to our friends at DCF. And then you have a few that are others. Others are typically items called in by an adult care home that don't reach the level of the necessary need to have it called in. And that's the end of this one.
Wow, that's a lot of information, but that's why we're here, is because of those committee questions. Representative Bryce.
Thank you, Mr. Chairman. Thank you, Lacey. Just a quick question. The civil monetary penalties that are collected, the money that's collected, if I recall, I vaguely remember a plan to set that aside for educating deficient facilities, or does that go directly to CMS, or where does that money actually go?
So the penalties that we discussed here today are the penalties imposed at the federal level by our CMS partners, and that money is given to the federal government, and then a split of that is given back to the state, and it is given to the state to do what's called the Civil Monetary Penalty Reinvestment Program. It allows facilities, stakeholders, people to request monies out of there to enhance the health, safety, welfare, lifestyle of residents.
Okay. Thank you, Mr. Chair. Just one other quick thing. These civil monetary penalties, do they start accumulating at the time of the statement of deficiencies, or is it retroactive to the onset of the behavior?
CMS typically will do the time period from either the day of which the non-compliance started through the day that it stops. Sometimes we're seeing that they'll stop at they'll run it through the day before, so it's the last full day instead of if they're doing a per day civil monetary penalty, so how do I put this in words? You were out of compliance from March 1st to March 3rd. Typically, CMS is saying your civil monetary penalty, if it's a per day, is running from March 2nd through whatever other 24-hour period. So in my example, there was only one probably 24-hour period there. The first, we don't know, if we didn't identify it at 12 a.m. on the 1st, and they probably didn't come back into compliance at 12 a.m. on the 3rd. So CMS is, when they're doing per day, they're typically running it through the amount of full 24-hour periods that they are out of compliance. Is that,
Mr. Chair,
sorry,
so just to be clear, if there's someone's in non-compliance, and let's say it's January 1st, and we give them a statement of deficiencies, if the non-compliance started back in November, then the penalties would start accumulating from November, not from the date we gave them the statement of compliance. Is that right?
correct?
Okay, thank you.
Representative Pickert.
Thank you, Mr. Chair. So I'm going to go back quite a ways in your presentation. When you were talking about the exit conference for the nursing home upper staff, and some select residents can go, I can't remember if you said it was the council or what that was, but my question is, if if there's a patient with dementia or a head injury or something like that, can family ever attend something like that?
The resident's representative could.
Okay. Okay, good. And then the other question I have, are there ever any nursing homes that are citation-free after a survey?
Yes.
How often does that happen?
Through the federal survey process, I think we've had one this year. One this year. It was actually one of our nursing facilities for mental health that had a deficiency-free survey. I could get you some statistics. It's not very common nationwide for there to be deficiency-free surveys with the federal survey process.
Okay, thank you.
Senator Murphy.
Thank you, Chair. When you're talking about replacing management and you go to a temporary, where does that come from?
So we have solicited prior to today because we've had issues in the past, but we talk with and we engage our stakeholders like Leading Age and KHCA and CASE and their members to see if there are management companies that currently operate within Kansas. I think you're going to hear from one today, Grace Team. But we ask, if we were in a pinch and we needed, is this something you guys would be interested in? So we have we have a handful of people that have said that they'd be interested in it. Unfortunately, of the handful that we have, there are few that have the extra staff to be able to drop everything and get a licensed nursing home administrator, a DON, a social service worker in a building in 24 hours.
Right, that was kind of what I was thinking. So, yeah, that helps things.
Representative Bueller.
Thank you, Mr. Chair. Lacey, I'm looking at the data on the A&E hotline chart. 2023 really sticks out. So it was a year that had among the lowest total hotline calls, but it had the highest number of IJ. Was there anything peculiar about 2023 that resulted in that? I don't know if that's subjective surveying, or I'm just curious how that happens in that course of about 7 or 8 years.
So 2023, if you'll recall, would be kind of when COVID was not at its height, but it wasn't quite ramped down yet. And that's where you would start to see, if you went back and looked, where visitation rights and openings of visitation started coming up. So the people coming into the home or being allowed into the home is where you start to see that in 2023. And I think that's where you start to see the spike, because prior to that, a lot of visits were window visits or door visits or non-contact visits. And so when you get to 2023, we get to where COVID is, the guidelines by the CDC are kind of at that point changing to allow for different types of visitation based off of your COVID status and in-person visitation. And more people coming into the home, I think, after not being there for a while, is why we saw that trend.
Okay, but so what I'm getting at, assume there was a repeat of COVID or something like that. Is that indicative of subjectivity in what is and what is not an IJ? Does it depend on the surveyor? I'm just curious. I mean, that just really, and I get COVID. I mean, we all lived through that mess, but that's a lot.
And it's important to note that these numbers are how it was triaged. It doesn't mean that we cited that facility at IJ. It means that when it was called in, the words that were used to give to my staff rose to the level of an IJ.
Okay. Okay. Thank you. Thank you, Mr. Chair.
Senator Thompson.
And that kind of sparked a question from Representative Bueller. It's kind of curious, does the CDC then inform CMS what they consider to be protocol for allowing visits during that COVID era? I think that, as I recall, that was what was going on. And whether or not somebody visited in person or not, was that considered an IJ?
Visitation was, I don't know that we actually ever cited anyone for an in-person visit, but you are correct in that CMS said that the leading authority and the guidelines that we are to follow is from the CDC during that time. And they continue to say that. We've had a couple of facilities reach back out and say, hey, there's updated stuff on COVID, but CMS says keep going to the CDC, and there's no one working there right now, so it hasn't been updated. But that is the response that CMS is giving us and giving our facilities is that they are to continue to look to the CDC for their most up-to-date guidance on COVID.
Yeah, and that was my concern because we now know that there was some pretty bad guidance coming out of the CDC on some of that stuff, and you hate to see people fined for using common sense in some cases. But thank you very much. Appreciate it.
Representative Reeves.
Sorry, Lacey, I had to step away, and I didn't get to hear the end but I'll look at your slides. But a question I had was, once there is a citation and a fine has been imposed, and so they rectify the situation, let's say a week later, but those fines have already been imposed. How long do they have to pay those fines? Like, what happens if they aren't able to pay the fines?
When they receive notice of their fine amount, they're also given the information for how they could apply for financial hardship if they think they qualify for that. And the financial hardship decision is, again, made at that CMS level. It's not our decision.
Thank you.
Committee, further questions? Representative Lopez.
Thank you, Mr. Chair. I had one quick question. As you're going through both presentations, is there any state that doesn't have any vacancies with their surveyors?
Yeah.
And what do they do differently that
Nebraska doesn't have any vacancies right now. They're using generalists. We also have some pretty good information from the University of Kansas Nursing Workforce Center that shows if you look at our counties that border Nebraska, the nurses that live in those counties work in Nebraska. So they're getting a pool of our nurses too, but they do use generalists and they are fully staffed. I believe Alaska said that they just got fully staffed. I could find some other states, but there are some states that are fully staffed. But that being said, fully staffed looks way different for everyone. So we have 15.1 or 50.1, I think was the number I said, of total FTEs. If you look at Texas, they have like 700 FTEs. If you look at Alaska, the person that is standing here doing this, he's the one surveyor they have in Alaska. The amount of FTEs to do the workload is very different for each state. And it depends on the number of homes in your state. I mean, Alaska has a lot fewer states. Texas has a lot more.
And then just when you bring that information back, the states that most represent or somewhat look like Kansas, can you put kind of out what's the difference? Like, is it pay? Is there something that they do? Benefits? Is there something that's outstanding that they're able to keep people in those FTE positions? Thank you. Thank you.
I will note, we don't have a lot of turnover. Once we find someone and we find good candidates, they stay. Turnover is not an issue for us. It's just getting someone to initially fill the position.
Senator Thompson.
Thank you. That's actually very good to hear. One quick question with the call to the hotline, say a family member has a concern about a facility or something like that. I'm assuming they give a family direction on how to document what they're seeing, or I don't know what kind of advice they're giving on the hotline to families who may have some concerns.
I wouldn't say that they're necessarily giving the families advice as much as receiving the concerns that they have and ensuring that those concerns are routed to the right party for investigation. If the family or whomever is making the call has additional information, say they have photos, they have a recording, things of that nature, they can submit it to our department. Unfortunately, a lot of those times, the items that they submit to us are stuff that would not be submissible in court, or they cannot show a chain of custody that would allow it to be submissible in court. And it's very hard for us to utilize those items to show a deficient practice was found.
Yeah, that's kind of interesting. It would be good to know that there was a source for families. Because I've had parents in nursing homes and generally had a pretty good experience. But, I've seen some things that concern me, and actually at the time didn't know who to report it to and how to report it and how to document that so that that facility, sometimes they they listen, sometimes they don't. They're understaffed in some cases, so that's a concern. Thank you.
And you can call into our hotline and remain anonymous if you wish. You don't have to identify yourself.
Committee, further questions? I have a couple. So on your IJ, your examples were very extreme. And I want to just say for the record, and I think everybody on this committee, we're not interested in jeopardizing people's lives, or we're not having this discussion. We don't want these nursing homes to be unsafe. So I just want to make clear, we all understand that. I know I'm speaking, but I do want to get to the bottom of this. So those are extreme examples. Are there other examples of IJ that are not as extreme that are still cited?
Those were actually some of the middle of the road examples.
So what would be a lower example then?
I think lower examples that you would see is if a facility upon revisit on a lower level deficiency, that's where you might see that lower level fine range. Luckily, in our state, we don't see that often because most of the time when we go out for our first revisit, our facilities are getting back in compliance. So it's rare that we're seeing CMPs issued for non-compliance at the revisit. So most of my real world experience to give you about it is when there is substandard quality of care, harm, or immediate jeopardy.
Very good, thank you for that. On slide 14, the third bullet point, the CMP may be imposed immediately or after a facility is given the opportunity to correct and revisit fines that the facility remains out of compliance. How much does that happen?
That's kind of what I was just discussing. So here in Kansas, we are rarely going out for a second or third revisit. Most of our facilities are able to correct their deficient practice and get back into compliance on that first revisit. So we're not seeing a civil monetary penalty issued in that range there.
Okay. Now on to 15, slide 15. So what's the percentage of that fines that come back to the state?
It depends on the mix of Medicare and Medicaid residents in the building. The more Medicaid, the higher amount we get.
Okay. Committee, if you'll remember last year, there was a bill around allowing for more flexibility. I believe that would be how you would put it, to use the CMP.
Those would be a different CMP that we're talking about there. That'd be a separate thing.
Okay.
But it would mimic this program at the state level.
But you have that program already available.
No. The only way, the Civil Monetary Reinvestment Program is only available for federally in, nursing facilities certified by Medicare and Medicaid. We do not have a Civil Monetary Reinvestment Program for assisted living, home plus, residential health care, those categories of adult care home.
Okay, so I was confused. So that is for the state licensed facilities, the bill was for?
It's 2316 and it can be around next year if you'd like to support it.
Well, as one of my chief objections, it doesn't make any sense to fine people to pay for, there was some, anyway. So committee, if you look on slide 15, you can kind of see kind of why my phone blew up, over this issue is, we went from 2022, 30, 34, 56, 47, and now we have 8, and what would that be? How far? 925. So we have 8 this year, IJs. What is different? We had 47 IJs last year. We have 8 this year.
The total number of IJs would be those first 2 columns added together, but you're still at a much lower number. I don't know that I know of any difference, honestly, as to why there is. I would have to probably refer to Dawn on that one, but I can't think of anything that is why the numbers would be, anything that stands out as to why they've changed, other than I think we are, again, we are catching up on surveys. We're in there more. I mean, we're still, in our world, we're still recovering from COVID. And I know that sounds terrible, but the nursing homes are still recovering from COVID. They're still recovering from losses during COVID. We're recovering from lost work time during COVID. But we're getting there, like, right? So we've been able to go full scale surveys, everything since 2023, but our hand was held for so long on not doing anything, we couldn't go in there. And as of this morning, we're not allowed to go our survey work is stopped again because of the federal shutdown. The only survey work that we will continue until that shutdown ceases is immediate jeopardy and non-immediate jeopardy high complaints. That's the only work that my team is now allowed to do.
Could it also be the fact that we're almost 20 months behind on surveying?
I wouldn't say so. And I only say that because 20 months behind is for our recertification surveys. Most of the time when immediate jeopardy is found, it is found on a complaint investigation.
Okay, very good. Committee, further questions? That kind of takes all my stuff off the list. No more questions? Lacey, thank you very much for that. That's been, I think, very helpful to see where we're at and what's going on. So, okay. Next, we will hear from Haley. Is she virtual? Okay. Haley, are you there?
Are you able to hear me?
We are now. Welcome to committee.
Thank you. I apologize about that, and I completely loathe virtual testimony. I think, as many of you know, I prefer to be there in person with you, but we're going to do the best we can considering circumstances of why I can't be there. I believe that Carter is going to be my phone a friend, assisting me with putting my presentation online. So I'm going to stop my video and allow that to come up. Okay, thank you. All right, so yes, my name's Haley Ordoin. I am here as a state long-term care ombudsman. And just a refresher for some of you that I've seen in other committees, what is an ombudsman? So we are an independent resident advocate. We investigate complaints concerning those health, safety, welfare, and rights of the long-term care residents, and we work to resolve them to the satisfaction of the resident. So it was previously asked, we don't know who to call. Oftentimes, the ombudsman's office is who is called for a complaint, for a concern, and we work together to collaboratively attempt to resolve any concerns or complaints to the satisfaction of the resident. So underneath this slide here kind of goes into a few more functions of our office, of how we identify and investigate. A lot of what we do is we provide information and assistance too. So we do a lot of referrals to different agencies, to different organizations. That abuse, neglect, and exploitation hotline that Lacey just talked about, we refer to that quite a bit. We connect people to the correct pathways very often for where their concerns are or to how to resolve their concerns. We try to work with providers of the long-term care services, so those administrators and operators, and even their team and their staff, to promote a culture of person-centered living, so that resident-directed living. We also make sure that the residents have access to us timely. So we go in annually, we attempt quarterly to provide routine access to those residents so that they have someone there advocating for them and connecting them and escalating issues if the resident so chooses to do so. All right, next slide, please. So this is just a summary of our last year reporting period. So you can see that is between October 1st of 23 and September 30th of 24. So we'll be getting ready and preparing our next one, since it has now ended, to prepare to you shortly after the beginning of legislative session. But this just kind of highlights a little bit of our program and what we have done. So keep in mind that this data is little antiquated based on the time that it was captured. But those blue boxes down there, the number of nursing facilities, how many licensed beds those are, those state licensed only homes, assisted living home pluses, and their licensed beds. So at that time, that was a total of 802 different homes and close to 34,000 total beds. Now, that doesn't necessarily mean that many individuals based on capacity and how full a home is, but it gives you an idea. In that time period, we made a little over 2,300 facility visits and assisted 67 different individuals subject to involuntary discharges and eviction actions. Keep that in mind when I speak about a few points here closer towards the end. But this just gives some anecdotal meat to the function of our program. Next slide, please. So we divide our complaint types when we receive these into our reporting system, and most of them go into these 4 categories: resident rights, resident care, facility environment and administration, and the non-facility. And I put descriptions on there so you can kind of see a little bit of what that includes. So a lot, close to half of what we receive is about the abuse, neglect, exploitation, in involuntary admissions, I would say, and involuntary discharges, dignity, feeling like a facility is retaliating against a resident, feeling like their visitation rights are being imposed upon, their choice is not being respected, or them wanting to coordinate to move back to the community and have their right followed of living in the environment of least restriction of their choosing. Down there, you can see, some of the resident care issues, restraints that can be pharmacological, non-pharmacological, different types there too, foods, activities, care not given or planned. So more directly into the actual care. Facility environment, sometimes we get those environmental concerns, supplies being needed, accessibility to power chairs, lift chairs, mobilized scooters, concerns with leadership, staff turnover, the fiscal management of their funds within a facility, and then some non-facility things. A lot of times Medicaid applications. Sometimes we've ran into discharges due to non-payment. Those would kind of go into some of these categories too. Next slide, please. And then who's making these complaints? I just think that this is always some valuable information. About a little over half of who we receive the actual complaints from is the resident themselves. A note, just kind of as a reminder, we do not go into independent living facilities because independent means that they are independent enough to advocate for themselves. But assisted living, home pluses, long-term care, those type of environments collaboratively create this. The second highest is then the resident's representative, their family, power of attorney, guardian, community member, friend. Sometimes we do have the facility staff in there in that kind of brown section. Others can be other referring agencies. So we do work together with Adult Protective Services. We do work with KDADS. We do work with KDHE. We work with the Attorney General's Office, Medicaid Fraud Inspection. We work together with all referring agencies to us and us to them also. And then we can also, the Ombudsman program, in my authority, I do have the right to file a complaint to the licensing agency on behalf of all residents due to the investigation that we have conducted. KDADS and I had spoke last, and I want to make one point of clarification in case it has been misconstrued. We do not confirm an allegation of abuse, neglect, and exploitation. We simply go in on the resident's concern. We do conduct an investigation, and then based on that investigation and the resident's wishes, we would then turn over our investigation findings to KDADS, and they would either confirm or deny or substantiate, I'm not sure the term, sorry, Lacey, substantiate or not the actual allegation. Next slide, please. And then this is complaint resolution. And I feel that this is important for you to understand, because you might see, okay, well, 58% is fully or partially resolved, 18% withdrawn, but then what about this not resolved? So the not resolved is very important for you to understand, because what that means is that not that the problem went away or that we weren't able to, really provide any help. It is that the resident was not satisfied with the outcome. If KDADS comes in and does not substantiate a complaint, that's technically considered not resolved, because it's not to the resolution of the resident's choice or liking. Also of importance, and this will come up when we talk about the surveyor vacancy, and I appreciate Leanne stacking this in the sequence that she did, because you have a lot of context based on everything that Lacey presented prior to. But if we have a resident that comes to us with a complaint, with a concern, and we, refer that per their request to KDADS, to the complaint hotline, let's just say, it might start as a small situation or a series of some small situations. And based off of that triage scale that KDADS uses at the complaint hotline, it may not be triaged as very high. And that resident, it then goes to their next annual recertification inspection and say, I think it was stated it's closer to 19 months right now. Well, I can't say what the exact time is of the average time that an individual is in a nursing home, but I know about 5 years ago, it was 2.5 years. It is possible, and we have seen, where a resident does pass before the complaint is investigated. And for us, when a resident passes, the case closes. If we do not have a resident that is an active resident of a nursing facility or an adult care home, that case closes. And it can be not resolved in that time. So that does apply in this, and I think that that is of something to be noted. Next slide, please. All right, so I have done this long enough to know that if I'm going to bring a problem to you, I also better bring a proposed solution. So I'm going to point out a few key things that we have discussed and our asks of legislature. So currently, federal regulations. So as Lacey stated, those federally licensed homes by CMS, those are mainly, your skilled nursing facilities, not your state licensed only buildings. Federal regulations require notice to be sent to our office for a facility initiated transfer. So those voluntary discharges. But that's not the case for those state licensed only homes. And I know that several of you are already aware of this and have seen, this isn't a new issue. This isn't a new request or ask that's being brought, but we would ask that language is amended to include our office in the notification from all adult care home types. And why do we ask this? Well, a lot of times we are able to work with the resident, to work with the facility to resolve issues, some of which, may be non-payment, or that the guardian conservator of such is not completing a Medicaid application. There's different referring ways that we can try to work together. And at the end of the day, it's really for the resident and their best interest of what they feel for them to not move and not to be relocated. So it really overall helps the resident the most in the benefit of this. And I understand that there's current regulation that Lacey mentioned also, that the state licensed only homes are reporting to KDADS. And here's where our concern comes in. KDADS, which we appreciate, has been very transparent about quarterly updates and sharing that information with the legislature, with us, also with provider associations, about the number that is, being reported to them. And one of the sections is about appeal rights and whether the individual would appeal the discharge. And we are experiencing inconsistencies in that information. So the providers are reporting to KDADS and say, for example, they say, no, this individual would not appeal it if they had the right. Well, then when they contact our office and we actually go through kind of the conversation of this and we talk about it, they're either not informed, don't understand, or told that they don't have the right to appeal. So they're like, well, we didn't think it was an option. Yeah, we would if we had the availability to do such. So there's inconsistencies of maybe what the data is capturing. And we just feel that our office would actually be able to help the resident much more if this was required. Next slide, please. All right, you've heard a lot already about increasing the KDAD surveyor staff. So I really won't spend too much time on this, but we hear it all the time from our residents that we forward to the abuse, neglect, and exploitation hotline. They expect someone to come out and to survey. And if it's put onto that next survey, I mean, we have months where we're constantly contacted. No one's been out. No one's been out. Can you come back out? Can you escalate this? Can you do anything for us? And, our state's already not hitting that marker of time frame. And it's really concerning to our residents and to our team also, that there has already been, from my understanding, the elimination of some of those positions. I understand the reasoning for it, but it now, can skew the data. And I know Scott's pointed that out before, that the vacancy rate isn't going to accurately, we didn't just magically go from a 50% vacancy rate down to, whatever the math ends up being, 28 or whatever, after the number is decreased. But our concern is, okay, we're already behind, and we're already behind in the annual survey. We're already down the number of individuals that we need. Cutting those positions, while we understand the purpose, we don't really see how that helps in the long run. How does that deliver, that higher care? That doesn't get us caught up. It's still a lengthy process. Like, there's short hanging fruit, there's higher hanging fruit. It's just concerning to us that we would eliminate positions, because once they're eliminated, they're not exactly the easiest to get back. I know you've talked a lot about other states, and it sounds like it's going to be a continuing, ongoing conversation. But I will say, I know that Lacey mentioned some other states. I know my colleagues in Idaho stated that they utilize those registered dietitians, and they've even expanded to the licensed nursing home administrators who, do understand the regulations and compliance to help conduct their surveys and help catch them up. Michigan has done the same thing. They've expanded and utilized those dietitians, those social workers, the sanitarians. They don't have state law, that requires it. But it seems like there's different ways, the state determining what constitutes that professional, and then CMS approving it. So there is framework out there, as was previously discussed, and we would highly encourage our state to look at not why can't this happen, but what needs to be done to make this happen, to expand that, to figure out the situation that seems to be occurring with exempt and non-exempt. It seems like, as Lacey showed too, there's far more pros than there are cons. And this would overall improve the care to those residents of adult care homes, which is precisely what we should all be here for. Next slide, please. Pharmacy providers, several of you were as frustrated as I was when I spoke of this a few months ago to different committees. The pharmacy provider choice and fees. So many nursing homes contract with those pharmacies to be able to timely provide the medication supply. And what we stated we are seeing is that they are charging those private pay residents with an medication administration and setup fee of on average 200 to 300. We have had a little bit lower, 100, 150 for getting their medications from other providers. And we feel, and our residents feel, that this really infringes upon their resident right of choice and financially penalizes them for exhibiting that. It is contradictory. It's penalizing someone from using their local pharmacy provider if the home has not contracted with that pharmacy to do so. So we would really ask for some sort of regulatory changes or law to ensure that. On the next page here, I wanted to provide you, I'm sorry, next slide, please. I wanted to provide you some context. So this is a sample letter from a provider, and I'm not, out here to blast that provider or anything. So I have eliminated their company name. But this is a sample that several residents had given to us. So showing on here that they're going to be incurring $150 monthly service charge. Now, it does state in there, and this has been pointed out, which I am not oblivious to, it asks for, that they encourage the use of the preferred pharmacy. And if you choose not to utilize the preferred pharmacy and or the preferred packaging, you will incur this monthly service charge. Well, the problem with that then is, yes, they're being given an option. You can use our pharmacy or not, but also the preferred packaging side, there's still a cost to that. So the resident would still have to pay an additional cost, even if they said, well, I'm not going to pay the $150 service fee over here to the home. They still have to pay to have it in the preferred packaging. So at the end of the day, there's still an additional cost and a hindrance to that resident to use their provider of choice. Next slide, please. All right. And then I think this is one of my last recommendations. We've talked before about personal needs allowance. Currently, for our state, residents of nursing homes that receive Medicaid benefits get a $62 per month, for lack of a better word, allowance. And this is for the residents to purchase common items, haircuts, undergarments, bras, socks. Hey, we're going shopping at Walmart, but if you have cable or internet provider, that money comes off of it. So, you might only have $15 for the month. Hope you've been able to save some things up. Our resident voices are very loud in this area that, not only does the initial personal needs allowance need an increase, but an ongoing adjustment. Other states have successfully tied this to the cost of living adjustment. And if you can progress to the next slide, I'm going to kind of provide you some context for that. Thank you. All right, so here is where we rank compared to other states. Our colleagues at Consumer Voice National Advocacy prepared this data for us that we very much appreciate. So it lists out each state and what their personal needs allowance is. You can see that several of them have the asterisk that notes a cost of living or COLA adjustment to that. So the national average right now, based on all of these calculations, is $72.89. So we're not even hitting the national average. The range is anywhere from $30 up to $200. I know that, makes a difference based on where you're located and your cost of living. But we rank 26th in the personal needs allowance, excuse me, in the personal needs allowance amount. So we would our ask would be, and I know that we have multiple other colleagues that are on board with this too, to increase the personal needs allowance to $72 with an annual cost of living adjustment attached to that. Next slide, please. All right, so here's a few ways you can contact us. My information is on there, and if you progress to the next slide, this is a map of our team across the state. So Lacey referenced that when they have a annual survey in their buildings, that we are invited to those. Sometimes notice wise, sometimes that works out for us to attend, sometimes it does not. But as I stated before too, with those complaints, if we have a resident that passes during that time, that case closes. So we're not able to then bring that to the surveyors for their annual review. But this is a breakdown of our team across the state. And I will say Sedgwick County, we have three team members in that region. Sedgwick County and Johnson County are our highest, most densely populated with all providers and all provider types. So they are probably some that keep us the highest busy, but we are available in the entire state. So I'm happy to stand here for questions and plan to stay on throughout the day based on all the context being discussed too.
Very good, Haley. Thank you for that. Committee questions? Representative Bueller.
Thank you, Mr. Chair, and thank you, Haley. Going back to your opportunities to resolve on the pharmacy provider choices and fees, is what you have listed as our ask, is that what you would consider to be best practice? I'm interested in this, a little bit of experience with my mother-in-law who's in the state of Missouri and the monkey business that goes on with medicines and all that good stuff. So what is best practice? Or is it just simply what you're asking?
Simply what I'm asking at this point, this is a continuous ongoing. I am actively researching with other states to see if they have any language that we may be able to mimic or replicate to not have to reinvent the wheel. But currently our state has none to my knowledge that we have found. Between state law, we've reached out to AG's office. There's nothing for us to currently go off of that we are aware of.
Can I ask, so I want to make sure I understand, who gets the money for these fees? They're charging the residents, does that come out of
the home?
Okay, and does that come from Medicare or Medicaid, or is it just what's charged to the resident?
So it's just what's charged to the resident. So depending upon that resident, they may have, their Social Security, they may have their annuities, they may have capers, okay. They may have VA benefits, whatever their sources of income, it is charged directly to that resident.
Okay. Thank you, Mr. Chair. Thank you, Haley.
Senator Thompson.
Thank you, Mr. Chair. Haley, thank you. And the pharmacy thing is a big deal. I dealt with that with my parents and in-laws. Quick question. How many, Haley, do you know, are on Medicaid in these nursing homes across the state that receive these personal needs allowances?
Ooh, I would have to get back to you on the precise number. What I can tell you is based on my experience, the case mix percentage is close to 80% of the population is Medicaid.
Okay. Thank you.
But I can get.
Yeah, it would be good to know. I mean, if we're considering, or if we're even looking at that, it would be good to know for fiscally what kind of an impact that would have on us. And I do think, Mr. Chair, that the reporting requirement seems like a no-brainer. Just expanding the reporting requirements so people's families will know if they're going to be discharged and why. So, thanks, Mr. Chair.
Very good. Representative Reese.
Hi, Haley. With that discharge, It's an involuntary discharge?
Yes, so we currently have, the federal requirements is that all discharge notifications are to go to us for the homes. So, and this is where there seems to always be a lot of confusion, because it's different requirements for different levels, for different types. So all discharges are to be reported to us, but the involuntary or there's been language changes, involuntary, facility initiated discharges are the ones that they normally give, the 30 days. There's state language, there's statutes that describes what constitutes that. Are they a harm to themselves or to others? Is it due to non-payment? Is it due to an increase of services and needs to a different provider type? Those sort of things. So those are the ones that are normally a 30-day notice required. That is what the adult care homes that are federally licensed are required to send to our office. And the others, like say they have gone to a hospital or they discharged themselves against medical advice, those are normally on a monthly basis that we receive, but that's only from the Medicare and Medicaid licensed federal homes, not your assisted living, not your home plus types. And that's what we're asking. We're asking for it to be universal for all provider types.
So right now for, let's say there's a person living in a facility and they are in the hospital, let's say in a psychiatric behavioral health unit, and the nursing home is saying that they are not going to accept them back. Who's responsible for making that reporting?
So if they are in a nursing facility, that would go to us. That they have the involuntary discharge notice. And here's the problem that we run into with that. Well, they are supposed to give us and give the resident's power of attorney, what have you, resident representative, the 30-day notice. Sometimes we see that does not always occur and they refuse to accept that individual back and take the CMP fine, the penalty that is assessed to them in time through KDAD. So oftentimes we'll refer that to KDADs to go out and to investigate for that resident. But, by the time that can occur, sometimes we work very much with the Kansas Hospital Association also, because we do face a lot of problems where the resident is, we're not going to take them back. We can't take them back. We refuse to do so. And then the resident is kind of in a lingo. We have several cases I could tell you right now that we run into that, where the hospitals then have almost like a holding wing, that it's taking up occupied beds and staff that really should be there for other purposes.
Thank you.
Committee, further questions? Representative Orpeza.
Thank you, Chair Carpenter. So thank you for your presentation. And expanding on Representative Reese's question, if we were to take up or recommend this amended language, how many increase in FTEs would that create or be needed for the ombudsman?
I'm currently going to say no. I reserve the right in the future. I've already submitted my budgetary request for this next fiscal year, and that has not included an increase. I don't anticipate at this time that would include any sort of impact of full-time staff to our office.
Okay, thank you.
Committee, further questions? So just to back up here, just on Representative Orpeza, so if you expanded to 525 more state-run facilities, you would not require any more staff?
It would not require more staff in our office because we already have the reporting system and we're already receiving notices from these buildings. It would, at this time, we don't anticipate that it would cause an increase of our staff for this next fiscal year. We do not anticipate that, no.
Wow. Okay, committee, further questions? Seeing none. Haley, I just have one question, and I'm going to ask this of Lacey at some point in time. So what would you view the overall quality of our nursing facility industry in Kansas as? What would you give it? Do we do a scale of 1 to 10, ABC? Just, what do you think?
Well, you're putting me in a placement. But I have some prior oversight of understanding that. I'm honestly, I'm gonna go middle of the road. I'm gonna put us right there in like that 5-6 range, and here's why. I am not ever going to come before you, as I've said before, and demonize the long-term care industry, because it is vital that we have those services. It is vital that we have those people there to care for loved ones of individuals who cannot provide that care. You are going to have a mix of both, and you are going to have, and we have seen, very often our office is not contacted because things are going great. It's contacted for concerns and complaints. And we do see the homes that do get it right. We have acknowledged to some homes, yes, you are really implementing person-centered care. Yes, you're following resident rights. We agree. And also, do we have the homes that put profit above the person? Absolutely. And it's a mix of both. And I'm going to say it's a pretty even balance of the two.
Thank you for that. Didn't mean to put you on the spot or anything, but I think the committee needs to understand that we're not, everything's not a deficiency. Committee, further questions? Haley, thank you so much for being here.
Thanks, guys.
Okay, next we will have Kylie, are you up first? Kylie Childs and then Linda Mowbray. So Kylie, welcome to committee.
All right, thank you. Kylie Childs, Director of Government Affairs with Leading Age Kansas. And we actually put together a joint presentation, so I'm going to let Linda introduce herself and take the first few slides, and then I'll pop back in here.
Chairman, committee members, I am Linda Mowbray with Kansas Healthcare Association, Kansas Center for Assisted Living. Very pleased to be here today with all of you. Talking about survey challenges for the adult care home providers. And, I think you've heard that there's challenges on the survey side. There's challenges on our side, staffing-wise. These surveys are unannounced. Back when I was actually working in skilled nursing, and I think some people still do it today, we used to have a code word that when they'd drive up, we'd say, "There's sunflowers in the parking lot." These were not announced surveys. They came in, you needed to be ready, and you needed to make sure that you had your ducks in a row. The purpose, are you going to do that for me? Awesome. The purpose of this and why this discussion matters. Kansas is getting older. We have many people that need care, and we need good care options across the state. Surveys are important because they do judge the quality and the conformity, if you will, to the regulations. The impact of the survey, if it's not done correctly, or if it appears to be punitive, or if providers fear retaliation, the impact is on quality, it's on workforce, it's on compliance, sustainability, reimbursement, reputation, and it's really hard to go to work every day in a facility that has had a bad survey. whether they were at fault, out of compliance, or whether it was a human error that was made, because we are humans dealing with other human beings, and that does happen. Being in compliance with survey, I think it was probably pretty eye-opening to see the training that the surveyors have to go through to be able to do their job. Our facilities have to go through that too. And every single staff member needs to be aware of what's wrong and what's right and what's required, and the amount of training that that takes, and the amount of time that that takes, and the different levels of education that we have as our employees across the facilities. It's not easy. And, you know, the survey book that we have is about 4.5, 5 inches thick. And it's just the basics. It's not above and beyond. So if we go on to the next slide, historically, we used to have a lot of deficiency-free homes, nursing homes that when the surveyors came in, they may have a few recommendations, they may have a few areas that they want clarity on, but we had a good number of deficiency-free homes. And that has sorely declined, as your chart will show you. Additionally, since the pandemic, and even before a little bit, homes are closing. As KDAD said, there are 10 counties without a skilled nursing facility option. And unfortunately, many of them are out in the western part or the northern tier parts of the state. Kansas is a big state, and some of those counties out there are territorially huge. So when a home closes down, you may have to drive 45 minutes, hour and a half to get to the next nursing home. Now that's hard on me as the daughter, but what about the spouse? What about the resident that had to leave their community where they've lived for all this time? It's vital that we keep our nursing homes open, and it's vital that we continue to put the resources out there, which does include regular, fair surveys. We put in a slide here to show that declining in nursing homes are not unique to Kansas. There has been a drop in capacity. And as the drop in capacity happens, then the population is still getting older. Where are these people going to go to get care? So going back to surveys and survey trends, the tags and the volumes, if you would, next slide, please. There's been an increased number of tags, greater use of immediate jeopardy, and Kansas has always been a bit of an outlier. Region 7 for CMS, the Centers for Medicare and Medicaid, has often been an outlier. That's Kansas, Nebraska, Missouri, and Iowa. But Kansas has always had a very high level of deficiencies. And I would challenge that we're no worse, and perhaps not better, but we're no worse than any other state. We just seem to be judged a little bit differently. And I think that chart explains to you Kansas compared to the national average. Now, as a lifelong Kansan, I don't like those numbers. We're better than that. The total number of IJs, the immediate jeopardies, yes, there has been a decrease. And I hope it's because we've been in discussions with KDADs. I hope it's because we have been putting, realistic plans into place. But I would guess it has more to do with the federal government and CMS and their involvement with surveys. I don't know that anything has changed so terribly much, but the outcome on the surveys certainly seems to be. I think one of the things that I want to clear up a little bit, though, is when we talked about, when KDADs talked about the surveys and reporting out what their findings were. So day 1, this happens, day 2, this happens, day 3, we're giving you, a heads up on what deficiencies might be written, but we don't tell you the scope and severity. Okay, that's fair, since since KDADs does not have the ultimate decision in that. But one of the tenets had always been, if you have an immediate jeopardy situation, if you have a situation where somebody's life is in jeopardy, surveyors aren't supposed to leave the building till it's fixed. So how then do you issue that IJ 10 days later when the statement of deficiency comes in? If it was that dangerous and a person's life was at stake, how did you leave the building in good conscience? Because right now we have registered nurses as our surveyors. How did you leave if it was that bad? I think one of the things that I would like to kind of explain, if I can, the scope and severity chart that KDAD's talked about. This is a nice graphic representation. And Chairman, if you'll allow, I'd like to pass this around and then get a copy to everyone after we take a break. Sir?
That'd be fine.
So the scope and severity is just exactly what it sounds like. It's a graphic representation, a grid, if you will, of A, B, C, E, F, G, so on. And it tells you how severe the deficiency is. Did it happen once? Did it happen a few times? Or is it a widespread problem? And the more severe the incident is, and the more widespread it is when you get into the Gs and the IJs and the fines and the penalties and whatnot. That's the way the system is set up. We have an awfully high number of IJs and Gs. I want you to take note, if you will, on the chart that's on your screen, the trend line, the purple one, for Iowa. Our neighbor in Region 7. There's trend lines for Missouri, Nebraska, and nationally. And I think you'll see nationally that the trend for more deficiencies or higher scope is going up a little bit. The dips that we have there, quite frankly, that was during COVID, and the surveyors weren't out there. We do need to have surveys. We do need to have accountability. So what is Iowa doing that's working, that's getting surveys back on track, that's getting surveys done, and that's lowering the scope and severity of what they're finding? Well, we have Iowa people here this afternoon that are going to tell you what they did and why it's working and what it is that we as a state can do to help with that. And I know you all like solutions, and I think probably the lowest hanging fruit is working with Department of Administration and changing that exemption, or, I wouldn't say let's put all professionals in the exempt category, because quite frankly, a job where I know I have to work 50, 60 hours a week and be on the road and away from my family several nights, that's not a real attractive job. If I'm going to do that, I want to get paid for it. So if we can talk with Department of Administration and change some of those pay scales, I think some of this will take care of itself. We are fully in support of having dietitians, LPNs, social workers, sanitation officers. That's the way the universal multidisciplinary team used to be. And we as nursing homes must have a multidisciplinary team to meet the needs of the resident. It's important to have different people with different areas of experience and expertise. And I believe that that's something that with your help, we would be able to accomplish and get surveys back on track and get our homes feeling comfortable with knowing that they can count on their survey 9 to 15 months and not be sitting there in month 19, going on 20, going, when are they going to get here? Thank you. I'm going to turn things back over to Kylie for the moment.
Hang on just a second. Do we have any questions of Linda's presentation? One thing I would like to see is you've got the other state trends. I would like to see Kansas is on that also.
To overlay it on the graph?
Right.
Yeah, I think we can do that.
I think that would give us you've compared us with Iowa, Missouri, and Nebraska in the national, but it would be nice to see Kansas on there also.
Can do that.
As a comparison. So if you could get that to us after lunch, that would be perfect. So Representative Orpeza.
Thank you, Mr. Chair. Thank you for your presentation. In your last comment, you said that there are nursing homes that are waiting. Why is that such a big issue? If they're always prepared and they're doing what they need to do for the residents, why does it matter when they come in to survey?
Thank you for the question, Mr. Chair. It does matter because there is the historical look back. If the surveyor hasn't been in the building for 19 months and they haven't been out on a complaint visit, they are looking at so much data, so many closed charts, and even though they have their sample that they look at, that's a long time to be judged. It's far better if they're out 9 months, 12 months, and then that time period is approved and certified, and then you go on. But if you're waiting 19 months, they're going to go back and look at things that the same staff might not have even been there, and yet you're going to be held accountable for it, and you're going to possibly get deficiencies over things that you had no control out of.
Committee, further questions? Seeing none, thank you. Kylie, welcome to committee.
Thank you, Chairman. Again, Kylie Childs, Director of Government Affairs with Leading Age Kansas. And is this on? Okay. All right, so I'm going to pick up, I believe it's on slide 7, with conflicting regulations and lack of guidance. So one of the biggest frustrations that you will hear from adult care home providers, whether that's nursing homes or state licensed only with assisted living and board and care homes or Home Plus, is that they're often caught between conflicting regulations, whether that is our health survey guidance and regulations or our life safety code, which is Fireside. And sometimes we get conflicting guidance from those two different agencies, and so you might have have a provider who is told from the life safety code survey side of the fire marshal's office, hey, do not, you cannot have doors that are not delayed egress. If you're going to not use delayed egress doors, you need to post your door codes above your magnetic key lock provisions. We have individuals with dementia and all other cognitive impairments that on any given day, they still may have enough cognitive awareness to read the door code that is posted and still be able to exit through the door. So they put the door code up to come into compliance with the variance that the fire marshal's office is requesting, and then they end up with an elopement on the health survey side. We have the health survey come in and say, okay, now you have a citation for an elopement. You need to take that door code down. That's your easiest way. So oftentimes we have providers that are just caught, which citation are you going to take? Are you going to take it on the health side, or are you going to take it on the life safety code survey side? Because the regulations are not talking to each other, and oftentimes we do not have a clear structure of who has the final authority and say. Those things get ran up the chain, but then we still have to answer to our state fire marshal or still answer to the secretary for Kansas Department of Aging and Disability Services, who breaks that tie. So oftentimes we still don't get a clear answer for providers, and that's one of the biggest things that they walk away with frustrations on. Part of the issue, too, is that we do not have anything in statute that grants waiver authority for the Kansas Department for Aging and Disability Services Secretary. So right now, if we wanted to be able to seek a waiver on the amount of RN hours that we have, per CMS regulations and things along those lines, we are able to request a waiver and put in a plan in place of how we're going to work towards addressing those staffing issues. But right now in statute, we do not have anything that says the KDAD secretary can grant that. So we go on a case-by-case basis, but there's nothing formally outlined of what that process looks like. So we try and help and work with KDADs and help our providers of like, here's what the steps in the process we're going to ask you to do, but we'd like to see something that's a little more official, put into statute, and something we can refer to for our providers moving forward. And then part of the issue just within the health survey agency is the differences in interpretation in the way providers are cited on scope and severity. So we've heard from numerous providers over the year that they will receive an immediate jeopardy tag even when no harm has occurred on an incident that another provider in another region received a G tag on, same incident, but because of the surveyor's interpretation of likelihood for harm or likelihood for serious harm, that's what one surveyor deems as immediate jeopardy, and another says, this is an isolated incident with this one resident. Systems were still in place. This is a G tag. So that's some of the frustrations providers have when they're being cited at different levels. And we understand that comes with surveyors and subjectivity and how each person interprets things. But we'd like to see some more consistency across there too for expectations of how to handle certain situations and when your processes are being followed. Another example of a conflict for our state license only side would be the HCBS final settings rule. That now is adding a new nuanced layer for our Medicaid residents that sometimes can come in conflict with our health regulations on our state license only side. So providers are wanting to be able to provide Medicaid services in our state license only settings, but when it's coming up and we have two things that are again butting against each other, they're going to try and make the decision that they can so they don't compromise the service for all of their community. And so when there's no consistent timely guidance from the state survey agency to help them with navigating these conflicts, it's creating unnecessary risk, cost, and stress for providers who are trying to follow the rules, and they'll just try and figure out which path they need to go down, which could inevitably pull some people out from providing Medicaid services at that state licensed only piece. In terms of workforce shortages and federal pressure, the survey agency itself, as you heard, is operating around a 50% or more staff vacancy rate. And Kansas is still requiring all surveyors to be RNs or licensed practical nurses as well, rather than allowing a more balanced multidisciplinary approach like other states. And one thing we would point out is, like Linda referred to, there's more things that are being surveyed than just those clinical aspects of care with residents. We're looking at their dietary, social services, all of these different administrative things that go into it. So we feel having people with those expertise and backgrounds in those areas can help with knowing what are the temperature guidelines that we need to be following with how hot a food needs to be. And they're well-versed and more familiar with those specific regulations and their background there. Providers are told that workforce shortages in their facilities are not an excuse for noncompliance, but when the state survey agency doesn't meet their responsibilities because they're also short-staffed, it seems to be accepted as a valid excuse. And so that double standard creates tension between providers and the state survey agency, who our providers are often fined for staffing shortages, while we have not heard anything being done to our state survey agency for the consequence of their own shortages as well. The irony in all of this for all of us seems to be this process isn't working for anybody, whether it's providers, the residents we're serving, the ombudsman's office, the state survey agency. Everybody is struggling with getting people we need to make sure the process is working. So we want to try and identify the ways that we can make the process work a little better. It's not that we want to get out of surveys. We want to find the way to be collaborative and make sure we're doing the best possible thing for the residents being served in the state of Kansas. Another thing that providers are often told is if KDAD surveyors are not finding any tags, it'll trigger a federal survey with CMS, which will more than likely inevitably result in a tag and place both the provider and the state in a position for a corrective action plan. So it's just better if providers take the tag when the state comes in the first time rather than not getting getting a zero deficiency survey. As you can see, we've had a decline in the zero deficiency surveys. We would disagree with this philosophy just based on what we're seeing in other states. Iowa, you'll hear from Leading Age Iowa later this afternoon, has a number of providers that are making it out with zero deficiency surveys every month. And they're even still in the same CMS region as us, CMS Region 7. So with everything, as we know in government, there's push and pull between states and federal. And we just feel it's time for our state to start pushing back a little bit with CMS of this is how this practically works for Kansas, and making sure that we're making those nuances and approaches that we need for our environment. In terms of IDRs, you heard a little bit about that. So that is an informal dispute resolution process. And right now, Kansas has one of the lowest participation rates of IDRs in the country. And why is because the process does not feel independent. Almost all of the tags through an IDR process are upheld in the state of Kansas. The Kansas IDR, which is where a provider can dispute a deficiency or a scope of severity if it rises to the level of an immediate jeopardy threshold, are upheld at nearly a 90% rate from 2022 through Q2 of 2025. And the IIDR, which is the independent, that is focusing more on the CMP that is issued by CMS, and they can dispute the amount that has been in there and what is relevant for the scope and severity if they have not already gone through an IDR process or they've completed the IDR separately. That has only been requested twice in our state since in that same time frame, and it was upheld 100% of the time. So providers do not have a lot of trust in the process being objective and looking at, was this cited correctly? On top of that, there is a financial disincentive to even file an IDR for providers. If a provider accepts the citation, they get a discount on their civil monetary penalty. If they appeal and lose, they pay more. So with the percentages we have that are being upheld, even if somebody feels like this was cited incorrectly, are you going to take the gamble and fight it and then risk losing and paying more on your CMP? Or are you just going to accept the tag and move forward with the discount on your CMP? So with that, surveyor shortages also delay reviewing plans of corrections and different things along those lines. As Lacey mentioned, different pieces in the survey process, that's what counts towards stopping the clock on your CMP. So from the time that you come out of compliance until your plan of correction is reviewed and the revisit is completed, you're collecting that CMP over that time, and that goes into the calculation for CMS to then issue your letter of how much you're going to be paying. So when we have surveyor shortages, it makes it difficult for them to get back out on revisits and make things timely along those lines as well. Additionally, I will make one note. There was a rule that was passed, I believe, last year on the CMS level that per day and per instance CMPs can now be overlapped. So previously, if you were cited as a facility, you received either a per day fine or a per instance fine. You were not allowed to have them overlapped. Now CMS can overlap those. So you can be hit with both. Again, more financial disruption for providers. Sustaining operations becomes more difficult. We haven't seen what the full impact of that will be yet because that just began this year with them starting to issue those, and it takes a while for the data to get entered into the QCore website for us to see that. And then I think Linda had one quick piece. She wanted to talk about the CMP reinvestment fund and its utilization, if I can let her real quick.
Mr. Chair, Linda Mowbray. The CMP, civil money penalties, there's a reinvestment fund, and I think Lacey explained to you that the money goes to the feds, but a portion of it does come back to the state. What has happened in the past is that grants have been set up, facility level grants, so that training can be done for things like specialized dementia training, whether it's dementia capable care or the music program that they had where there was headphones and different types of music playing for folks with dementia and how that works and incorporates. Some of the grants could be on workforce, and they were all designed to improve quality. Some of them could even be on infrastructure, such as HVAC systems, to improve the air quality. One of the things that has happened in Kansas not too terribly many years ago, we had a large company that went into receivership. And the state of Kansas, the secretary, had to take over those homes to keep them running. And part of the fee that paid those receiverships came from the CMP fund. I don't know how many dollars are actually in the CMP fund today. I don't know how much the agency is holding back so that they have a cushion for future receiverships. I do know that there are opportunities that should be available to our homes. But do keep in mind the facilities that are paying those fines are generally not the ones that receive the grants to do the additional training. So while it's not KDAD's decision, we are taking from the folks that are having the most trouble and giving it to the ones that seem to be doing okay. And I don't see that there's anything right or just for our residents about that. Last thing I'll say is that as of Monday, CMS issued a memo that is reformulating the federal side of the CMP grant monies. And it's going to increase the amount that can come to states or to individual grants by about 20%. It's a 7-pronged program, and we look forward, if and when they open back up again, working with them and getting that program launched on November 10th. Thank you.
So really the heart of this slide is not that we are trying to avoid accountability or anything along those lines. We're looking for a fair process that if a provider does have a concern, we can go through an IDR process and feel like there is something independent that is truly overlooking that and not just being upheld by the state agency who issued it in the first place. In terms of state agency noncompliance, you've heard a little bit about this already. The state does have state performance standards that CMS outlines for them as well as the state survey agency. And on the most recent fiscal year 24 findings, there's 2 main things that the state survey agency is not meeting. And most of those is going to be due to staffing. It's going to be your requirement for recertifications being completed within that 12 to 15.9 month timeframe. As you heard, we're averaging closer to that 19.9 months. The other piece is the off-hour surveys. And so there's a certain percentage of surveys they need to start outside of that Monday through Friday 8 to 5 window. Again, we're asking surveyors to come in on a Sunday and start on a weekend. We're asking them to start after 6 p.m. So that makes it difficult for them to find staffing as well. Some of these standards that are set up by CMS just make the system difficult for our state to carry out, especially when we already have a nursing shortage and a difficulty with being able to staff across all of the different sectors that we have in Kansas as it is. So some of the common threads and issues you might have heard from Linda and I today is when you're putting all of this together, we feel that providers have been overpenalized without consistent support. We do not have a technical assistance arm within the Kansas Department for Aging and Disability Services. That is something that is allowed by CMS regulations. It has to be separate from your survey unit, but it is something that we could potentially explore to help with providing more of that guidance that providers are, when they're seeking, okay, what am I supposed to do? How am I supposed to handle this situation? Surveyors are not allowed to answer technical assistance questions, but this branch would be able to help with solving some of those questions. Standards are often conflicting, unclear, or inconsistently applied, and the state survey agency does not have the resources needed to meet its own obligations for completing surveys as well. So the end result is a system where providers feel trapped in an unfair cycle. Residents are at risk of losing access to care if providers cannot sustain these operations under these conditions and under the weight of fines and unclear rules. Some potential solutions, because we hate coming to committee and not having, only complaining, we'd like to bring some potential solutions as well. There are several steps we feel Kansas can start looking in that direction to take, despite the nursing home process being federally overseen. So we could increase survey agency staffing and allow multidisciplinary survey teams and not just RNs or LPNs to serve on those teams. So again, as you've heard multiple times, taking a look at that exempt versus non-exempt piece or what other things we need to do to make that possible. Creating a truly independent IDR process so providers have confidence that disputes will be fairly reviewed and taken into consideration. And you'll hear from a vendor later this afternoon that talks about what that process looks like. Several other states already do have that process in place, whether that is just for their IDRs or their IIDRs or both of them. And then establishing waiver and clarifying variance authority and statute for our KDAT secretary and our fire marshal to give providers clear workable options when standards are conflicting. We want to be able to run that up to the chain and get a final answer of here's how we're going to bridge these two regulations and make sure it works for the situation that we are providing care in. Some other solutions would be looking at a dedicated technical assistance branch at KDADS to provide clear, timely compliance guidance and stronger collaboration with KDADS and CMS. Again, that push and pull, making sure that we are advocating for the right and quality care that we have in Kansas, but also advocating for Kansas and what works for us. Sometimes what we apply on a federal level, it doesn't go across as a blanket statement and work in every state the same way. And we want to be able to see that we can push back on CMS where things just are not the right approach for Kansas. So these changes would bring a fair balance, fairness, and accountability to the system and something providers, residents, and taxpayers deserve. And we would be happy to answer any questions that any of you may have.
Very good. Thank you for that. Committee questions. Representative Bueller.
Thank you. And so Kylie, when I look at the potential solutions, are these in your priority order? So if we were, because one of the questions I was going to ask you or Linda was, okay, what can we do in 2026? So I'm hearing an awful lot about the exempt versus non-exempt, which would seem to be your first bullet point. And after sitting on this committee last several years, the independent IDR process review seems to be, but can we interpret that these are 1, 2, 3, 4, et cetera?
I didn't write them that way, but they would be falling very similarly that way. I would say also establishing that waiver or variance authority, because that's where we find more of our conflicts, and providers are, again, just forced to take a citation on one or the other, or sometimes both. So when we have those issues, what is the process that we can work out there? And being able to clarify that in our statutes, I think, would be helpful.
Okay. So if there is, legislative improvement enhancements, changes, whatever the right terminology is for 2026. We can work with you and Linda to, okay, all right. Thank you, Mr. Chair. Thank you.
Any further questions? Representative Oropesa.
Thank you, Mr. Chair. On the paperwork that was passed out, it's from 2006. Is there anything in the last closer than 19 years?
And you're talking on the survey
Yes.
guidance? Yeah, so that's the same grid that they operate off of with
Okay.
issuing those tags. So the A, B, C, D, all the way up through immediate jeopardy level, same guidance that they're
Okay,
operating.
thank you.
Any further questions? So just very quickly, so how is the IDF set up now?
The IDR process?
Yeah,
So
IDR,
independent.
sorry.
Yep, IDR process is set up in statute, and then we have regulations that outline that. Again, that is for any time a state survey agency comes in, issues a citation, the statement of deficiencies, or the 2567, is given to the provider within 10 days of leaving that survey. Provider has then another 10 days to request the IDR. Once it's requested, it's typically supposed to be scheduled within 30 days.
I might not have been very, so who are the members is what I'm more getting at.
So there is one person from the survey department who is not supposed to have been in direct involvement with the survey. And then there are two other individuals who could either be a provider, consumer, or somebody else at KDADS, just not out, they have to be outside of the survey agency. So sometimes we run into where we have 3 KDADS members.
How many members are the total then?
3
3,
that sit on the panel.
okay. And so there's no clear, so it could be 3 KDADS people, but there may not be a provider or
Right. It depends
anybody
on,
else. It might just be 3 KDADS people that are making this decision.
correct. And it depends on scheduling. Again, timeline 30 days, so depending on how quick KDADS is able to get that scheduled, who's available. If providers are not able to come or consumers not able to come, sometimes they'll reach out internally with KDADS, and we see that quite often.
So maybe this afternoon we'll hear about maybe some other states have larger committees to make
Yes,
this
and
decision.
some of them contracted out through a vendor, and so that way it's not necessarily a part of the state survey agency. They have more contacts that they're able to pull in for those things.
Very good. Committee, further questions? Representative
Yeah,
Mueller.
I just want to make sure I heard, and maybe this is for Linda, that if we, or one of you had stated that if there is a survey with 0 deficiencies, you're going to get hit by CMS, that happens?
That's something that's often told to us, that if we get 0 deficiency survey, it'll trigger, and CMS will see that. Sometimes the theory is CMS will then follow up quickly with a federal survey, and most of the time when federal comes out, they will find something.
Okay.
So then both provider and state are on a corrective action plan.
Okay. Okay, thank you. Thank you, Mr. Chair.
Representative Reeves.
Yeah, that's stuck out to me too. I would like to hear Lacey's opinion about that. If that's okay, Mr. Chair.
Our staff has never made that comment, to my knowledge. I know Dawn or I have ever said it, so I'm not sure if it's being heard from other states, but that's not something that we have ever said. That being said, I am happy to look at other states. I do have the ability to look and see what facilities had deficiency-free surveys, and I can look and see if it's called a look-back survey is what CMS would then do. They would exercise their right to come. And what would happen is say there is a deficiency-free survey, our staff would issue the statement of deficiencies. We wouldn't change our process. We don't even notify CMS that it was deficiency-free. We only notify CMS when there's no opportunity to correct. We would notify the facility. We'd give them, they still get that piece of paper. They still get a statement of deficiencies that says that you were deficiency-free. We don't need a plan of correction. That's where it stops for my staff. There's no enforcement, there's no correction, there's no nothing. The federal government has the ability to say, we want to come back and we're going to do a survey, the same exact long-term care survey process that the state of Kansas staff did. And state of Kansas, don't go do your revisit until after we have done this. Once we've done it, we're going to tell you what we found, what your staff should have found, or what your staff did find, and they accurately found it, or they should not, and they need to delete that deficiency. So then not only at the end of that survey is the facility getting a statement of deficiencies from the federal government, we as the state of Kansas are getting kind of a report card for the staff that did that survey.
And so that begs, how many times are more deficiencies found by the feds versus what the state found?
I don't want to give you wrong numbers for this year, but I could tell you last year, my staff scored 100%, and we found everything that the federal government should or found. I don't believe we're that high this year. I think we're sitting more around 90%.
Very good. Thank you for that. And while we have you here, or maybe this afternoon, so in that receivership fund, how much money's in there? You can find out.
I know.
You know now, okay.
Yeah, so right now we're sitting at a little, I think, over $10 million. Of that, $5 million is reserved for emergency funds for things like Linda and Kylie had talked about for the Skylines, if there's an emergency receivership, if there's a temporary management. It is important to note, though, that when we use it in that emergency fashion, we must pay it back. So all of the funds that KDADS and Secretary Howard used when we took receivers in, that was paid back in full to the fund as required.
But it does seem that that money could be used for training and helping these nursing homes with staff and stuff like that too, doesn't it?
Absolutely, yes. I can get you a full list of the current programs that we have in place that have been approved by CMS and are receiving monies. We have, I want to say somewhere in the ballpark of 75 homes that are participating in some form or fashion. That being said, that program is shut down today until further notice.
But would more homes qualify for that? I mean, it seems.
Every home qualifies. It doesn't, the qualification for a home to request money is not indicative of how well they do on a survey. Any home can request money at any time.
I see. Well, for the committee's benefit, I really appreciated that over the period of time. At one point in time in the social services budget, we had 20 plus nursing homes that were in receivership, and they were operated out of that fund over a period of time until they sold. So I did appreciate not having to cough up money during the budget process to operate these homes. But I'm not sure it benefits us to have a large amount of money that could be used for training or some programs and stuff like that just sitting there. And there is some, consternation about using the fines for receivership and stuff like that too. So anyway, committee, further questions? Oh, you have something?
I was just going to say, if I could, there's currently a national nursing home staffing campaign that CMS prior to today was spearheading that would allow states to get money and use those not get money, but use the money that's in their civil monetary reinvestment program to help with staffing, to help with our nurse aid training program, our website, to open the doorway to get healthcare staff in. There is a national effort and campaign that we're working with our partners at CMS as we speak.
Very good. Thank you for that. And then are you working on a permanent waiver of the feds? I think I've lost track of it, and I'm not sure it was in there last year, but for a couple of years, I put in social services budget, we put a proviso in there that would allow the nursing facilities to apply for waivers when it came to the 24-hour nursing, if you remember that.
So what we were requesting every year was to have the waiver authority to match the waiver authority that CMS was putting out there. So CMS had put out some parameters to request a waiver for the 24-hour registered nurse requirement. And as Kylie had mentioned, we do not have statutory authority to make waivers. So we were trying to mimic the waiver capabilities that CMS was bringing out so that we could, as a state, do it. Because every state that's certified by CMS is also licensed by my team as a state licensed facility here in Kansas too. So they're required to meet those requirements as well for their state license.
But what I found to be ironic was that our own state statutes were tougher than the federal government.
They're the exact same. They're the exact same.
They are now.
No, the requirement for 24-hour nursing is the exact same at the federal level and the state level.
So they can acquire a waiver for 24-hour nursing staff.
As it sits right now, because we have the authority in the budget proviso and CMS still has that authority. We have not had a facility exercise their ability to waive that though.
Yeah, I was real disappointed in that. They came to me a lot about that. And then I think there was 2 people the first year that.
No one's actually ever done it. They've
No one's
applied or they've started the process, but no one has ever actually actively had an RN waiver in Kansas.
I'll be darned. I heard that there was 2, but it came about during COVID when they were having incredible staffing programs. We had testimony before the Social Services Budget Committee that one guy paid like $9,000 over Christmas weekend because he was required to have 24-hour nurses and nobody wanted to do it. And I think they paid some gal like $1,000 an hour to do it, you know, which was pretty good money. So anyway, well, committee, any other questions of any of our other conferees? Is this for Lacey or is this, okay.
I have one quick question, Mr. Chair. Thank you. The average age of your surveyors, what is the average age?
I would have to get back to you.
Okay.
I'll have to give my HR. I don't know. I'll have to give the HR and get their
Okay.
ages and get back to you.
And the reason I ask this is because I know there's longevity there. However, we are in a different time post-pandemic, and people are looking for different things in nursing professions. So that's why I wanted to know kind of what the average age was. Thank you.
Very good. Thank you. Thank you, Kylie. Thank you, Linda. We're going to get on down the road. Committee, I might remind you that we are looking for these recommendations, and we will do them today. So we've got a lot of thoughts out there and stuff like that, so write them down. At least I have to write them down because I'll never remember again, but whatever, bring them up. Thank you very much for being here. Okay, next we're going to move on to Ricky Turley, WebEx. Ricky, are you there?
Yes, good morning.
Good morning, and thank you for your time.
Yes. Thank you for the opportunity to speak. My name is Ricky Turley, and I am the Director of Health Services for Lakeview Village in Lenexa, Kansas. I wanted to say that my goal here today isn't necessarily to shed light on whether a deficient practice did or did not occur, but it is more to highlight the inconsistent survey scope and severity determinations, specifically across state lines, even though we are all operating underneath the same federal regulations. So my examples that I was going to give today are kind of my direct experiences over the last couple of years. But I do know that I have heard from many other peers that I work with in other communities that have shared similar experiences on other regulations as well. So a little bit about us. We are a 5-star not-for-profit community. We operate at a very high standard. You know, we tend to be the facility that will self-report any mistake or any issue that occurs on our campus, taking a very proactive approach to where we self-report it to the state. We draw the spotlight onto it. That way we can look at every actual incident, near misses that occur, and we're looking at it from that understanding of failures are going to occur, whether that's a system failure, whether that's an equipment failure, or whether it's a people failure where somebody did not do exactly what they're supposed to do. And we try to operate that's part of our job, to investigate those to the fullest, make corrections, look at our practices, and what do we need to do to make adjustments to ensure whatever did occur does not happen again. So on this note, at Lakeview, we've had 2 different incidents over the past couple of years that fall under the same exact FTAG. It's FTAG 689, which is free of accidents, hazards, supervision, or devices. So I wanted to highlight those 2 levels to kind of showcase how they were done. So incident 1 was December 2023. we had a resident that does have a level of confusion that exited through a door that had malfunctioned. The door was locked down, but the Roam Alert system, which is supposed to alert nursing staff that that particular resident is at that door, the control board failed. It didn't send any sort of alert to the staff, but the equipment itself failed. The resident got outside the door, went down the stairs, and a staff member that recognized that resident notified or went to that resident, assisted the resident back to the floor, got him back into the building very safely in a matter of minutes. So no harm occurred. We self-reported that incident just like we always would, saying, hey, this was a system failure. We looked into it. The door had been tested a week prior to by the actual company that installs it. Our maintenance team had actually just tested the door from a system standpoint 2 days prior to the incident occurred. And at that time, everything was operating the way it should operate, but electronics fail. And when we had the company come out, they did say it was a bad control board that just failed and it wouldn't have alerted us to any way. So that was cited. I think the surveyors came out after we self-reported it. And they did list that and cite that as an immediate jeopardy situation. Another incident that occurred was April 2025. This was another confused resident on that same floor that all the systems functioned absolutely the way they should. The stairwell or the door alarm went off. It alerted the staff. The staff responded to the door alarm. They, within 58 seconds of that door alarm going off, were seen on camera running up and down the stairs, hallway to hallway, looking for the resident, trying to identify where they were at safely. They were found by our staff on the campus still and were safely returned to the floor. Again, we self-reported it because we look at those and take those incidents seriously. That was probably one of the few times I can say throughout my career that I looked at and I was like, wow, everybody did exactly what they're supposed to do. They did what we teach them to do. Our equipment worked properly, and within 58 seconds, we had initiated a widespread search. That is best case scenario because we don't have one-on-one care for these residents. Again, the state came out and we were issued a immediate jeopardy tag on that one as well. So when you look at those two tags, I look at it as we operated at the highest standard that we should. We investigated the incidents immediately. We took proactive measures to ensure safety once we discovered there was a problem, and we self-reported it ourselves. And we got issued an immediate jeopardy tags despite us doing really everything within our power in those incidents to make sure systems were working the way they should. In contrast, there was a situation in Missouri a couple of years ago that it was the same exact F-tag number. The difference between this situation was it involved a resident that was missing for 3 hours. The resident was found by the police and returned to the community. And that one was cited only at a G-level tag. So the problem is not just that these individual incidents, it's about the inconsistent application of federal standards depending on which side of the state line you're on. We very much believe in self-reporting and proper follow-up, that accountability should be also collaboration. Incidents will occur, whether that's that staffing mistake, equipment failure, but it should be what actions do we take once we've identified, and do we take those good faith efforts to do everything right and look at things to make sure we're trying to proactively prevent it from happening again. In those two cases that I am referring to, I feel like we did everything from a training standpoint and from a system testing standpoint to ensure proper functioning. The moment we identified there was an issue, we put a staff member one-on-one at those particular doors or that incident to ensure that safety was there until we were able to fix the situation. And then you self-report it. And when the state comes out to investigate it, sometimes 2 weeks later, it's still then issued as an immediate jeopardy tag. And that's where I'm having a hard time feeling like it's consistent and it's a collaboration. A facility trying to do the right thing and operate at the highest standard shouldn't be held to a higher standard. It should be consistent across the board. In my opinion, Kansas providers are being held to a much higher bar, even when the systems function and staff respond rapidly. Residents are returned safely, even though the resident was returned safely. Missouri providers are facing a far riskier situation with the example I gave, and were cited at a lower level. For federal regulations to be fair and effective, they must be applied consistently across all states. Without that consistency, providers lose confidence, staff morale suffers, and it becomes harder and harder to attract and retain quality teams. I just respectfully ask that we review how the scope and severity determinations are applied for greater consistency across state lines in the survey practice. Thank you.
Very good. Will you stand for a few questions if there are?
Absolutely.
Committee questions? Senator Thompson.
Thank you, and thanks for the testimony. I appreciate it very much. And I know you guys have had some experience with your facility. You do a good job there. So the immediate jeopardy was assessed, even though you cleared it up in a matter of minutes. I'm assuming you were fined for that?
Yes, so we do get a federal fine from it, and then we live with that survey result on our record for years, to where it looks like that we failed to do the right thing. And again, I'm not going to argue that incidents occur, but incidents are going to occur in every single community out there. I feel like you shouldn't be punished to a higher standard for taking the proper action and self-reporting it, doing that all independently.
Did you file an appeal on these?
I did on the second one. I did not on the first one. Being very transparent, I have not ever heard good things about the appeal process, and that there is a bit of fear on how you're going to be then perceived at your next survey. So I did not the first time. The second time, I was so proud of our team here for doing the right thing that yes, I chose to appeal it.
And did you find the process fair, or do you think there were some issues with that?
I will speak to mine. It was primarily KDAD's employees on there. There was one outside facility on there. And truthfully, I kind of felt like it was a waste of time to do the appeal. No positive outcome in my benefit came out of that whatsoever. It was just a matter of expressing my case just like I just did here. And then they read their statement of deficiencies, and then it came back as a deficient practice.
Okay. Thanks, Rick. I appreciate it. Thanks, Mr. Chair.
Committee, further questions? Okay, Ricky, thank you very much for being here. No other questions here.
Thank you.
Okay, next we'll move on to Cheyenne. Are you here? Oh, you are. Okay, very good. I didn't know if it was way back. Welcome to committee, Cheyenne.
And thank you, members of the committee. I know your lunch is coming, so I won't talk for very long. My name is Cheyenne Strunk, and I'm with Grace Team, a management company who works with 13 nursing homes across the state of Kansas. I've also worked in long-term care for 14 years, and I have served in every corner of the state, including growing up in a county in western Kansas that doesn't have a nursing home. So unfortunately, what you've heard today, this is not new challenges. They're not recent challenges. It's a long-standing issue that has created reputation harm, financial strain, emotional turmoil that's contributed directly to the workforce challenges that we've continued to face in aging services and the burnout that we have also been facing. So I would like today just to talk to you some key challenges that we have seen from our perspective. And you've heard some of them, so I won't try to reiterate too much. But the number one is the inconsistency and the over-enforcement of surveys. Again, you've heard this morning, but Kansas providers are cited more frequently and at a higher severity level than the national average. The data shows this is less about quality of care and more about the interpretation of the likelihood for harm. An example of this that I can give personally and that I've heard is elopements, which ironically, you just heard from Ricky. And you can have an example of a resident leaving a building and nothing happened to you, all the way to a resident leaving a building and you will get an immediate jeopardy fine, and either way, the resident was not harmed. Either way, in my experience, it's usually just like Ricky said, a door maybe malfunctioned or a door the resident went out of. Either way, resident came back, resident wasn't harmed. My last elopement immediate jeopardy tag was $100,000 for context of what it costs when it comes to penalties. The focus should be evaluating on nursing home processes rather than just focusing on one bad outcome. Again, what Ricky just said rings true. When everything works like it's supposed to and your staff respond exactly like they're supposed to, that's the kind of things that we want to be held accountable to. You have good processes in place prior to the incident. You have a good quality process where you self-identify, fix issues, and we believe that that should be taken into account when determining the scope and severity of a tag. My family and I actually volunteer at a local nursing home, and this past week we were met with tearful employees telling me how sad and frustrated and burned out they were dealing with an IJ citation. And the part that made them the saddest is the amount of time and energy it takes away from giving residents the time and attention they deserve. So for context on what some of this looks like, as a provider, as an administrator, if I have an allegation of, for example, abuse, neglect, or exploitation, and it happens and we're made aware of it Friday at 3 p.m. How many of your staff are ready to call it quits by Friday at 3 p.m.? Same goes with our industry. But what happens is we have to start our investigation immediately if we want to keep from the fines, if we want to make sure everybody's safe, if we want to make sure our processes are in place. So you're asking your staff on a Friday at 3 p.m. who are thinking they're leaving and going home for the weekend in a few hours, they're there all night. Because in order to be in compliance and in order to keep your fines and your penalties as little as possible, you have a window of time that you want to make as short as possible so the fines don't incur day after day after day. So I'm asking my staff at 3 p.m. to get 100 employees in the building as fast as possible to educate them, train them, and make sure they fully understand where our process failed so we can immediately fix it for the safety of our residents, and then we move forward. All while self-reporting to the state, all while doing our internal investigation process. But the point of that is to keep the fines at minimum if we think there's going to be an issue. We want to show we're in compliance as soon as possible. The second thing is self-reporting being penalized. Again, Ricky just said it. So federal rules require self-reporting, yet KDADS treats these incidents the exact same as if their surveyors discovered the issue. This discourages transparency, as responsible providers face the same punishment as those who conceal them. So responsible providers, Ricky, my teams that I've been working for, they're saying, hey, we messed up. We did it, we messed up. And there could be people down the road that say, we're not gonna say anything and hope it's just not found. And that exists. Excessive and strict enforcement of immediate jeopardy tags, even though self-reported, they continue to damage facility viability, creating long-lasting consequences. I just talked to a director of nursing this week who told me that because of these IJs that I've explained to you, where there has not been harm to the resident, she is having census issues, having people move in because these surveys are public knowledge. And it looks like her building is doing a terrible job or poor job taking care of people. But what she doesn't get the opportunity to say is, yeah, there was an immediate jeopardy given for an elopement for a person that walked outside. We brought them back in. They were not harmed. They were safe. But I can't explain that. These families are looking online and deciding where they want to go. And there's really good people doing really good work, reporting correctly, following regulations, who are being held to a 2-year consequence of this will follow your building for years before it falls off. An example again of investigations that I've dealt with is related to medication errors. We're in a human service industry. Mistakes will happen, but there's been multiple examples of medication errors not being cited, all the way to them being cited to an immediate jeopardy level. Again, my experience that I recently had, it's been a few years now, but we had a medication error. The medical doctor came in, told the surveyor, from my experience, there was no harm to the resident. Her medical doctor said that. The medical doctor said, this resident was not harmed with this. Surveyor cited it as an IJ. That tag was $99,000. Immediate jeopardy fines, which you heard, they're tons of money, upwards to $4,000, $8,000, $9,000, $10,000, $11,000 a day, threaten the viability of small and rural facilities while staff morale and public trust suffer under these highly public survey results, like I said. Grace team is consulted daily about the management of struggling communities in Kansas, and it's common for struggling communities to have financial issues, and there's a direct correlation with the fines and penalties related to survey outcomes. You also heard about the IDR process, which is another key challenge that I just want to mention really quickly. The process is the process is to challenge the validity of a deficiency cited, and it's often overseen entirely by the KDAD staff, which is leaving providers like us without independent or neutral representation. I can also tell you from experience, and it's been a few years, I have been a provider on that board, and it is a process that definitely needs, in my opinion, an overhaul. It needs addressed to make it a more fair and neutral opportunity for providers. And you also heard from Ricky, and I will attest to that as well. Most facilities say it's not worth your time. It's not a fair process when you can send in your money, get a reduction on your fines, pay less, and then you just move on with your day. It's time to, the tag is what it is, pay your money, you move on, and you keep taking care of your residents. And the last thing I want to mention is accountability gap for licensed staff. Facilities are cited even when they follow all policies, procedures, and processes in case of abuse or neglect by licensed staff. Licensing boards frequently delay or fail to act, allowing individuals to move unchecked to other nursing homes. An example of this is if an employee is terminated for substantiated abuse by the nursing home. So the example is I investigated and I determined this staff member did not act appropriately. I'm going to terminate them because of their treatment to a person. They can go down the street and work tomorrow at the nursing home. There is no process that says, hey, there's a red flag on this person's license. The same thing happens to diversions of narcotics with licensed nurses. They can steal all of my medicine and I terminate them and they can go get a job down the road tomorrow or next week and start working again. We're not asking to avoid accountability. We're asking for consistency, fairness, and transparency in how surveys and enforcements are carried out. Many providers are fearful to give testimony such as this today for fear of retaliation during their own survey process. I think if that didn't exist, there would probably be 40 of us up here today. I'm up here on behalf of the many staff in the state of Kansas who pour their hearts out every single day for the residents of Kansas nursing homes who just want consistency in the survey process and want KDADs to see that even though we may have had a bad outcome, that shouldn't take away from the work being done, the processes being in place. I was supposed to be joined today by another Grace team member, and she was unable to make it due to an IJ citation, which further proves my testimony today. We want self-reporting to be recognized as a responsible act, second to what Ricky just said, not punished as if it was concealment. And above all, providers just want support, partnership, and consistency as we work tirelessly under difficult conditions to serve Kansas seniors delivering quality care. Difficult conditions that have yet to see a full rebound from the ramifications of COVID. Our hope is that we continue to create an environment where our residents feel safe and our staff want to continue the work in the long-term care industry. I'm not going to lie, after 14 years in this industry, it's hard. The work is hard. The regulations are hard. Staffing struggles are hard, as I'm sure you've heard through testimony in the past few years. And our goal is to keep good, hardworking Kansans in the industry. Inconsistencies with the survey and excessive strict enforcement drives good people away from the industry and ultimately gives us few caring people who are here to care for the elders of Kansas. So I just respectfully ask this committee to thoughtfully consider all proposals that you've heard today to streamline the survey process and incorporate greater collaboration for the betterment of the seniors in Kansas. Thank you.
Very good. Thank you for that, Cheyenne. Committee questions? Senator Thompson.
Yeah, I'm right next to you. That's okay.
I thought he was pointing to something.
No, that's okay. Thank you. I have to imagine that you have to build the cost of these IJs into the escalating cost of providing services. So it contributes to that. Do you have, I don't think, is there insurance that covers this sort of thing, or?
You grin and bear it and write the check.
So you just have
Yeah.
to eat the cost.
You do, yeah. And there's things you go without, right? Because the money has to come from somewhere and you're managing a budget. And if you have a $90,000 fine, then that comes from somewhere else.
That's huge.
And it may be, you don't take away from resident care. Obviously, that's your priority. But there may be priorities. There may be improvements to the nursing home. There may be things that you've been saving money for that don't happen because of this.
So if I heard you right, it's better to take the risk not to self-report and to just take the risk than to actually self-report and get fined for something that you actually did right.
So you said it, but I will tell you that I have always worked with integrity, and I've always worked in the integrity of the regulations and the license that I carry. And me and my teams have always reported. And there have been many times that there are tears, because the facility said, we did everything right, but this staff member made a mistake. And I said, I know, but we still do what's right, and that's reporting to the agency. And you heard it this morning, you will get an immediate jeopardy tag for something that happened 30 days ago. But it's an immediate jeopardy tag 30 days ago. They trusted me to continue to care for that person for 34 days. And then they cited me at an immediate jeopardy tag. Yeah.
Thank you, Cheyenne.
So on record, I have never done that. But
Yeah,
do I
no,
believe do I believe there's providers that do? Absolutely.
Well,
Because
yeah.
if you go 19 months without a survey, maybe that's a risk we're taking.
Well, it's a perverse incentive.
Mm-hmm.
It really is, and it shouldn't be. I agree 100%. Thank you.
Yeah.
Thank you, Mr. Chair.
Senator Murphy.
Thank you, Chair. Part of what Senator Thompson was talking about a little bit as far as the incentive to not report. Comment more than a question. My background is in aviation. So I was an airline pilot. If I deviated from regulations, I could self-report, and I got immunity for that, as long as nobody got hurt. And I guess that's what I'm looking at. It's really frustrating to have to self-report and get penalized as if you just got caught red-handed. And I just think that's a real problem.
Yeah, and to your point, like I said, I've done this for 14 years, and I've probably had G or high-level tags probably 10 times in 14 years, and they've 100% been self-reported.
Yep. Thank you.
Representative Bueller.
Thank you, Mr. Chair, and thank you, Cheyenne. I think this is the third year now I've heard a version of this same approach, and it's getting to the point where my blood pressure's up about 2 or 3 points every time I hear it. So, and this may not be so much for you, but maybe for Lacey and the others in the audience. If we are going to have a collaborative industry that, whether it's including of the providers, the residents, the long-term care ombudsman, and KDADs, we've got to get past this. And I would like to know maybe what the reaction is from KDADs who are in the audience, either anecdotally or at some point in the day if we have it. But it just seems downright fair when my first comparison is, in this sense, these punitive measures feels a little bit like the IRS going after good tax-paying citizens. That is maddening. So if this is the approach that the surveyors are using, we're never going to fix an industry that's already struggling. And for each one of them that closes, this kind of stuff just makes the industry worse. So I would like a reaction from, or at least a response, maybe reaction is the wrong one, a response from KDADs in terms of the testimony that we just heard. And I'm sure you might be willing to either have a conversation with them or they have your testimony. But this is wrong. This should not be happening, especially when you hear the comparisons to other states. We ought to be better than this as a state. I mean, this is just freaking wrong. So apologize for getting off the rails there, but it does make my blood pressure go up 2 or 3 points. Thank you, Mr. Chair.
Well, we will have KDADs back before us to answer some of these questions. Representative Reeves.
Yeah, Chair, I'm not sure who to ask this question to, but I need a tutorial on who determines the fines, the level of the fines, how many days these fines are for. What's the process to, is this CMS or is this So it's federal? Really?
It comes out of the Kansas City office. And I think Lacey was the one that mentioned it. Not only do you get a humongous fine, but then she said you may wait a year to get it. So you wait for the piece of paper, because I think last time I was on, I just started calling them weekly because I wanted to pay it and just move on from it. And it took months and months and months to get it, because you have to get the form, you have to get the paperwork, so then you can ask for the reduction in your fine amount. If you're not choosing to fight it, then you can pay it and move on. But it does come from the CMS office in Kansas City.
But the fine is triggered by what KDAS reports to them, by the surveyors.
Yes.
So the gatekeeper would be the surveyors as far as CMS levying a fine.
Yeah, because that's where the
Okay.
information comes from. Yeah, their findings when they're in the building doing the investigation.
Thanks, I'm going to get that clarified.
Sure.
Representative Pickard.
Thank you, Mr. Chair. Thank you, Cheyenne, for being here and, you know, in spite of possible retaliations. I mean, it's so refreshing to hear really good nursing homes being represented, you know, like doing the right thing no matter what. So keep up the good work. And it's not only in KDADS. There's a lot of agencies in the state where we're finding unfair penalties and that kind of thing. So, yeah, we need to fix it.
Thank you.
Thank you.
Representative Reeves.
Thank you, Mr. Chair. So we know that the surveys are done unannounced.
Yeah.
Right? So should the surveyors avoid doing a survey on a Friday?
They don't work on Fridays. So my example so they don't work on Fridays. So everybody takes a deep breath, right? Because they're not going to come in on a Friday. So that part is good. One of you asked, I think it was you, Representative, you said, "What if you're ready all the time, why does it matter if they're unannounced," right? And when I ran my building most recently, when I knew I was in the window, I needed all of them there. So your little summer vacation, you better get it over with before that window opens up, because I need all hands on deck to get through a survey, because they may come in and ask for something that is 16 months ago that people are digging for hours. They may look at something that only this person has in their office. So that's one reason why you want everybody there, because you don't know what they're going to ask. You don't know when they're going to come, which is fine. Everybody's used to that process. But as you're inching towards the 19-month mark, people know I may not be able to take off today, or if I'm taking off, I may be called back in because they showed up. So back to what you said, my example of just because I did the investigation and just because I got everybody educated and trained and we fixed the broken process or the broken system to make sure residents were safe, we report it that day to KDADS, but you don't know when they're going to come. So if they think it's a concerning enough event that they come out and survey you based on the example I gave, they may come next week, they may come next month, they may not come at all. They may come during the annual survey and say, "Hey, we're here to do your annual survey, but you have 3 complaints attached." And one of those complaints that they're also investigating may be the one from my example I just gave you about a Friday night. Does that make sense?
No, I was just confused because the example you gave, it sounded like the survey was done Friday, you got cited, and so everybody had to stay.
Right.
And not go home.
So once you understand, as a provider, once you understand the process enough, you know what steps need to be taken and what you need to have in place. So when the surveyor does come and investigate the situation, you can say, "We started on Friday night and we corrected the issue immediately."
Okay, thanks.
Representative Bryce.
Thank you, Mr. Chair. Thank you, Cheyenne. Appreciate you being here very much. I think I have to piggyback onto Representative Bueller's comments that the whole process seems very punitive and penalizing people that are responsible and trying to do the right thing, and that's very, very frustrating. I think earlier in your presentation, you said a line, I don't know if I wrote it down right, but you said something about we need to change and focus on nursing home processes rather than just not individual incidents. And I think we do need a paradigm shift. I don't see how this is going to change unless there is a paradigm shift away from what we're doing. Can you give some details or explanations how we would change the paradigm from looking at individual incidents and more toward the processes in the nursing homes?
Yeah.
If I got that right. Thank you.
Yeah, so I'll answer it and tell me if I'm on the right page. So when we have an example of a situation that had been cited at an immediate jeopardy level, when the incident happened, we started the investigation. We identified the problem. We started training all the staff. We fixed the issue. The resident was not harmed. We notified all the appropriate people. And we can look at the entire system and say, yeah, here, this little part is where we made a mistake, or this is where the staff member messed up, right? We do all of that. And then what we do is we write what we call a past noncompliance. And it's essentially saying, we messed up, here's how we fixed it. These are all the processes we put in place. But when a surveyor comes in, they will not consider a past noncompliance or a plan as good enough to not get in immediate jeopardy. They'll say, and I've experienced this, you did everything right after it happened, but it still happened. And I say, you're right, but when the elopement happened, nobody was hurt. The resident went outside for 58 seconds, like Ricky said, and they're back in. Staff brought them back in. They were assessed. They were fine. You're right, but it was still an elopement.
So if I could, Mr. Chair, are you saying that the sort of the gotcha, somebody eloped, nobody was harmed, but they gotcha on this incident, there's not taken into account the fact that you have processes in place and everything, perhaps like the gentleman on, excuse me, on WebEx, excuse me, he said, everything was done right, nobody was hurt, everybody did exactly the right thing, they got the IJ tag. So when this happens, there's no consideration by the surveyors that the processes are pristine or good or right. It's just gotcha.
Correct.
On something that could be just, something that just falls out of the blue. Is that what we're talking
Exactly
about?
right. That's what we're saying. And that's what he said, and then that's what I reiterated. Yes.
Okay, thank you.
Any further questions? Representative Reese.
So and I'm sorry, I didn't ask this of anybody else, but you're there, so I'll ask you, and you're so good about answering questions. So when there's a citation, do the families of the residents, are they informed of that, and how do they respond?
Yeah, so an example for me would be when a resident elopes, we'd notify the family, right? Where we say, hey, so-and-so, Mr. whatever, he walked outside or he followed a family member out the door, and the family member turned around, saw him. They were in the parking lot. They were not that far they were right by the front door, brought back in, and he's fine. We double-checked all of our processes. We made sure all of our things were in place, and families are pretty understanding. And oftentimes, in my experience with it, they're so grateful. They're like, well, thank you for taking care of him. Thank you for making sure he's okay. And after that, rarely are they then continued into the survey process or outcome. Maybe if it's a pretty involved family, and they'll be like, hey, I saw the surveyor was here. Was that about my dad? And we'll say, yeah. And they'll say what happened, and we have to tell them.
Have a follow-up question to that.
Sure.
So I seem to recall in some of these slides that if there is a review done, that there's a resident or consumer that could be a part of that team?
Yeah, so what she was referring to was the annual survey process. So not necessarily the complaints, but when they come in for the 3 to 4 to 5 day survey, at the very end, there's an exit survey, and you can invite anybody. They're really good about that. At the end, they'll say, hey, we're done. We've done all we can do. They don't give you scope and severity information, which is okay. That part's fine. We all sit around a table. Residents can be in there. All my staff that want to be in there, and they can hear some of the citations, or sometimes they even tell you concerns, like.
Yeah, I'm just wondering about how involved the residents are. And I know this is all very complicated, but I'm just wondering how involved the residents are and the families about just the process. You know, I would want to, I mean, we're not going to have anyone, a family member or a consumer here, a resident here
Yeah.
to give us their opinion about surveys and everything. I was just curious as to what kind of concerns or opinions that we would get from them.
Yeah, surveyors have resident council meetings where they invite all the residents together, and we aren't in the room, and they ask a lot of questions, and we tell our residents, be honest with them. And surveyors also call family members during the week of an annual survey. They'll call and say, we're here, we're doing our survey for the year or whatever. We have some questions about your mom. And they'll ask questions. Are you notified? Or do you come and visit? If you do, how does mom look when you get here? So I think they do a good job with that. And I as a provider, and I would say most providers have no concerns with that part of the survey process.
Committee, further questions? Thank you very much for being here.
Thank you.
Committee, we will adjourn. We will still be back at 1:30, so eat fast. and staff. So we're going to go ahead and. Is that me or is that somebody else?
It might be, some.
Okay, okay, good, good. Okay, we're going to start at 1:30, the presentation for independent and informal dispute resolution. So first up, we have Charlene. Charlene, are you there?
We are here,
Yeah.
Mr. Chairman. Bailey is going to go first. Bailey Brockmeyer.
Oh, okay.
Okay.
All right,
Thank you.
Bailey, are you there?
You're on mute, Bailey.
Bailey, if you control M, yes.
Okay, I'm so sorry. Can you hear me?
Yes, we can. Well,
All right.
Bailey.
All right. Good afternoon. Thank you so much for this opportunity to speak with you all today. While it was our preference to appear before you all in person, due to scheduling restraints, we are participating virtually. We do appreciate this opportunity to engage with you all in a remote format. It is an honor to be here and to contribute to the important decisions that shape Kansas's policies and impact on the communities. My name is Bailey Brockmeyer, and I serve as the current IDR and IIDR Managing Director at Improve Health. I have worked in the long-term care field for about 16 years, where I started my career providing direct care to residents. I am a certified investigator for nursing homes. I'm SMQT surveyor, state surveyor certified, and also a certified life safety specialist for healthcare facility managers. I have 11 years of experience with IDR and IIDR reviews, and I've been with Improve Health now for about 8 years. Alongside me today are two of my colleagues who will also be presenting. And so I will now turn it over to Charlene Kalchek-Belitsky to introduce herself, followed by Charlene Bea.
Yes, hello. Thank you for having us here, and thank you, Mr. Chairman, for getting us started. My name is Charlene Kalchek-Belitsky. I am an IIDR consultant for Improve Health, and I am the former managing director for IDR and IIDR here at Improve Health. I've been with the company over 15 years. I'm a registered nurse and also a licensed nursing home administrator. And I have over 30 years experience as a nurse. And my background is mainly in nursing homes, as director of nursing, and then as a administrator, and then as a chief operating officer overseeing operations of skilled nursing facilities, assisted and independent living. So we're happy to be here today. So I will let my colleague Charlene Bea introduce herself.
Thank you, Charlene. Good afternoon, Mr. Chair and committee members. My name is Charlene Bea. I am both a registered nurse and an attorney, and I currently serve as a corporate compliance officer and arbitration coordinator for Improve Health. I've proudly been with the organization for over a decade. My professional background spans long-term care as a practicing RN, including consulting roles. I too am SMQT qualified and previously served as a long-term care surveyor in the state of Michigan. Additionally, I've worked as an IIDR and IDR reviewer under the leadership of Charlene Belitsky, and that's given me a deep understanding of the regulatory and procedural nuances involved in the dispute resolution processes for nursing facilities. I appreciate the opportunity to speak with you today and contribute to the discussion surrounding IDR and IIDR processes. Back to you, Bailey.
Thank you so much. And to clear up any confusion, we do have two Charlenes on here, two wonderful Charlenes. And so just to differentiate the two, Charlene Kalchek-Belitsky we'll simply call Charlene, and Charlene Bea I may refer to as Charlie. I do just wanted to see if you all have a PowerPoint presentation up in front of you all that we have prepared.
I think it's on our S drive, if not.
Okay, I can try and
I was going to,
share.
Bailey, I can share my screen if you'd like me to.
Okay, yeah, that would be wonderful. That
Yep,
would be
okay.
great. Thank you. Thank
I
you.
will share my screen. I'll look over to my other screen so I'm paying attention, but you might see my head swivel. Presentation mode.
Our tech is getting your slides up right now.
Great. Well, so that we don't waste any time, I'm going to go, I'll just kind of.
Oh,
move
it disallows
forward here.
sharing.
I think they're up now.
Okay, thank you so much.
Okay, wonderful. So here, I'm going to be on slide 2 talking now about our session objectives for today. In today's session, we're going to walk through the core components of the informal dispute resolution and the independent informal dispute resolution. We will refer to these as IDR and IIDR. These are processes that offer a structured way for providers to dispute federal survey findings. We will clarify what each process is, who it's relevant for, and then break down the steps involved in both the IDR and IIDR processes. We will also compare the two, talk about CMS regulatory requirements, and give a picture on how Kansas currently handles IDRs and IIDRs, including the final decision authority and the possible outcomes of the process. Finally, we'll look at what's required of an independent IDR vendor and under CMS rules, and discuss the options that Kansas has moving forward and how these processes are managed. And next slide, please. And we will start first with IDR. Next slide. The informal dispute resolution, it's a voluntary process. It gives nursing homes a single informal opportunity to dispute survey findings after they receive the surveyor's report. This is also called the Statement of Deficiencies. It is also known as the 2567. It is important to note that this process is informal, meaning it is non-legal. It doesn't involve court proceedings or formal administrative hearings. The purpose of IDR is to allow providers to present evidence or clarify facts that they believe were misunderstood or misrepresented during the survey. This process can help resolve disputes early before any enforcement actions like civil monetary penalties, or denial of payments are finalized. While the process is informal, it does play a critical role in maintaining fairness and accuracy and how regulatory findings are documented and enforced. Next slide, please. So the facilities, there is, while the IDR process offers facilities a meaningful way to dispute certain findings, it does have clear limits set by CMS and the State Operations Manual, Chapter 7. And if you don't mind moving to the next slide, please, that would be great. Facilities may not use the IDR process as outlined in Chapter 7 to challenge the scope and severity ratings of a deficiency unless it was cited at the level of immediate jeopardy or substandard quality of care. The facilities cannot challenge remedies imposed, such as the civil monetary penalties or other enforcement actions during IDR. Only the underlying deficiency cited can be challenged. The survey process itself cannot be challenged during IDR. This includes how the survey was conducted, the number of surveyors or subjective opinions, and the facility may not use the IDR process to challenge the inadequacy or inaccuracy of the IDR process. So the key takeaway here is IDR is focused strictly on the accuracy of the deficiency citation and not on the consequences or the process surrounding it. And next slide, please. So we do mention a lot about the limits of reviewing the severity and scope. So I wanted to kind of highlight the basics of CMS severity and scope grid. This is a tool used by surveyors to categorize the seriousness of deficiencies identified during surveys. It combines two key dimensions. The severity you see there in pink, it classifies how much actual harm has occurred or the potential for harm to residents. And then it's also classified by scope, which reflects how widespread the issue is, whether it affects a few residents, a pattern, or is systemic across the facility. Severity is broken into 4 levels. You can see there, 1 is the lowest severity. There's no actual harm, but potential. Level 2 is no actual harm, but there's potential for more than minimal harm. Level 3 is actual harm, and level 4 is it's immediate jeopardy. There's a serious adverse outcome that occurred or was likely. Scope is rated in 3 different categories. We have isolated, where it affects 1 or very minimal residents. A pattern is more than just a few residents or repeated issues or repeated instances. Widespread is kind of a systemic issue or facility-wide issue. So when combined in a grid, these levels determine the severity of the citation that you see there in purple and blue. And this directly affects whether enforcement actions like civil monetary penalties or denial of payment may apply. And this grid also determines whether a provider is allowed to use IDR to challenge the scope and severity. Again, only the deficiencies cited at the higher levels, immediate jeopardy and substandard quality of care, these are the ones in purple, can be challenged on the scope and severity. All deficient practices can be disputed, but the severity and scope level can only be challenged in IDR for those purple severity and scope levels. All right, and next slide, please. All right, again, so the goal of the informal dispute resolution is to determine whether the citation was appropriately issued based on facts and regulatory guidance. So the reviewer starts by examining those federal regulations and CMS guidelines related to the cited deficiency. This ensures the citation is being evaluated within the correct regulatory framework. Next, the reviewer closely examines survey findings as documented in that statement of deficiencies. This includes looking at a description of the alleged issue, evidence presented by the survey team, and the specific regulations cited. This includes the surveyor's investigative findings. This report, the statement of deficiencies, and this stands on its own. It must be clearly written to ensure effective communication, all in accordance with CMS, providing that they provide the principles of documentation guidance. This shows they have to include relevant record review, interviews, everything for a sufficient investigation by the surveyor. And then the facility has the opportunity to submit supporting documentation such as medical records, policies, staff statements, or other relevant information. These materials are reviewed to assess whether they clarify, contradict, or explain the surveyor's findings. And then after evaluating both sides, the reviewer makes a recommendation to uphold the citation as written, delete it entirely if it lacks support, or reduce or amend it, such as adjusting that scope and severity rating or clarifying the language. This recommendation is then forwarded to the state agency who has the final decision-making authority. So overall, the IDR process is designed to ensure that deficiencies are accurate, fair, and supported by evidence while giving providers an informal avenue to seek correction before enforcement actions are imposed. Oh, next slide, please. So what is each state's IDR process? CMS does set the minimum standards in the SOM Chapter 7. States are given a fair amount of flexibility in how the process is carried out. And as long as it's fair, timely, and meets the minimum federal requirements. While all states are required to provide some form of IDR process, the way it's carried out can vary significantly from one state to another. Some states use a panel of experts, sometimes 3 to 7 person committee who collectively reviews evidence, makes a recommendation. This might include recommendations or representatives from the state survey agency, a provider trade association, working with another state to help conduct each other's IDRs, or a long-term care facility such as nursing home administrator or director of nursing. Others use designated individuals within the state survey agency. The states may assign the review to internal staff members, typically somebody who's not involved in the original survey. This method is often simpler and quicker, though it may raise concerns about perceived impartiality. Some states also offer a choice. A few states allow providers to choose between having the review conducted by the state agency or by an independent organization. For example, Improve Health, we are an independent review organization that some states contract with to conduct IDRs and IIDRs. This allows flexibility and gives providers more confidence to the neutrality of the process. But regardless of the structure, for IDR, state retains responsibility for administering the process and covering costs. While the structure and participants may differ from state to state, the overall goal is the same: fair, evidence-based review of the survey findings. So now it will be on to the next slide, but I'm going to go ahead and turn it over to Charlene, our IDR and IDR consultant, who will guide us through the next part to dive deeper into specifics of the IIDR.
Yeah, thank you, Bailey. You probably all noticed that there is another I in IIDR. And just to give you a little background, the IDR process that Bailey just talked about has been in effect since 1987 as part of the Nursing Home Reform Act. It was also part of the Omnibus Budget Recommendation Act, or OBRA. Those of you that have been in the industry a while remember OBRA. So IDR has been an opportunity for a long time. Next slide, please. Next slide, please. No, I'm sorry. Back one, please. No, back one. Back. Up. There we go. So IIDR became effective on January 1st, 2012. And IIDR is part of the Affordable Care Act. The final rule was published on March 18, 2011. And the CMS rule is reflected here. So what IIDR is, what the regulation says is that following a nursing home survey, state survey agencies are required to provide an opportunity for IIDR to review survey findings, cited at a scope of severity of G or above. And we kind of, a lot of us here today have talked about the scope and severity grid, for which CMS has imposed a civil monetary penalty and is subject to being placed in escrow. So initially, after the survey and after the facility receives their statement of deficiencies, the state agency letter, the communication gives them an opportunity for IDR. And then further down the road, and we kind of addressed this earlier, was listening in, it depends on how caught up the regions are. CMS will issue the actual letter of the notice of a civil monetary penalty. And in that letter, it gives the facility an opportunity for an IIDR. Next slide, please. So the IIDR process does not remove or alter the existing informal process, okay, which remains in use. The State Operations Manual, Chapter 7, goes into great detail about the difference between the two processes. And so we're going to get into that a little bit. So it's really in addition to the current IDR process. So right out of the State Operations Manual, a provider can request both IDR and IIDR if the IDR was completed prior to the imposition of the civil money penalty. And I can tell you there's been a lot of confusion about this over the years, about if a facility can do an IIDR after an IDR. And in most cases, they can. And we're going to talk a little bit more about some of the contracts we have in states where we do both IDR and IIDR. The process that Bailey kind of went through about the actual reviewing of the citations is relatively the same. We're looking to see if a deficient practice existed, and if it did, did the facility rebuttal provide any information to dispute it? And we make a recommendation, just like the IDR, to either uphold, support, delete, or amend. Next slide, please. So what is each state's IIDR process? Well, just like IDR, the state handles it a little differently. However, the additional I in the IIDR process means it must be an independent entity. There has long times, there's been a lot of, I should say, gnashing of the teeth about IDR process not being truly independent, because a state agency can do the review themselves. So one of the reasons why in 2012, we got the IIDR process. So the reason for it was, just real briefly, is that citations that are higher level and associated with those civil monetary penalties that are going to have a greater impact on the facility, they want an informal dispute resolution to be conducted independently. In other words, you can't decide. The state, it has to be independent. So what does independent mean? And the state operation manual goes into great detail about that. And we're going to go a little bit into that. Just briefly, it should have no conflict of interest. And if they're going to use the survey agency, it may be external but it has to be organizationally separate from the survey agency. So next slide, please. So the SOM, the State Operation Manuals, goes into great detail about how you qualify to become an independent informal dispute resolution entity or person. Each state has to have their IIDR process approved by CMS. And so obviously some of the key components are expertise and training. The person that you are designating to do your informal IDR has to have understanding of the Medicare and the Medicaid requirements and of the state operations manual. Also, what is the person's background? They have to have a background in healthcare, standards of practice, healthcare management. We also do life safety code. So we have life safety code experts who do those types of IDRs. So the background of the person doing the review is relevant to the disputed issues. And we'll get into a little bit more about the background, but most of our people, we have a diverse background of people that do reviews, not only from the provider side, but also from the state survey agency side. The entity or person has to have no financial or conflict of interest. And like I had said earlier, it may be a component of the state agency, provided that the component is organizationally separate from the state survey agency. Or you can contract with an independent entity such as Improve Health that, we're going to go into our accreditation, how we're accredited as an independent review organization, and the background of our reviewers and our history with conducting IDR. Next slide, please. Comparing IDR and IIDR. Next slide, please. I want to say, first off, we have been doing IDR since 1997. We got started. We were the peer review organization for the state of Michigan, and the state of Michigan reached out to us because they were getting quite a few IDRs and they just didn't have the time and the staff. And so, long story short, we started doing them, and then it kind of evolved from there, having contracts with other states. And the process has evolved into providing IIDR services, which started in 2012. So just a couple of comparisons. The Code of Federal Regulations is different. One is the 0.331 and one is 0.341. One we already talked about is informal, and the other one has to be independent. The request for the IDR, it has to be pretty much, every state follows this, that you have to have your request in within 10 days of the receipt of your statement of deficiencies. And I believe Lacey talked to that about that. And for the IIDR, the facility has to request it within 10 days when they get the offer to do an IIDR from CMS, from the Centers for Medicare and Medicaid Services. So the two different timeframes. The deadline of completion for IDR, there's really nothing in the regs that say the IDR has to be completed by the state within this time frame, but state rules vary. Some states have statutes that will go into detail about that, but each state for the IDR process has to have a written process, and it should be timely. In the IIDR world, it's very clear in the regulations that it has to be completed within 60 days of the facility request. How does the provider get the recommendation back or the final decision? In IDR, each state differs on how they communicate that to the provider. Some of them give them a report, and some of the states where we do contracted IDR, we provide a very detailed report back to the state agency with our the reasoning for our rationale and references for our recommendation. And we are providing a recommendation back to the state survey agency in these cases. Some of them just, some states say it was upheld, or some states say it was deleted with no rationale. It's really from soup to nuts how the state agencies communicate back to the providers about the end result of the IDR and the IIDR. It's similar with IIDR, but the IIDR, the regulations are very specific that you have to generate a written record and what has to be in there. So in both cases, the final authority still lies with CMS. So for IDR and IIDR. When we do our reports, our final outcome is a recommendation. We'll recommend to support, delete, or amend it. We give you rationale, references, and then the final authority obviously is with the state, and CMS is the final determination. If they see something they don't like, they can actually overturn anything. So I just wanted to say, since the ombudsman was on, in the IIDR process, this isn't in the slide, but another difference is that the state agency has to notify the resident and the resident representative and the ombudsman of any IIDR request and who is what residents are affected by it. So if let's say, you know, your mother is one of those persons that eloped and there was an immediate jeopardy and it got to the point of an IIDR, that person would be notified, or the resident representative would be notified. And those three individuals, the ombudsman, the resident representative, and the resident, each have an opportunity to make comments, to submit, to be reviewed with the IIDR. So that's not the case with IDR. As you know, residents' privacy is protected in the statement of deficiencies, so the names aren't there. But in those cases, the state agency has to do the best effort to notify those people that an IIDR is in process. You have an opportunity to comment and submit it to the whoever has been designated in that state to conduct the IIDR. Next slide, please. Okay, I'm going to turn it back over to Charlie and to talk about the current IDR process in Kansas.
Thank you, Charlene. And so, like Charlene, I had the opportunity to listen to Lacey present to the committee this morning, and she did an excellent job laying out the IDR and the IIDR process. You just listened to my colleagues talk about the IDR process in accordance with the CMS regulation. So let's take a look at the state requirements. Next slide, please. So the state of Kansas requires a 3-person panel appointed by the Secretary for Aging and Disability Services, or KDADS. How is this operationalized? My colleague provided an overview of how states may choose to handle the IDR process. And so how is that operationalized in Kansas, and how does that work? After the written request is received from the administrator, the department is required to provide the administrator with a face-to-face IDR meeting. The administrator must identify the disputed deficiencies, provide a detailed explanation for the basis of the deficiency. And as we learned, they're not permitted to use this as an opportunity to challenge the survey process or inconsistencies with the survey process or surveyors or remedies. They're to provide supporting documentation, including information that was not available at the time of the survey. The Kansas Administrative Regulations under Article 39, this 3-person independent review panel consists of 1 member from KDADS, from that nursing home survey unit, provided that that individual did not participate in the survey that gave rise to the dispute. And so given the staffing concerns raised by Lacey, this may be challenging to implement. I heard some of the testimony regarding provider trust in the process and concerns that the citation is upheld often by the same agency who issued it. And so transparency and trust is really a key element when we're looking at the members of the panel. 2 members, the other 2 members, may be employees of the Department of KDADS, but shall be from outside the survey unit. Charlene read that piece that stated it must be organizationally separate from the state agency. And so that individual can be a healthcare professional or a consumer not employed by the department. We learned earlier that sometimes 3 KDADS people on the panel, depending on the schedule availability, is seen in this process. And perhaps contracting through an outside vendor or individual or entity may be of interest to the committee as they weigh their options and learn more about this process today. The next slide. And so now we'll talk about what happens after the panel is convened and what are the requirements. So the panel is convened within 30 days after receipt of the request from the administrator. If the panel cannot be convened within those 30 days, the department will advise the administrator of the date of the panel meeting. Panelists are to adhere to confidentiality requirements related to the information presented in the IDR process, and Charlene spoke to that in that the statement of deficiencies uses those identifiers to refer to residents. So that does help to maintain confidentiality. More than 1 IDR request can be reviewed during the panel meeting. And note that the panel should determine the order and the method of presentations by the administrator or representative of the facility and the department. Time limits: each representative provides oral presentation, and those time limits are imposed by the panel. Questions: only the panel can ask questions of the presenter. And prohibitions, I spoke already about that, in that this should not be an opportunity for the facility to bring up issues outside of what's prescribed in the IDR process. The recommendations that flow from this panel meeting include a recommendation to uphold the citation or the deficiency, to delete or to revise, or what we call amend the citation. And that could be, under certain circumstances, the scope and severity. Written recommendations follow after the panel meeting, and the facility is notified of the findings by the state. Next slide, please. Charlene, we're going to turn it back to you.
Yeah, thank you, Charlie. I just want to say that when we were asked to do this presentation by Leading Age, Kylie presented us with some things that she wanted us to cover. So I am in no way an expert on the IDR and the IIDR process in Kansas. I think the best person to address what the process is, how it's actually operating is, you know, probably your commissioner from KDADS, but we did do some research and tried to cover what Kylie had asked us to include. So thank you, Charlie, for that, for the IDR process. So the current IIDR process in Kansas, next slide, please. We have been told that your state functions with the use of a panel. We were unable to locate the written IIDR process approved by CMS. That's something that the KDADS would have. We do know that, as we talked about before, about what type of an organization can conduct an IIDR, that the process and the entity or person has to be approved by CMS. So it has to be approved as an independent IDR entity or person, whether it is a state agency or outside organization contracted by the state agency. So we went through that before. I'm not going to go through that again, but so we've been told that the IIDR process in the state of Kansas is conducted in accordance with State Operations Manual Chapter 7, which makes sense. So next slide, please. I want to say one more thing about IIDR is that it doesn't sound like you have that many. So it's you know, I'm not, it didn't surprise me that we couldn't find a lot of information out about the IIDR process. But since we were asked to talk about both IDR and IIDR, we felt that, you know, wanted to share the comparisons. So why do states choose to outsource IDR or IIDR programs? This is an interesting question. As we heard earlier, and what I said about the state of Michigan is sometimes the state survey agencies don't have the time and the resources to do the IDRs, especially if they're done in person. If there's a panel, there's more than one person. Difficulty staffing from the state. IDRs can be done by the state agencies, but a lot of states outsource them, and we'll talk about which states we outsource with because they don't have the time, and also because of the provider's perception of the conflict of interest. And I think we heard about that earlier from the people that spoke from the providers associations and from the actual provider arena themselves. So, you know, there's all kinds of time frames associated with citations, civil monetary penalties, resurveys, recertification. And if somebody's IDR or IIDR is hanging out there, it really makes things very difficult. So a lot of times states, those are some of the compelling reasons to outsource it. Some outsource IDR and IIDR. Some only outsource IIDR, so there's all kinds of options. Next slide, please. Final outcomes. Charlie, you're up.
Yes, ma'am. And so we'll talk a little bit about those final outcomes of the IDR process. Next slide, please. As Charlene mentioned, our organization, Improve Health, currently has contracts with several states, as illustrated here on this slide. We have IDR contracts in 5 states and IIDR contracts in 10 states. For IDR, we have the state of Delaware, Michigan, Texas, West Virginia, and Wisconsin. And for IIDR, our contracts with states include Arizona, Delaware, Illinois, Indiana, Kentucky, Michigan, Mississippi, Ohio, Virginia, and Wisconsin. We support multiple provider types, including nursing facilities, assisted living, intermediate care facilities, hospice, home health, and settings that care for individuals with intellectual disabilities. Next slide, please. Some of the current statistics around our IDR and IIDR work. And you see the time frame there between 2022 and 2025. The state, you know your stats on this, but as the slide shows, and as we heard some discussion and Charlene's comment about IIDR, you don't have very many IIDRs, but from the information that we have, was provided for us. 100% of the IIDRs have been upheld during that time frame, and for IDR, 89% are upheld. And our recommendations, looking at the states where we provide those services, IDRs are upheld 75% and IIDRs upheld 91%. And so we might talk about this later in our discussion today, but the timeframes, I know that time is of the essence, and there's staffing challenges, but our average turnaround time from assignment from the state agency to return of our written recommendation to the state is 16 to 18 calendar days. And so this includes those, complex substandard quality of care and IJ citations. Next slide, please. So what contributes to a recommendation to uphold, delete, or amend, we call amend or reduce a citation? Deletion. In this instance, the 2567 or statement of deficiencies does not support a deficiency. To uphold, that reflects that the rebuttal provided by the facility did not provide evidence of compliance with the regulation. And so the 2567 or statement of deficiencies demonstrates a deficient practice. And as I think Bailey said earlier, it was able to stand on its own. An amendment occurs when the statement of deficiencies, the 2567, supports a deficient practice, but maybe the scope and severity is not supported, or there may be resident examples that didn't withstand the principles of documentation, and there was not enough evidence to include that resident in the example. Some of the evidence that's required in what, the panelists, be it an independent entity, an individual, or the panels by different states, depending on how they choose to execute this process. The quality of evidence and documentation from the state agency and the information from the facility is really important. And so relying on that written record, not using this as an opportunity to amend what the surveyor findings reflect, but to really read through the evidence that's presented in the 2567, and similarly for the facility to review all of the information that they've provided, looking with detail and specificity at dates, care plans, and any other supporting information that they believe would be of assistance to the panel. Next slide, please. Charlene, back to you.
Yeah, so I know we talked about why you would outsource, and one of the questions that we were asked to cover is consideration of cost. What does it cost? Okay, so that's a great question that I don't have a great answer to. So next slide, please. It varies by state. Our contracts are all with the states, okay? So the way we obtain these contracts, usually a state will go out on a request for proposal, and there will be a detailed information on what they want to include in their process for IDR or IIDR, and then we bid on that. Some of the examples of some of our contracts are a base fee per citation. So citation F whatever is so much per review. And then some of our contracts are base fee per tag, which would be a lower amount plus an hourly rate for the reviewer. We also have some contracts where it's based on the actual scope and severity. So lower level A through E level scope and severity citations might be one price, and then the higher level ones would be a higher price. So there's all kinds of different ways to be compensated as an independent independent entity to provide IDR and IIDR services. So it's really hard to nail it down. Obviously, next slide, please. Obviously, one of the big factors is your volume. You have over 300 nursing homes, skilled facilities. Like Charlie said, in some states, we also do assisted living. We do some ICF facilities, hospice, home care. So, it depends on the volume. How many IDRs and IIDR requests you get a year. And then if something is based on an hourly rate, a citation for an elopement IJ could take 2 hours with one example. And then you could have a citation such as infection control, where there's 15 examples. And you have to look at each of those examples separately, which could take 6 hours, more, whatever. So it really depends on the complexity of the citation. You know, there's when the survey is done, there's actually an event number assigned to the statement of deficiencies. And so you could have an event number that has 20 citations, but they're only IDRing 10 of them, or so it really it's a very cost depending on the volume. Also, how are you conducting them? Our company is 100% virtual. We do conference calls, and we also do video conferencing depending on the contract. Some states offer that video conferencing conference calls. Some states did have in their state regulations that it would have to be face to face. So we've done a little bit of traveling, but when COVID hit, that came to a screeching halt, as you know, and we haven't not done any in-person IIDRs or IDRs since then, because we offer the video conferencing. And you don't have to offer that. So any travel expense was, for those contracts that we had, was the cost was incurred by the provider. So you want to have somebody travel to you, or do you want to do a video conference? They lion's share will pick the video conferencing. Other costs are administrative costs. Those are all built into our contracts. What it is to oversee you still have to have somebody, the state agency, who is responsible for overseeing your IDR and IIDR program, even if you do outsource. And then obviously the costs associated with an RFP and things like that. So next slide, please. Back to Charlie.
Thank you, Charlene. And so what makes Improve Health a qualified independent dispute resolution entity? We believe our qualifications rest in our URAC accreditation and our NIRO membership. So I'll talk to you a little bit about those 2 points. We've held our URAC accreditation since 2002. And who is URAC? So URAC is the Utilization Review Accreditation Commission, aimed at promoting healthcare quality and accountability through rigorous standards and evaluation processes. Every 3 years, we undergo a review by the accrediting body to evaluate our processes in implementing IDR and IIDR and administrative review process. This includes a deep dive into our policies and procedures, compliance with HIPAA provisions of security and privacy, confidentiality, employee training, adhering to the conflict of interest standards for every review completed by every employee, review of employee qualifications to ensure the qualifications are aligned with the review conducted. For example, where there's been substandard quality of care for a pressure ulcer citation, did the reviewer possess the requisite skills and training to render a decision or a recommendation to the state agency? We are also members of NIRO, and NIRO is the National Association of Independent Review Organizations. NIRO is a valuable membership for our organization because it provides access to a professional network of URAC accredited IROs, independent review organizations, who collaborate on issues facing the rapidly changing healthcare arena. Improve Health is an active member of NIRO and active participants engaged in committee meetings, planning educational conferences, and discussions about solutions and challenges for IROs. NIRO publishes white papers on topics such as AI in the review industry. Members have access to a legislative tracking report so we can stay up to date on challenges and regulations that impact the review services industry. Next slide, please. So impartiality, that's really important to maintain independence. And so here we'll just talk to you a little bit more about our history in providing IDR services. We provide timely, impartial, and high quality reviews as evidenced by our continued success in maintaining accreditation with URAC. Our staff are experienced in having previously worked in a facility, albeit we're required to adhere to those COI requirements outlined in the SOM Chapter 7. And so having that UREC accreditation where we're required to test what we believe we've applied with our policies and procedures. So they pull random files. We don't even know who they're going to pull when they go to test our policies, our procedures, and our conflict of interest attestations. The staff, they're educated about confidentiality standards and conduct telephonic or web meetings, ensuring that both parties are heard and remain neutral in sticking to the facts and the evidence presented. We're a trusted partner in upholding the integrity of the IDR process and have done this since 1997 for IDR and 2002 for IIDR. We believe that our organization continues to help healthcare get better when we follow the regulations and partner with states to ensure the regulations are applied fairly and in accordance with the federal regulations when we review an IDR request. Next slide, please. Bailey?
Right. Yes. Thank you so much, ladies. So we do have just a couple of slides left here. And we're going to kind of go through a little bit about improved health process and some of the qualifications that we have to help you all gain a clear picture of what a state can expect when working with an independent review entity such as Improve Health. So part of our review process, we kind of outlined some 5 steps here. Each review begins with a submission of a request. It's through our secure online portal. This ensures that the sensitive information is protected. Nothing is on paper. All applicable material is accessed through this online portal that both the facility and the state agency are provided access to. We also have a process for case assignment. Once it is submitted, the managing director, which is myself, conducts an initial review of the case to assess the scope and complexity of the case. So based on that, the case is assigned to a reviewer with the appropriate expertise and no conflicts of interest. The first level of review, the assigned reviewer then completes a conflict of interest attestation to ensure objectivity. They then review all submitted documentation and consider relevant regulatory standards. And if requested, they facilitate a video or conference call to allow further clarification or discussion. Then we have a second level review. Once that recommendation from the reviewer is drafted, the managing director, myself, conducts a second level review. This includes verifying that the findings are well supported by the documentation, are in alignment with CMS and the Code of Federal Regulations and all guidance, and free from any omissions or inconsistencies. And then completion of it. Finally, we have a recommendation that we submit back to the referring entity, to the state agency. It's important to note, though, that while we do provide an impartial, evidence-based recommendation, CMS, again, does retain the final authority to accept or reject the recommendation. Next slide, please. So the additional qualities of independent entity that a state would want to consider are outlined here, kind of in mentioning some of Improve's health strengths, such as proven experience. We do have decades of experience in IDR and healthcare programs across multiple states and care settings, as outlined earlier. We have longstanding partnerships at the federal and state level. Internal expertise. Our team of reviewers includes those that have experience as administrators, director of nursing, registered nurses. We have previous state surveyors, life safety code specialists. Our team also completes monthly trainings to keep reviewers up to date on the ever so changing regulations and state requirements. Impartiality and integrity, probably one of the most important. We are entirely independent and impartial in our approach. We have those coming from both sides, very unbiased. They come from the provider world as well as the surveying. So seeing both sides. Very impartial. All recommendations are based solely on applicable standards of care and regulatory compliance. Security and compliance. Staff are required to complete rigorous annual security and HIPAA compliance training. The security of our HIPAA compliant IT system is also, it's a part of our evaluation in the audits and annuals and 3-year reaccreditation surveys for our URAC accreditation reviews. And so that is all that we have. I know we are getting kind of close to the end, but we at this time would be very happy to answer any questions that you all may have for us.
Very good. Thank you for that. Very informative. Committee questions. Representative Bueller.
So I don't know who would answer this question, but I looked at the map of the states that either do IDR or IIDR. So let's pick one, West Virginia. You do both for them. When did you start? So I'm interested. Today we do everything through our KDADs. If we wanted to completely outsource both IDR and IIDR in the state of Kansas, how long would it take? I understand we would have to change our statute, but we'd have to go through the RFP process. Can you tell me in one of those 10 states from start to finish how long that process took?
Yes, sir. From start to finish, from the start of the survey or start of once we receive the request?
Once you receive the request. So we inform, I'm just saying, we inform you and we change our statute in 2026 that we're going to outsource this. How long would it take to do it?
Yes, sir. So whenever, like if it's an IDR request, once we receive the request, every state, again, has the opportunity.
Excuse me. He's talking about as a provider, if we went with an RFP for you, not an actual request or.
I want to change the process in the state from us doing it internally to working with you or someone like your company. Does that make sense?
Yes, sir. Yes, yes. That is, I actually, I am not going to be the one to answer that. So I will see if
I think CKV
one of the
could
two
take that.
Charlene's.
Her experience.
I can help with that.
CKV
I
has
think,
experience doing just that.
you know, many years of experience with different contracts. I mean, once the RFP, you know, it really is based on how long it'll take you to get the RFP ready and, you know, changing your statute too. And then once it goes out for bids, you know, there's a bidding process and there's a date. We could be up and running within 30 to 60 days because we, you know, we have processes in place to do IDR and IIDR reviews for all different types of states and all different types of providers. So, and you know, that would probably be written into the RFP when the organization or the vendor that is awarded the contract, when you would want that organization to go live. So we would be in compliance with the contract. Sometimes we've gone, you know, we've had some contracts were signed and they didn't get implemented for 6 months, but it's totally up to you. But we, you know, we would base our the contract bid on what you want. Want it to be live in 30 days. You know, that our portal, we have everything is online. You have access to the, I don't know how your IDRs are done now, if it's all paper, but everything is electronic. So the state has access to the IDR in the portal. We have IT support for, you know, if you want your providers to submit it directly to us, we have that capability through our portal, and then you can go in and see the IDR. There's all kinds of different ways of, some states receive the IDR and then they send it to us. I mean, the easiest way is for the provider to send it directly to us. But we do provide support to all those people that are using the portal. And with our portal, we're always updating it like everything else. But I think we've had this particular portal for at least 7 or 8 years. So it's very sophisticated. Our reviewers look at everything online. And like Bailey and Charlie talked about, all of the security for all this protected health information is part of our URAC accreditation process, looking at how do we protect a patient's, you know, information, because we're getting parts of their medical record. So did that answer your question, sir?
It does. It tells me that within a year or so, we could change. Okay, that's what I need. Thank you, Mr.
I would
Chair.
agree with that, but
Okay, committee, further questions? I have one. How many other providers are you aware of that do the same services that you do?
oh, that's a good one. You know, not many. I would say there's a handful across the country.
Well, I see
don't-
you only serve, what, 15 or 20, you know, so obviously there are other states and other providers out there, I would think.
Well, that's true, but they could be doing, they could be not outsourcing. They could be doing it on their own, you know, like, or for the IIDR, they could be using an organizationally separate agency from the state survey and not outsourcing it that way. But there are other organizations. There are some individuals too, you know, some prior surveyors that do it as an individual. We're an entity. We're a big company that does other things too. So there are other ways to outsource it. So, but Bailey or Charlie, unless you know, I would say probably, I mean, they come and they go, but you know, we probably have 4 or 5 competitors that I can remember.
I
Yeah,
would
I
say
will
that's still accurate, Charlene. Go ahead, Bailey.
Yeah, I will say that we are one of the largest IDR entities in the U.S. There are quite a few who do the trade association. They'll work with another state to do each other's IDRs. That has come with their own issues in that process that they kind of experience internally doing IDRs. But yeah.
Okay, very good, thank you. Committee, further questions? Thank you, girls, again for your time today.
Yes, thank you so much for the opportunity.
All right, we're going to go on. Bob? Bob, welcome to committee.
Committee members, thanks for inviting me and letting me speak with you today. Definitely something I like to talk about is survey. So the good news, if you've survived the day and you're still awake after lunch, I have no procedures, no regulations, no long slides like that. So hopefully keep you all engaged here. Do you have my presentation? Yeah, you can go ahead with that. And just to answer a couple of the questions on the last one, we're another company that does IIDRs. And to your point, your question about getting started, as soon as a contract's signed, within the week we can be going. It's really quick on our end. I'm sure it's quick on their, on Improve's end as well. It's really the state's process that tends to slow us down, so. Well, my slides aren't too complicated, so I can talk anyways. But just to kind of give you an overview of why we're here, I think there was some interesting solutions, right? So we're a private sector company. We do all kinds of stuff. Yeah, there we go. You can go ahead and go to the next one. I'm the CEO, Bob Foyer of CertiServe. And so we do surveys. We do of all sorts of facilities. We do the IIDR reviews, as you can see there, surveyor and supervisor training. And then we also do some disability and other social and health services support work with litigative physician support. You know, these are providing opinions and things like that. So we're in a few different places. You know, I don't want to spend a lot of time talking about our company specifically. I really want to go over what the private sector can sort of do to solve some of these issues, and also what we've seen in other states. You can go ahead and hit the next one. So just to give you an idea of our credentials, though, why I can stand here and talk about this stuff, you know, we work with over half the states in the United States, so lots of experience seeing different state agency challenges and what they've worked through and ways to solve them. Right here in Kansas, we've been working with KDHE for 6 years now, since 2020, and I think our contract's still out there till 2029 or 2030, so we had a great relationship with them. It's been very nice working with them. We've always wanted to work with KDADs. You know, we cross paths with their group over various conferences. Just haven't had a need to go there yet, or there hasn't been an RFP yet. That's really the only thing holding us back. You can see CMS Region 7 I mentioned here. That's your region. We have contracts with all your neighbors in your region. So Missouri, Nebraska, Iowa, we've had contracts with them since 2020, 2021, around there, and all of those states still have active contracts. We've done a lot of surveys for them. And then some other bordering states to your region, just to give you an idea, that if you kind of look at the map, we're in all these states I listed there: Colorado, Arkansas, Kentucky, Tennessee, et cetera. So that gives you an idea of the fact that not only do we do survey across country, but we do surveys in states that are similar to yours, very large states, rural areas, with a smattering of these high density urban areas as well. So it's kind of nice. And then just some other background real quick. Our leadership team, me and the other C-suite, we were all part of the CMS rollout of the new survey process back in 2007, 2012. So we had a CMS contract to do that. So we were training surveyors in all the states in this new process. We have a member of our leadership team that contributed some questions to the SMQT, which is what all nursing home surveyors have to pass to go into nursing homes. And then we also have worked with providers at my last company for several years. We were selling a software system that basically let providers prepare for survey, find their own issues, find their own root cause, hopefully fix those issues, all to the betterment of the resident. And then they have less deficiencies. It's kind of like everybody wins. All right, next slide. Can you go back one? Sorry. So the questions that come up a lot of times when I talk to new states are, well, how can you work with the agency? What different ways can you do? And we've done a lot of different things. So I'm going to kind of just talk through some of the different potential ways that we can do this. And just to focus, our core thing that we typically provide is survey, oversight, and the quality assurance of the survey results. So we go and find deficiencies, we QA those ourselves. But there's different ways to get to that point. So I can tell you the options, and I'll tell you my preferences and what I've seen work the best. So on this first bullet here of turnkey versus supplemental. So by turnkey, what I mean is the state agency tells us this facility needs surveyed, and we just go there. We schedule a team, we go in, we do the survey, we exit, we QA our own writing, and then when it's all done, we kind of tie it up with a bow, give it back to the state, here you go, ready for CMS or whoever else needs to look at it. So it really helps the state agency because they're kind of, hands off. It's like a big chunk of work they just don't have to worry about. Now, we can also do supplemental type work, and that's more of an environment where maybe it's 2 surveyors are from the state, a couple surveyors are from our company, and we kind of work together on the team. Maybe they're short of nurses, and so a lot of states do multidisciplinary teams, which you've heard about earlier today. Maybe they don't have enough nurses, so they might have a lot of generalists, but you need to have at least 1 nurse on every survey team. So they might ask us, hey, can you give us a nurse? That's all we really need, because we have surveyors, we just don't have enough nurses. So that happens. Now, I'll tell you, the turnkey stuff is nice because of the flexibility. Our surveyors have really no limitations on when they work, unlike a lot of states. A lot of states either have union or exemption rules or budgetary rules, or they can't pay overtime, things like that. Once we take over the survey, we don't have those restrictions. And we'll touch on some of the budgetary aspects of that towards the end here. I'll just mention multidisciplinary teams again. You've heard it this morning. I think it's common sense, makes sense to probably everybody on the committee. It makes sense to have different disciplines in the facility. It's a great benefit to have a dietitian reviewing the kitchen area and the nutritional menu and things like that. It's a great idea to have a social services person talking to residents about their emotional needs and their activities and what they're getting to do. A nurse is great. Nurses are great for clinical activities, and it's not that they can't do these other things, but they're not the expert in that field. So in as much as the committee's thinking about recommendations and things to do, I would definitely encourage you to find ways to get those multidisciplinary teams in there. It'll also help with some of the staffing vacancy issues if you're able to get around that. So getting back to some structural ways to work, there's also a focus on what we work on. Some states will want us to do just RETA certifications so that their team can focus on complaints. I think that's probably a good idea because I don't know if Lacey touched on it in her presentation, but typically immediate jeopardy complaints that come in are required to be looked at in, I believe it's 72 hours now, it used to be 42, 48. So, you know, calling us up and saying, hey, we need you in this facility in a day or two can be trickier than having somebody that's in the state agency get there. And so research, however, you know, we can kind of schedule our entry a little more whenever, as long as it's in that 12-month kind of window. So that's an option. But I will tell you, we do complaints for lots of states. There's also, not all complaints are IJs, right? There's tier 2, tier 3 type complaints that, you know, it's just whenever we get there. And so we can schedule those as well. And of course, we take complaints with research. So there's that. Some agencies will be focused on a certain facility type. You know, using KDHE as an example, I think there was a couple years back where they were pretty good on hospitals and EMTALA surveys, but they were missing, I want to say ESRDs and HHAs, or home health. You know, and so we were really focused on the things they were missing until they got some people in there. We helped them train some new surveyors, and then they were good. And so it's sort of a temporary way to let the survey agency kind of catch up with whatever facility or survey type they're struggling with. We also do, less commonly, but we definitely are capable of doing back office and post-survey support. And so what this is when you think about after the survey, the 2567, which is the statement of deficiencies you've heard referenced a lot, you know, that comes in, it has to be reviewed, and then if there's any deficiencies, the facility has to provide a plan of correction to say how they're going to get back into compliance. That all takes review time. You may have to do a desk audit. You may have to go back on site. Typically, the state's going to take care of that because, as I said, we hand that survey back to the state, and they kind of handle everything post-survey. But we certainly can do it, and we do it for a few states. So we manage all the communications with the facility all the way through getting them back into compliance. The only thing we really wouldn't do in that regard would be enforcement. This would be the monetary policies. If you're going to close down a facility, put special management in place, those things are still going to stay with the state just from a jurisdictional standpoint. And then training. You know, we love doing training because as a mission, you know, I see this, you guys are here in the state, but I can tell you the whole country's got the same issue with not enough surveyors. And I feel like when we can get in there and do some training, we're adding surveyors to the pool. And the more surveyors that are out there, you know, even if it's in just one state, people move, right? You know, and so a surveyor that gets trained in one state 3 years later may move to another, and you just want to have more surveyors, you know, and that's sort of the key. So we'll put together training programs. Our training supervisor was working with CMS for years. Again, part of that rollout I mentioned earlier. So he's got lots of training experience. Those are typically, I think maybe it was Lacey mentioned, it's about a 6-month process to really get a surveyor up to speed, and I would agree with that. The challenge for state agencies is you might hire up 20 people to put through training. You're going to lose some on the way. It's surprising how many people will think, oh, this sounds like a great job, you know. I've been a clinical nurse. It'll be nice to kind of get out of the clinical role and start just doing some regulatory stuff. They get in there and they find out it's a lot of work. And, you know, they're getting paid less than they can get in the private sector typically. So they might, you know, go in for 5-6 weeks and they're like, yeah, this isn't for me. And so you get to the end of that process. Now you've only got maybe 14 or 15 left, and you've invested payroll dollars in all those people through that training process. So it's kind of nice when we can come in, train people, and, you know, help let the survey agency focus on doing work, doing the surveys. And I'll touch on that again some more. But so those are all areas that we can help with. Now I've got the next few slides here. I've got some differences from the state agencies and some benefits for all the stakeholders that really matter. You know, so from a staffing standpoint, state agencies have some limitations they have to deal with. There's budgetary issues. Some of them are on fixed pay scales for public employees. Sometimes they lose people, and it's not because there's not people available. It's just that the working environment doesn't work for certain individuals. And so I've got a couple things listed here: retirement, burnout, labor market relocation. So, for example, somebody may be a surveyor. They love doing the work. As states face more and more vacancies, what happens to the people that are left? They're getting more and more pressure to work more, right? And so now it used to be maybe you went out on survey 2 or 3 weeks out of every month. Oh, we have too many vacancies. We need you to go out every week. And in a big state, especially like Kansas, you know, you got rural areas, you're going to be away from home that whole week at a hotel. And I understand Kansas may not send everybody the whole week. It sounds like there's hour limitations, but you get the idea. You're away from home. It's a tough job. So you're like, I just can't do this anymore, and you quit. Now that person probably has years of experience. They're a great surveyor, and they're gone. They're out of that market. And what I feel is nice from our standpoint is we get to take people like that. We let them work as much or as little as they want. So we kind of keep this knowledge in the field, so they get to keep working. It helps relieve this overall nationwide shortage of surveyors, but it meets them where they're at. Sometimes people retire. They're like, I was a surveyor, I loved it, but I can't work full-time anymore. I want to work here and there, and we do that. So if we have a retired person that can do 7 or 8 surveys in a year, that's 7 or 8 surveys that would be 0 if they just left, And so we have the flexibility to do that, whereas state agencies do not. And certainly no fault of the state agency. They're working in a framework of government employment, and the private sector, we don't necessarily face that. Selection from a national pool, if you think about, I like the sports analogy, you look at a big giant college, their football team's great. And why? Because their best football players are really good because it's a big pool. Same thing here. We're hiring from the whole country, so we get really good surveyors because we can pick from the whole country. So that's kind of nice. It really, the people that work for us tend to, they kind of take it as a bit of a bragging right? I was able to get through CertiServe's training, so I must be pretty good at my job. And that's great for morale. It's great for the people that work with us. Training, I think Lacey again mentioned that there's 3 hours of required training from CMS per year. State agencies, I'm sure, do more training than that. I'm sure KDADS does more training than that. But some state agencies struggle with it because they're so overworked. Whereas, again, we don't have that same constant pressure from CMS or from a given state legislature to get X amount of stuff done. So we can spend a little more time training our people and keeping our surveyors up to speed on all the new regulations, making sure that they know what they should be doing. So I feel like that's a bit of a difference between us. This rapid response bullet point really has to do with making changes in staff. There's bad cops, right? So you get surveyors, and you've heard it from the providers, or you may hear it from additional providers, but there's times that some surveyors just aren't great. They're sort of citing things just because they can, or they just like kind of using their ability to do that. We don't want that for our folks. So we can remove those people quickly. States have a more difficult time removing employees. There's often some hurdles with red tape, or there's processes in place, and it can take a lot longer. Whereas we can make those changes very quickly to keep our overall surveyor team to really good, really provider friendly, residents focused, and get rid of those kind of issues. And lastly, is independent company culture. That's a similar sort of thing. We don't have any of the political issues that go on at times. We're just out here working. Administrations come and go in different states, and the parties and the political affiliations can change. Hopefully, we're all working for the same thing, but sometimes the focus or the pressures change, and we just don't have that distraction. So it helps kind of keep our surveyors feeling more comfortable and happy. And then on this mission driven with the focus on quality, that's what I'm speaking of there is we're not trying to catch up. KDADS and other state agencies, they've got a certain amount of surveys they've got to get done, and they've CMS sort of on them with their performance numbers and with their time to last survey. Like we've spoken of today, the 19-20 months that KDADS has should be lower. We don't have that same pressure. And so when you hear things like, well, we're going to make sure that we're only in the building a certain amount of time so that we can churn through surveys, the way that happens, there's definitely a possibility that things will either get missed, which isn't good for the resident, or surveyors will cite things quickly without necessarily interviewing everybody, so they may miss things that the facility was doing that actually would have shown that they were in compliance, just to try to get done quickly. If we need to go into a facility and we need to be there 2 weeks, 3 weeks, whatever it takes, if there's IJs, we're not going to leave the building until immediacy is removed, because we don't have that same pressure to get out and get on the next survey. We're able to really focus on quality, protecting the residents, and helping the providers too, which I'll speak of more. And then, working across the country, we see all the things that other agencies are doing that work well. best practices. There's definitely times a state agency will say, oh, here's how we handle this, or here's how we do that. And we'll say, that's a really good idea. And so we'll snatch that up, incorporate it into our operations. And I think that helps us out. So hopefully those differences didn't come across as too negative. The nice thing is we haven't worked with KDAD, so I can say none of the negative things in here have to do with KDAD. So it's good. So some benefits to the state agency. I talked about differences, but the ways we can really help them. As I mentioned earlier, enforcement is retained by the state. But beyond that, the level of delegation is really up to the state. So as much as they want to give us, they can give us. And so they can decide where they're comfortable. If they want to have us do surveys, but they don't really trust us at the end for whatever reason, they can keep all the post-survey work. It's very flexible. We can stop wherever they want. And that's kind of nice. They still retain all that control. Just because they pull in a private company, they're not losing control of anything. They're still in charge. Contractors travel statewide. So, a state like Kansas where you have rural areas, you might have a lot of people that live in certain areas of the state, maybe closer to the cities, that don't want to drive 4 hours out into the country, or, maybe they're just hard to get people out there. Our folks, they're used to it. They travel all across the country. So they're always away from home. So it's easier for us to go out to some of these harder to get to facilities. That helps the state agency sometimes because they might have a team that can work close to home because they don't need to travel so far. We've talked about how travel hours count towards the hours, the 40 hours a week here. In that example, if you have to have a surveyor travel 4 hours there and then 4 hours back, there's 8 hours out of your 40 in that week already. So you lost a whole day. If you can have them work closer to where they live, you kind of get that day back, and then you can send us out to the ones that are really far away. So because it's not costing you anything. On-demand support. So the idea here is, we can work as much or as little as needed. We have a number of states that we don't work in a lot, but they have an active contract. And that's because whenever something comes up, whether it be sick leaves or, absences, maybe they're doing a big training, all staff training for a whole week, they don't necessarily have to stop their survey momentum because they can have us come out and do some work during those periods. Other states we've worked with have had leadership changes. Maybe the top couple people of the survey agency left or retired or something, and they haven't even got anybody in there yet. We can go in there and kind of keep the work going while they sort of reorganize, figure out who they're going to promote, who they're going to bring in from other departments within the state government, however they're going to reorganize and get going. If they took a month or two to do that and just stopped working, you can see how all the surveys get behind. We come in, we work for that month or two, and then we stop, and so it's not like they're spending tons of money because we're not working a lot, but it does keep everybody from falling behind. There's also I don't know we've talked about it a lot today, but there's CMS state performance standards, and this has to do with how many surveys they're doing, and it's a lot of metrics, but the short version is some states will be struggling to meet those, and we can kind of step in and help get them there sometimes. Some of those metrics have to do with how many surveys they've completed, and that's one where we can definitely help because maybe they're almost there and they just need to get a few more done before their reporting quarter. I think it's quarterly. We can come in and do a few and get them there on that. And then lastly, the IDR feedback. I don't want to spend a lot of time on IDRs. You've heard a ton already from Improve. I will say, when we're doing IDRs and IDRs, our folks are active surveyors. I think Improve mentioned they have some former surveyors. Our folks are all active surveyors. They're right in the regs. They know what's going on. We actually provide feedback to the state agency so we have a recommendation letter that we write, similar to what Improve described, but then we also provide feedback that they can use to improve their surveys. So as an example, a lot of citations will come through and we'll do a review and we'll say, there's no evidence that the facility was out of compliance. However, it looks like if you had talked to this person or you had pulled this record from the facility's documents, you probably would have had a tag. So we'll send that in feedback. We say, the 2567 didn't have this evidence. It's likely there was a deficiency, but we can't support it because the evidence isn't there. We still kind of go with the innocent until proven guilty sort of mentality. So that helps them then go back with their surveyors and say, okay, don't forget to talk to this person. Don't forget to get this record. Get the evidence they need to support their deficiencies, because nobody likes to see dropped tags. The surveyors work hard on the tags that they put together, and to see it just go away because of a lack of evidence, even though you might be very confident that something that shouldn't be happening was happening, that can be frustrating. Yeah, benefits to residents. All right, good deal. So first off here, I think this is the most important reason we even started our company, was because we felt like we could help residents. And I think that's why the committee's here probably, is really a focus on residents. We talk about providers and we talk about the state agency, and they're all very important. The reason all the providers there is for the residents. And, I feel like the states often are very busy. They are so focused on work, they might not get to do as much training as they want to do. I mentioned this earlier. So we spend a lot of time on investigative skills. We're not necessarily hoping to find tags. What we're really wanting to do when we're in there is find the root cause of issues. There's going to be negative outcomes. That doesn't mean the facility's doing something wrong. But if they are doing something wrong, we want to find where that break in the process occurred. It could be the training is correct, but the CNA just missed it or didn't or forgot it or something like that. It could be that the training's wrong, and so, let's fix the training. The idea is to find where the deficiency is so the provider can fix it, and then all the residents are better off. And that's really where we spend a lot of time internally training our folks on proper investigation, talking to people closest to the resident first, kind of working your way up the chain. Because if you talk to the administrator first, they're going to know, they're going to have time to go and tell everybody, hey, listen, they're asking about this. Here's what you need to tell them. And then it kind of covers up a problem. And, I won't say that happens all the time, but it can happen. And so you need to investigate properly. Throughout the week, we are continually communicating with the providers, and we're also communicating with our supervisor staff. So the surveyors are out there talking to supervisors whenever they have questions. So they're very well supported. I know the state agencies do this as well, but sometimes the supervisors at some state agencies are overworked because they're short-staffed. We just started working with the state a few months ago, and they, out of, I think, something like 10 or 12 supervisors they were supposed to have, they have 2. And so the odds of a surveyor calling in and actually getting an answer that same day is really tough. We don't have that problem. We've got plenty of supervisors. Our surveyors are well supported, and what that translates to is when they run into new situations with a resident that had something happen, they can get the immediate support to know how to go after that, to get the evidence they need, and then that means no more lost citations, and addresses all the concerns that the resident may have. And lastly, our surveyors are there because they want to be there. I don't think anybody goes into surveying just because they want to get a paycheck. It's a tough job, and in most states, it's an underpaid job. So most people are there because they want to be there. The downside happens is when there's structural employment issues that prevent people from working. I don't want to work every week, or I have to make at least this much to pay my bills, and the state just doesn't pay enough, so they leave. We can provide a work-life balance, better pay, all those sorts of things so that those folks can still do what they really love doing. And so all of our surveyors are very much there because they want to survey. And I think that helps them really focus on the residents, help the residents out. They're just really passionate. In an office, you can also end up where some of these goals are not necessarily aligned to the resident. If the office is like, oh, we really need to catch up on surveys. Well, catching up on surveys is not the same goal as looking out for residents, because now you're just trying to get done with surveys. You're not necessarily trying to dig into any issues that you might find in the facility. So it helps to not have some of those distractions. And as I mentioned earlier, we just don't have the time limits that some states do. Our surveyors can work, they'll work through the weekend, they'll work through holidays if need be. They're going to stay there to make sure that residents are getting taken care of. And that's especially important in cases of jeopardy or harm where there is something going on that can be continuing to harm more residents. We don't want to leave until that's been addressed. All right. So, and then lastly here, I've got benefits to providers. Consistency is a big one. You've probably heard that from the providers today, that they would just like to know what to expect. And when you see one situation gets cited one way and a similar situation gets cited completely different, that can be frustrating for them because they sort of are like, well, we would like to try to fix this, but we don't even know what the surveyors are going to look for. So since we kind of cover the whole country, we don't have the same variability from state to state that some providers see. And then some states kind of have regional different disparities. Texas is a good example because they're so big. But even within an office, some states operate where they'll have a certain team of surveyors that always works together. That same team starts to kind of develop their own opinions that might be different from other specific survey teams. We mix our people up all the time. So the surveyor team themselves may have deliberations about, well, do you think this is deficient, or what tag should this be cited under? And so I think that helps lend some consistency to the process. Plus, we're pulling up supervisor support. When they have questions, they're going to ask our supervisors. It's the same consistent message from all our supervisory team. We also have a very dedicated QA team, and compared to state agencies, sometimes it's an add-on function. Supervisors at state agencies are often the QA people, and so it's not their only job. We have dedicated people, that's all they do is QA review, which the important thing there from a provider standpoint is we're going to get rid of tags that don't have evidence. And so a surveyor might cite something because they believe there was an issue, but if they didn't really prove it out, they shouldn't be getting cited for that. So we'll go through and find those. And so it's to a benefit to the providers, right? Because they're not getting tags that they look at and are like, well, they didn't even ask us what we were doing to take care of this issue. Well, then you really shouldn't get cited for it because you can't prove that you're doing anything wrong. And the other thing that happens in the QA process is we'll get, at least at state agencies that I've experienced, you can get surveyors are like, whenever I see this, I know they need to be cited on this tag because they're doing X, Y, Z. That's an assumption, and it's not necessarily true. And so in the QA process, we can be like, well, why did you cite this? Well, because at my state, we always cited this when we saw that. Okay, well, that's not what the regulation says. You didn't get the evidence. We need to remove that tag. Providers, I think, appreciate that. I don't think anybody's trying to avoid accountability. They just want to know what the standard is that they're being held to, and that's where our QA really comes in on. We do a very collaborative approach. We've heard from lots of providers, they feel like the survey process is punitive, like they're being punished. And we don't want that. The goal of survey is to improve the quality of care, not to punish anybody, despite these massive penalties that they seem to issue. So when we're in there, we're talking to the staff every day. We always say, when we get to the exit meeting with the nursing home administrator and whoever else they want to invite, there shouldn't be any surprises. They should know what we're going to be talking about because we've been talking to them all week. And the other thing that happens is I've heard from providers that'll say, I asked my surveyor, how can we go about fixing this issue? And I said, well, we can't talk to you. And it's true that the surveyors can't provide technical guidance, but there's really nothing that says they can't either point them in a direction of some technical guidance or at least review the regulation that they're being cited under. Well, the reason that we have to cite you under this is because the regulation says this, and here's what you did that doesn't meet that. That's okay to talk to them. It gives them an understanding and it helps them understand what they need to fix. And so we talk through that stuff. We don't see any reason not to try to help the providers in as much as the framework from CMS allows us to. And then, we try to be very compassionate, professional. We don't want surveyors in there that are like, I'm going to show you how tough I am and how much I can make your life miserable because I'm a surveyor. It's just not our culture. It's not the way we work. And when we hear about situations like that, they'll be out of our company. We won't keep them around. I think sometimes state agencies are under too much pressure. They already have a bunch of vacancies. So, how can you let another person go just because they weren't that nice? And for us, not being nice is unacceptable. And then, this last one's an interesting one because state agencies sometimes, since they are surveying the same group all the time, the same facilities every year, hopefully, you can get a reputation. Certain facilities, oh, that facility's always a problem. Well, sometimes the management of facilities changes. Sometimes facilities fix things, and maybe they're not such a problem anymore, right? So one of the things that can happen is surveyors go into a facility that they know has historically been a problem, and they're sort of expecting problems. And, you know, when you're expecting things, you're more likely to find them. It's just kind of been proven out, I think, over the years in all kinds of studies. So we feel like since our teams are not going back to the same facilities because we're working all over the country, we kind of remove that sort of past bias that can happen. It also gets rid of the idea of any kind of retaliation. You know, if a state agency, and whether it's true or not, if the providers feel like the state is retaliating against them, they're not going to have that with us because we're not the state. We're a separate entity, right? So we don't necessarily have that same motivation. And same thing with media coverage. I think that's another big one. You'll see the horror stories from certain nursing homes, and so then the state agency feels under pressure to find lots of violations in that home, because if they don't, then some reporter is going to say, well, the state went in and they said that it was fine, but yet we know these bad outcomes were happening. You know, we're going to look for what we're going to look for. We're not going to worry about media coverage in that regard. We're just going to do what we're there to do. And so I think that all that independence kind of helps with all of those things. And then, you know, I didn't have it on the slide, but IDRs, IADRs, you know, it's the same thing. We can electronically take those. So providers, some providers say, oh, well, the state makes us write all this stuff, and it's just a big hassle to even do it. We make it super easy. It's electronically submitted. And, you know, we'll set up a call with them, and we'll listen to their side of the story. And it's pretty straightforward. So next up, a little changing gears a little bit here. We do, when we exit facilities, we do a survey that we kind of give an anonymous link to the facility so that they can kind of give us some feedback. And I won't read through all these. You guys can read them. But you can see how there's sort of some sense that some of the state surveyor experiences that providers had weren't great, and typically they're better for us. I think my management team gave me a couple dozen of these things. I picked out 6 just to throw in here for you guys to see. Changed some names to protect state agency identities. None of these were KDADs. Like I said, we haven't worked with them, so that's good. But I think it's kind of indicative of the difference between what a state agency survey can be like and what our survey can be like. So yeah, you can read through those at your leisure. I think I've got one more up here. So yeah, so some budget considerations. We talked about this, you know, it's a great solution to use outside survey agencies. You know, why don't you just do that and it'll solve all the problems? Well, because it costs money, right? Resources are always never as plentiful as we'd like them to be. So there's a couple considerations though that I'll throw out there for you to think about, especially if you end up working through legislation on making things happen. You know, we work in a couple different ways. Most states will do a flat rate, and the reason that works well is because a state can say, you know, we have X number of dollars that we're willing to kind of throw to an outside agency to get some stuff done. When we do a flat rate, what we're saying is, and this kind of goes with the second one, the all-inclusive versus reimbursements. At the extreme, everything's included in one price. So that's going to be all the travel, all the time for the surveyors, any overhead we have, all of it. It's just going to be some price for one research survey or one complaint survey. And so the nice thing is you can budget that real well, because you can say, well, we want to do 40 surveys with your company or with an outside company. And so then the state survey agency can say, okay, here's the 40 we want them to do. We know it's going to cost this much because it's 40 times that number. Really easy to budget, really know what to expect. It removes a lot of risk. So the variable pricing, and that's something more like charging per hour based on the survey team's time, and on the reimbursements, it's like you think about travel expenses. The nice thing about flat rate inclusive rates is that if we go to a city and there's a college ball game or there's a big conference and all the hotels are super expensive, it doesn't cost the state anything extra. You know, that's just a risk we run. If a survey runs long, I mentioned earlier, if we need to be there 2 or 3 weeks to get rid of immediacy, it's still going to be the same price to the state. You know, we're going to absorb all that expense. You know, we hopefully make enough on all the other surveys to counteract it, but we lose money on some surveys, and that's okay because we're going to do the survey right. So that's some things to consider. Funding sources, you know, most state agencies are funded by CMS. CMS gives some money to the state because they're contracting this work out. But a lot of states we work with do kick in some state funds as well. You know, with the shutdown, I believe KDAD said they're stopping. I think I heard from KDHE, they're still going today. We have probably only 2 or 3 states that we've heard from that are actually stopping work today. And a lot of it's because most of those states have some state money supporting their survey agency. And so therefore, they can keep working even if the federal government shuts down. We don't mind it too much because the couple states that stop, we just take anybody that was working there, we move them over to the states that are continuing to work, which is the majority. So, you know, the other thing and this might be too common sense for state government, you know, I'm a private sector guy, so sometimes these things, you know, don't make sense to me. If you have 30 vacancies, you know, you're not paying people. So there should be some money there, you would think. I know it doesn't always work that simply, but I will often tell people, you know, they'll say, well, you know, you guys cost more than if we just hired somebody, and that's true. But if you have 100 surveys that aren't getting done, isn't it better to get 50 of them done than 0? Especially if you're just not paying the money because you have all these vacancies anyways. So those are some sort of things to think about when you're thinking about budget. And with that, I think I'll just see if you guys have any questions.
Very good. Thank you, Bob.
Yeah.
Committee, I'm not leaning one way or the other, but we do have everything on the table when it comes to this, and that's what we've heard is from this privatization. It is on the table and a potential possibility that I think we should investigate. So, committee questions. Representative Bueller.
Thank you, Mr. Chair. Thank you, Bob. I was going back through your support models, and I think your last comments may have covered this, but in light of what the chairman just said, I would be interested to the answer to this question. Can your company provide IDR and IIDR for the state of Kansas if we change the regulation? So you could that could be a turnkey thing we could turn over to you?
Correct.
Okay. In any state, are you the sole provider for surveying?
Not at this point. I will say in Virginia, we do a lot right now. There is an example that lost a lot of their upper leadership. Governor Youngkin signed an executive order to really fix everything. It's been in the media in that state a lot. So we're actually heavily involved with training their supervisors, training all their they have a whole new batch of surveyors. We're doing a lot of their back office work. We're making decisions on whether something is harm or not, which is typically something we reserve for the state. There was a legislator in Arizona a couple years ago who floated a bill to privatize the entire survey agency in that state. But of course, that's a pretty big ask, politically speaking. So there's no states that are there yet. Maybe 5-10 years from now.
So that kind of lends into what kind of capacity is out there. So let's say KDAD's, excuse me, said, hey, we need some help getting caught up on 10, 50, however many surveys. Mm-hmm. Is there a capacity limit that you have right now, or?
There is. You know, Kansas is a smaller state compared to some of the other states we work with. You know, you think of big states like California, Texas, New York, you know, they have a lot of facilities, Florida. You guys don't have that many. So even if you said, hey, we want to do 30% of our 303 facilities, that's definitely within our capacity. If you wanted us to do all 300, it depends on how quickly you wanted them done. You know, if it's like, we need them done in 2 months, that'd probably be beyond us. But we're always growing too. You know, as we continue to get more states, we're constantly training new people. We're working with different states to find ways to train non-surveyors to bring them in. Right now, states are the only avenue for somebody that's not a surveyor to become one, just due to the way CMS is set up. Again, going back to Virginia, we're working with them to bring in a few dozen folks that are our employees that will train through them. So that, again, constantly increasing our capacity.
Okay. All right. Thank you, Bob. Thank you, Mr. Chair.
Representative Reeves.
Thank you for your presentation. What is your turnover rate right now?
Our turnover rate, I would say it's probably around the 15-20% range. And that sounds probably high, but I will tell you that a lot of it's upfront. And so we have a pretty rigorous orientation program. So I mentioned that the surveyors have to come through a state program. So we don't typically have to worry about the 6-month ramp up because we're hiring people that are already surveyors. However, we will hire people and we'll take them on 2, 3, 4, 5 surveys with us to make sure they're going to match all the things I talked about in here in terms of compassion, professionalism, you know, not focusing on punitive activities. And so we lose some people there. In our training program alone, we probably lose 10, 15% right off the bat because they get out there and we see behaviors that we just don't want out of surveyors. They'll be mean to an administrator. They'll be like grilling them, like, the old light bulb hanging in the interrogation room kind of thing. And so, yeah, we're like, yeah, you're not going to work out here. And so we can make those changes quickly. But after that, it's typically just retirements. We pick up a lot of people that are 50 and older, who are already just kind of winding down at the end of their career. They don't want to totally quit yet, but 10, 15 years goes by and, now they're kind of getting to where they are ready to call it quits.
So it sounded like when you were responding back to Representative Bueller that you could do a short-term contract. So let's say we just wanted to help our state get caught up.
Absolutely.
And then that's it.
Yeah, absolutely. And what I find that is helpful, and your neighbors, Nebraska, do this. They a couple of years ago, they were quite a bit behind, and we went in there and we did like a dozen or so over a couple months, I think a dozen a month for a month or two. And then they were starting to get caught up. They had hired some people, they had some people coming out of training. And so we slowed down, but we kept the contract open. We just didn't attach any funds to it. It's sort of like you write these contracts so that they run 5 or 10 years, and then every year you kind of decide how much do you want to spend, and then and that way you don't have to go through the RFP process every year, because that is definitely the biggest hindrance to getting started, is getting the procurement team to understand the language of survey, getting them to evaluate properly. There's just challenges and delays with that, so that's what we see other states do.
Senator Thompson.
Thank you, sir. Thank you, Bob. I'm not arguing against looking at this, but, I'm seeing dollar signs.
Absolutely.
And that's probably my biggest concern. We're looking at, and I'm a big free market guy. But how do we, particularly when you're contracting with an agency and you get third parties involved, it becomes virtually impossible for the legislature to control that kind of thing. And I guess that's my biggest concern, duplication of efforts, among what you're doing versus what KDADS may do, and what kind of oversight we can even have on that process. That's probably my biggest concern. And what are you seeing in the states that you're already working with regard to how they deal with that so their budgets don't get out of control?
Yeah, absolutely. So typically the contracts will have some fixed amount of money that is a limit, right? And like I mentioned earlier, it's easier to sort of plan when we have fixed rate pricing, because if it's at a legislative level and you're saying, we want to help KDADS get 50 surveys done, and you put out a RFP, you're going to get some prices back, and you'll presumably take the best bidder, and then right then you'll see how much that money is. So that's going to be your hard limit. You're not going to pay any more than that. You'll know right up front. Now, other states that have sort of more loose structure, they might not define an amount of surveys they want us to do. They'll just say, we want to have a price list. And what happens there sometimes is they'll limit it by PO, purchase orders. So they may have a purchase order for a couple $100,000, and then once we've worked through that and it's out, then we just need to pause for a minute until somebody approves another $100,000 or another $150,000 or whatever it is they want to approve, so that the budgets don't just spiral out of control. You're not getting invoices like, wow, I didn't even know we asked them to do this much work. And the other thing to keep in mind is we only do the work that the agency is telling us to do. And they're still providing oversight. I mentioned a couple instances where there's less oversight because of states losing upper leadership, but in most cases, when we're in a facility and we think there's harm, we're calling the state, to say, here's why we think it's harm or why we think it's not harm, but what do you guys think? It's still the state typically making those final decisions. It's very rare that anything of substance like that we make the final decision. It's all, we're going to gather all the information and present it to whoever the designated person is at the state agency, and so they still retain that control.
And in every state you're working just directly with the agency. There's not any kind of legislative involvement other than providing some additional funds like you suggested?
Yeah, typically we're working with the state agency once the funds have been allocated. A lot of times the state legislature will allocate some funds, whether it's from some other part of the state budget or if it's just maybe directing the state agency to use their CMS money on private sector contract solutions, can kind of go both ways.
Okay, thanks, Bob.
Yeah.
Thanks, Mr. Chair.
Committee, further questions? Oh, Representative Ruiz.
Sorry, Bob, I thought about another one. Right now, you're contracted with KDHE?
Yep.
Under what capacity?
So we are doing research, complaints, revisits. We do pretty much any survey activity with them for all. So KDHE, I think it was mentioned earlier, they're all your acute and continuing care facilities. So hospitals, home health, hospice, ESRDs. I think ICFs in Kansas fall under KDHE. So yeah, we're just doing all those surveys. And we have been doing some precepting and training as well for them. They've hired some new surveyors. They'll go out with our teams to learn and observe how to survey. So yeah, that's pretty much it, survey and training.
Committee, further questions? Seeing none, thank you very much. You gave us a lot of things to think about.
Yeah, well, I appreciate the opportunity to speak, so thanks.
Oh, I did have one real quick. So what would be your relationship with CMS? I mean,
Yeah, good question. So CMS knows who we are. We work with them pretty regularly, especially on enforcement actions. Sometimes we'll collaborate with CMS's attorneys, on things that have risen to that level. They see our surveys come through. They know it's from us. They know it's on behalf of a certain state agency. We're subject to the same look-back surveys and comparative surveys that CMS can do. The way it typically flows is, CMS is going to do some portion of a state's surveys as comparatives or lookbacks to kind of grade the state on how they're doing. If it happens to be a survey that we did, they're going to be looking at our surveyors instead of the state surveyors. So largely we're just kind of like another state agency to them, I would say. The only difference is we don't have the enforcement jurisdiction, to like close places down or anything like that.
so following up on that, how afraid are you of CMS when they review your survey?
We actually don't, I wouldn't say we're afraid at all. I mean, it's one of those things, it's like taking a test, it's like, well, I hope we do good. But if we don't, it's a learning opportunity,
Well, you've heard our testimony, you've heard testimony before, the big fear, I think, of some of our survey crews are, are they going to find something that our crew didn't find, and then we're going to be in trouble because we didn't find that.
Yeah, well, this goes back to the slides I had about the resident and the provider benefits. We're really focused on doing the right thing. We're not going to worry about if we don't cite anything, we're going to get in trouble. We have no motivation against a deficiency-free survey. If the facility doesn't have deficiencies, we're not going to cite anything. We're not worried about CMS seeing that and coming after us. If they want to come after us, and do a comparative survey and they find some tags, well, so be it. Explain to us why you found that, and we'll see what we did wrong. But, we're pretty confident in our results. And I think the last time we had one, I think they may have had one tag that they picked up that we didn't. And that facility only had 2 or 3 D-level tags. There was no jeopardy in there. CMS didn't come back and find jeopardy or anything crazy like that.
Very good. Thank you for that. Committee, further questions? Seeing none, thank you very much for your time.
Thank you.
Okay, committee, next we have surveying and credentialing processes in other states. Kelly, are you on?
Yes, I am.
Very good. Welcome to committee. We can hear you fine.
Thank you. Do you want me to start with my presentation now?
Yes.
Okay. So Leading Age Kansas asked me to talk about survey activity in Iowa. I am the Director of Clinical Services for Leading Age Iowa, and I'm an RN and nursing home administrator by background. I also was a state surveyor for a short time, so have some experience in this industry. And I started in this position in 2021, so I have been tracking data for about the last 4.5 years on surveys in Iowa. And I provided you with some graphs that looked at the nursing home survey frequencies, the fines, the number of deficiencies, and then also the severity of those deficiencies based on that scope and severity scale. And basically, I mean, we can go through the graphs if you want to, but what we're seeing is that the state average for Iowa currently for nursing home providers is 11.34 months. So there are 6 nursing homes as of September 1st that are over 12 months. So, and they're at 13 months. So they're very close to that CMS expectation of a 12.9 months. Additionally, we have noticed that with the decrease in the recertification length, that providers are not receiving as many harm or immediate jeopardy level deficiencies. The cumulative fines at both the state and a federal level have decreased, as well as the total number of deficiencies. To date, in 2025, I have reviewed through the end of August for surveys. There are 48 nursing homes out of 392 total that have had a, we collaborate very well with our state agency, and they provide us as much context as they're able to through their CMS contract. And they were actually discussing this very topic on a call that we have with them just a couple of days ago. And they also have noticed the same trends. And I asked them, you know, what do you think is the reason for having less immediate jeopardy, less harm? And they identified that it is indeed because they're in there more frequently. Looking at the nursing homes, they're not identifying as significant of situations in the majority of providers. So there's a few things that I think have helped us get to this point. And I believe the person who testified before me was talking about, you know, outside survey agencies. And Iowa also contracted with surveyors, a couple of different companies, a couple of years ago with some COVID relief funding that they had to get caught up on those recertifications. And throughout that time, it allowed the state to then hire their own staff and conduct those surveys so that they're able to get to that period that we are right now. They also now have full or nearly full, you know, it may be 1 or 2 surveyors that they're looking for out of 6 regions. They probably have, you know, quite a few surveyors in each region. They're looking at completing an average of 8 recertifications per week. So depending on the survey, the size of the provider that they're surveying, they're required to have so many surveyors on that survey with them. And so they may have 1 or 2 that they're not, that are vacant at this time, but for the most part, they are nearly fully staffed. They also staff their complaint department different than their recertification recertification survey staff. So there's a dedicated set of individuals who complete those recertifications. They may pick up complaints or incident surveys during the week that they're in those buildings, but they also then are focused on that recertification. And then they have a separate set of staff that go out and just complete complaints and look at those incidents that occur, those abuse investigations, things like that. So that then allows them to schedule more recertifications. And there are times where those complaints build up. And then currently what they're doing is they're doing like a complaint blitz where they are putting some of their recertifications aside and getting those surveyors on those complaints and incidents to get those caught up, and then they'll resume those recertifications. Obviously, with the survey link that we have right now, they have that flexibility to do that in order to get them caught up. They also did some redistricting. So in Iowa, you know, we tend to have a lot of providers who weren't the greatest performers in like the Des Moines metro area, which used to be split up between a couple of different regions. And it seemed like one region had a lot of poor performing nursing homes in it. So they redistrict to split some of those up and allow for those surveyors then to have less problematic nursing homes to be able to then conduct those recertifications in a timely manner. Another thing that they've implemented is directed plan of corrections. And with that, they've identified repeat offenders to say that in the directed plan of correction, which is a CMS enforcement action that the state can do, they have worked with some nurse consultants, administrative consultants, and require that the nursing homes get in touch with those individuals and contract with them until they're able to then get back into substantial compliance and maintain that substantial compliance. And so that is one option that has helped improve the quality care and decrease the overall issues that we've had in some of the nursing homes. And I'm not gonna say that we don't have issues, because we still do. We still have those providers that are very poor performers and incidents that happen, like you may hear about in the news, but for the most part, they have reduced and we're seeing a lot better outcomes. So that's the end of my presentation. If you have any questions for me, feel free to ask.
Very good. Thank you again for being here. Committee questions. Wow, it doesn't look like there's any questions. Okay, very good. Well, Kelly, thank you so much for your time.
Yeah, thank you for having me.
Okay, Jody, are you on?
I am here. Yep. And I'm not sure why my camera's not working.
Welcome to committee.
I'm sorry. It says the camera's working on, like, I've started the video, but for some reason it's just not sharing it. Let's see.
Hang on, our
There we
guy's
go.
working on it too. Oh, you got it?
Yeah, and I have a presentation with a couple of slides on it, if that's all right to go ahead and share.
Sure.
Oh, sharing is unavailable, it says, but I believe that this was provided to you all, so I can just go over it and explain it as best I can. So what I have provided for you all is a couple of graphs that show data on deficiencies throughout the country, and then also compared to the region in Kansas. I'm sorry, I should back up. I got a little flustered with the camera. I should introduce myself. I'm Jody Eager. I work at Leading Age in the national office, and I work on nursing home regulatory issues. So I'm specifically working with CMS and with Centers for Disease Control and Prevention for the most part, and then providing support out to our state partners, Kelly, which you just heard from in Iowa, Kylie Childs, who you heard from this morning in Kansas, and all of our other partners. We're in I believe it is 42 states at this point. So, and I, again, work on the nursing home regulatory issues. So, I took a look at what the average number of deficiencies are looking like. Yep, thank you. Across the country. And as you can see from this graph, Kansas is, for the past, I went back to fiscal 19 because we know that things were a little bit different during the pandemic, but Kansas has consistently been outpacing both the nation and, in most cases, their individual CMS region when it comes to the average number of deficiencies for a survey. On the next slide, you'll see that this is also the trend when it comes to immediate jeopardy citations, that Kansas is outpacing the national average as well as the regional average. And in fiscal 23 and in fiscal 24, there was a significant difference between the national and regional averages and Kansas's state average for immediate jeopardy deficiencies. And so clearly there's I think it would be a little bit short-sighted to think that Kansas providers are just providing poor care, right? I think that the difference is probably due more to a change in surveyors or a change in survey process, maybe a change in training. That's typically what we see when we see a big jump. Other states have had jumps like this in the past that we've looked into, but we know that CMS is working with the state agencies to try and improve consistency among surveyors. And so we expect that, or we are told from CMS that what we should expect is that the states that are a little bit below the average in terms of deficiencies would probably increase a little bit, and states that are above the average should be decreasing, but it doesn't seem to be the case of what's been going on for the past couple of years in Kansas, which I think is why this issue, one of the reasons this issue is before you all today, one of the concerns. On the next slide, I've just taken a look at the civil money penalties, the per instance CMPs. And again, we see that Kansas is outpacing both the national average and the regional average. Just for a quick reference, the states in your region, it's Kansas, Missouri, Iowa, and Nebraska. Those are the 4 states that you're being compared to here in the regional tallies. And then the last graph that I have for you is the percentage of overdue recertification surveys, because I know that this is also a concern, especially when it comes to workforce issues. And Kansas is not alone in this. Again, we are hearing across the country that state agencies are having a significant problem with filling workforce vacancies in their state agencies. We know that CMS is trying to address the workforce shortages both in state agencies and in nursing homes. But this is kind of the outcome. There was a significant lag during the pandemic because surveys were frozen. Then we had a exacerbation of the workforce shortages. Now that we've entered another government shutdown, this is only going to further exacerbate the problem of overdue recertification surveys. And you can see that Kansas, again, is outpacing both the national and the regional averages in fiscal year 25 to date in terms of overdue recertifications. And for a point of clarity, an overdue recertification survey would be a survey that has not been completed in the past 15.9 months. That's the cycle time that surveys must be completed in for a regular standard recertification survey. So I did want to talk a little bit about some of the work that we've been doing in the national office. This is not certainly the only state that we've heard concerns from. This is not the first time we've heard concerns. And we embarked on a project, or rather, we developed a work plan a few years ago to kind of guide our work around this issue. And we came up with 3 main issues or kind of targets that we wanted to address. And so the first is this inconsistency in citation and enforcement. And what we're looking at, some of the areas we're looking to address regarding this would be surveyor education, training, and experience standards. There are no federal requirements in terms of the education of a surveyor or the experience of a person who works as a state surveyor. There are, of course, training requirements that have to be completed once you are hired as a surveyor, but there's no specific training that needs to be completed in order for you to be hired. We are also looking at surveyor compliance with statutory and regulatory requirements. So this would be the state performance standards that the gentleman before us was talking about. We keep an eye on those. They are released every year. And in fact, the fiscal 24 results were just released. And so we kind of keep track of those to see how states are faring in terms of their performance standards. And they are graded on everything from the use of an immediate jeopardy template to how well they're doing completing those overdue recertifications surveys, how quickly they're uploading the surveys into the online platform that allows CMS to access it, and several other metrics. In fact, nursing homes, I think, maybe have the most metrics among all of the providers that CMS is evaluating, or the provider types for surveyors that CMS evaluates. We're also looking at surveyor accountability, best practices, and evaluation systems. And so there's a couple of different programs that I'm going to talk about with you today on what we found as best practices around surveyor accountability. And then also with the evaluation systems, there's several states who have different feedback mechanisms on what a survey performance or a survey experience is like. So we'll talk about that. And then we're also looking at the informal dispute resolution and independent informal dispute resolution processes. These vary from state to state. There is a federal requirement, but it's pretty vague. It basically just says that the state needs to have an IDR process. But the way that a state conducts an IDR, or the way that IDRs are handled in terms of who does an IDR, it varies from state to state. And we've found what we believe to be some best practices among our states, and what seems to be working best. That's also something that is evaluated on the state performance standards, though, which is how often is a citation overturned through the IDR process. Our next kind of target area relates to the timelines for survey completion. So this could be the survey cycle, meaning how frequently, that 15.9 month survey window, or how long a survey takes. And CMS is actually piloting something right now called the risk-based survey that looks at surveying providers who meet certain metrics that they would then qualify as a high-performing provider. And CMS has not released these specific metrics, but we know that it has something to do with the number of citations they've had on past surveys, whether or not abuse has been cited on a past survey, the scope and severity, meaning whether like a citation resulted in actual harm or immediate jeopardy. If a nursing home does not fall into one of those categories, they are considered to be a high performer. Also, quality measures are another metric, and they would be eligible for the risk-based survey, which would be a 2-day survey conducted by a smaller survey team. Only 2 surveyors typically are coming out, or a small handful of surveyors, and they're really just focused on issues that they've identified before coming on site. Like, for example, if there has been a complaint, or if there's been a call to the ombudsman and they know that there's an issue they need to look into. Otherwise, it would be anything that comes up on survey, but they're not doing a typical deep dive into a record unless it's been flagged, for example. So CMS is piloting that. We've been advocating for that survey to actually be introduced as an official survey process, and we do hope to see that within the next year or so. And then also with the survey process reform, survey and investigation response times, we've heard from some of our states that when surveyors come out immediately after something has been reported, it doesn't give the nursing home enough time to actually investigate what is being reported and to know kind of the background, what exactly happened, and then to be able to put interventions in place. And then lastly, the barriers to quality improvement. This is something we hear, and it's probably the biggest issue that we hear, and I know that it's one that we've heard in Kansas too, which is kind of the attitude and the approach of both our survey agencies, but also the administration, is kind of seeing that, like, nursing homes are terrible places and we need to come in there and we need to find every single thing, rather than looking at it as here's a nursing home that is providing care for residents, and is there something wrong? Also looking at more constructive survey processes, and then the incident reporting and quality assurance processes to allow both nursing homes and surveyors to really be focusing on where the quality issues are. So some of the best practices, after doing all of this research and kind of looking into each of the states to try and find what we call the bright spots. I mentioned the survey mechanisms, the survey feedback mechanisms. We know that in Nebraska, for example, their state agency actually introduced on their own volition a survey that is available to all providers where they can provide feedback on what the experience has been like for them. And then the state agency, the state survey director, actually takes that feedback and uses that for quality improvement among his survey teams. And so he says, okay, we're hearing, for example, that many providers are reporting that there's not enough feedback during the survey. You know, surveyors are not answering questions when the provider is asking, like, well, what is it exactly that you're looking at here? What's the problem? Oftentimes we'll hear that surveyors say, I can't answer any questions. And that's actually not true. They're not allowed to provide technical assistance. That is true. But it doesn't mean that they can't speak to the provider at all. And we find that when the surveyors are more willing to say, well, you know what, we have this issue with Mrs. Jones that we are looking into a pressure ulcer. Just that little bit of information really helps to make the experience go a lot better, so that the providers in many cases are able to say, oh, okay, well, here's the documentation that you might be looking for. And here, let me talk to you about this issue. And so not only does the survey go better, but it also means that the residents are getting better care because it's more of a constructive process. With the IDR panels, so I know that this is something that Kansas is looking into, and it's something that the gentleman before us spoke about. There's two states that I wanted to highlight. The first is New York, which actually, New York and New Jersey, they evaluate their IDRs together, but they have a panel that does this, and it's the same now in South Carolina. And the panel is made up of folks from the survey agency, but it also includes providers, representatives from the provider world. So it's not the provider who has put forth the IDR, it's not the provider who's disputing the citation, but independent providers within the state, and they come together and they review the IDRs and review the regulations, and they are able to provide really a very neutral third party evaluation and determination, or at least recommendation to the state of what should be the outcome of the IDR. I have South Carolina up here specifically because they are doing this panel, and it's a very new thing. South Carolina previously didn't have the IDR panel that included the provider. And just within, I want to say, the past year, the Leading Age South Carolina affiliate was able to work with the state agency to make those changes. And they did it actually at the regulatory programs level rather than having to go through legislation. So it was a really positive experience for everyone and very collaborative. We've heard in Washington State of kind of off-survey technical assistance. So they have a nurse, it's called a quality improvement nurse, and she's housed under the state survey agency, but she provides assistance outside of the survey process. Because again, CMS says you're not allowed to provide technical assistance during the survey. The surveyors are there for enforcement. However, the survey agency, they're the experts on the regulations. And so they're able to send this quality improvement nurse out to a nursing home off survey, and they will maybe run the survey pathways, kind of almost like a mock survey. They'll discuss what they're seeing, what the issues are, and then they can provide information on resources and best practices that will help that provider improve quality for the resident before it ever gets to the level of having to be a deficient practice. And then the last one is the culture change initiatives. And this again is coming out of Washington State. There are several states that have things around culture change, but this one was by far my favorite because it was a collaboration between the state agency and the Leading Age state affiliate, where they work together to really transform the survey process and kind of the thinking around it. And they have 4 main concepts that they're targeting. And so those are, number one, they foster a culture of mutual trust and respect, where they believe, okay, the regulators, the state survey agency, these are the experts on the regulations, but the provider is the expert on the resident and on the resident's needs. And so how can we work together, recognizing both of those two truths, right? That we're both experts in our own subject matter. They also have they call it the 4 pillars. Their second pillar is surveyor competencies and qualifications, and the goal is to have well-trained surveyors with critical thinking and analytical skills. And so it kind of goes beyond the CMS requirements for training, which is requirements on the regulation. And they're really trying to work with surveyors about, okay, how are you citing this regulation? How are you interpreting this regulation? And how can we more effectively communicate that to make sure that it is consistent? Also looking at accountability, and this is real-time feedback without the fear of retaliation, and using feedback for process improvement. And this feedback is not just providers to the surveyors or surveyor to surveyor, but it is also from surveyor to the provider in ways like they complete a scorecard, for example, where both the survey agency and the provider get to provide feedback on what the survey experience was like, kind of like a shared understanding and raising awareness among all groups. And then lastly, the communication pillar, which is a goal of timely, clear, and consistent communication. And that's among survey regions within the state as well as between the state agency and the regions. And this touches on an issue that we've heard, or at least a recommendation that we've heard from many of our states, of the state agencies really working with the provider community for things like joint training or joining monthly calls where the surveyors will say, okay, here's some of the issues that we're seeing coming up in the survey in the nursing homes, and here's what we would recommend. And the survey or the providers can ask the surveyors, hey, when we look at this particular regulation, what does it mean, or how are you interpreting it? What should we be doing in our communities in order to provide the care and to meet the regulation? So those are kind of just an overview of what we're doing at the national office and the best practices that we're seeing. And I'm going to stop my screen share now so that I can so that I can see you all, and I'm happy to take any questions.
Very good. Jody, we see you now. Good, very good. Thank you for that. That was very helpful, and those best practices sound like some pretty good things that we might be able to implement. Committee questions? Well, I can attest that they're all awake, so I know that. So they're not asleep after lunch, but apparently no questions. Yeah.
Okay.
Hold on just a sec.
Thank you, Mr. Chair.
Representative Pickard.
It's really neat to hear about culture change and how they're going about doing that, because that's something that you can't legislate, and I think it starts from top down, and it's really refreshing to hear that it can be done. So thank you.
Yeah, and I will add that we have taken this to CMS, and we have suggested to CMS that they incorporate this as part of the surveyor training as well, and different communication techniques. But it really is I think it really is a mutual trust and respect, and a culture change that's focused on the mutuality of it. It's not just we recognize, hey, it's not just about saying to surveyors, hey, you need to be nicer. It's about surveyors and providers really having that mutual respect for one another.
Very good. Thank you for that. Committee, further questions? Seeing none. Thank you, Jody.
Thank you.
Okay, committee. Well, now it's time to put your thinking caps on. We've heard a lot today. Obviously, about a lot of things. So, Leanne, are you ready for some she's ready to type up 100 pages of recommendations, aren't you? Maybe not that many, but I do think we have some good ideas. We've heard some good ideas that we can start. Could we have Scott or Lacey come up for just a minute? I think there may be some questions. I have a couple of questions just more on the budget type of questions. How much do we spend on surveying and credentialing as, do you have that broken out? Just the, certificate, that budget item? Do we have that? You need to phone a friend?
Yes, if that was an option. I thought maybe that would, Scott Bruner, I'm the Deputy Secretary. I'll check what we submitted in the budget. I'll do that while you're asking Lacey other questions. Or, yes. I'll start on there.
All right, Lacey. Go ahead.
Oh, I thought I was answering questions. What's the question?
Oh, I thought you were going to answer my question
No,
about
he's
the
going to be
budget.
looking at the budgeting stuff if there were, and I was going to answer other questions. But we can wait. Scott doesn't want to wait.
Representative Pesa.
Thank you, Mr. Chair. I have a question before you get that answer. As you're talking about employees, do you have any positions that are like an as-needed, they don't need insurance, they just kind of want to do this work and fill in as needed? Do you have any positions like that? It's called peer in another type of, for just a name, but do you have a setup like that for the surveyors?
We've never utilized that, but I think we could do something like I think it's called a 1099 contract. That's an option with state employment, so they couldn't work over that many hours, I think, within that year. But those are options for any state employment.
Okay, thank you.
Committee, further questions? Representative Reeves.
Lacey, do we have options right now for off-survey technical assistance?
Not within my commission. Our agency has been working towards trying to get that back in place. We did create a new commission, the Commission on Aging, and that is one of the directives as that commission gets up and running that I think we do hope to have within there.
Did that answer your question?
Yes.
Okay. Scott?
Maybe just to also continue on Representative Ruiz's question. So the PEAK program, which is our agency's quality improvement initiative for nursing facilities, that's outside of our commission or outside of survey. It's on the aging side. So that would be as an example of things we could build on. So in fiscal 25, the end of the for that fiscal year, we spent a total of $10.7 million on survey activities that are in Lacey's commission, and of that, 6.8 million was for salaries and wages.
Very good. So, and that was, so in that $6 million, that was paying overtime, and obviously we've got a lot of folks now, because we're so short, that are getting paid overtime, and their salaries are a lot higher.
Well, a good share of the survey team, because they're exempt employees, they're salaried, so they don't earn overtime. There are some employees in the one that's eligible to earn overtime.
So I guess I'm confused. I thought we heard that you had a lot of employees that were non-exempt. So you have all your employees except one are exempt
So our
from overtime?
our registered nurse surveyors are by classification exempt. So they're salaried employees, are not eligible for overtime. They work what's required to complete their job. So we've talked to the Department of Administration about that status. The Department of Administration looks at federal rules about what's exempt and what's not. There are criteria for declaring somebody to be exempt or not. We've gone through that conversation with them a couple of times as we've talked about raising wages or using licensed practical nurses or using other profession types, licensure types on the survey teams. And when KDAD's made the decision to make all those survey RNs exempt, you can't go back. You kind of get one shot at making that classification or changing it, and you can't reverse it. So that's where we've been in a little bit of a pinch with RNs. And then, as Lacey explained this morning, as we've been trying to hire LPNs or other types of professionals in those generalist roles, they'd be most likely non-exempt because they're either not licensed, they're not in a professional management job, so they'd be paid overtime if they were working over their 40-hour week.
All right. Committee, any more questions? Senator Thompson.
Thank you, Scott or Lacey, on this one. You heard the complaints from the nursing homes that, we had situations that they gave examples of with the IJ that had been resolved almost immediately within minutes. And, obviously that's a big concern for us. How do you reconcile that with, what obviously they're getting big fines for something. We want oversight, yes, but we want it with some common sense rules. Just curious on your take on that.
Well, my job is to work with Lacey and the team on oversight. So I appreciate the questions. We've been talking to the industry a lot about these kinds of issues and trying to figure out what the right approach is. I think the couple of things that, at least my observation, kind of listening up to now, you heard from us about what we're doing and how we do it, and Lacey can talk more about how IJs or past noncompliance is looked at. You've heard from providers. The other voice that comes to me and comes to our agency are the voice of consumers and family members who call in, either call in complaints or let us know about incidents that happen that are really severe, very problematic, troubling, that we need to go and investigate. So there's a balance there. There are great operators in the state. There are great folks that are really committed to the work. We don't. It is troubling to hear a suggestion that we're out trying to find things because there's some incentive to us to find that. I don't think that's true. I haven't found that in my investigation of this over the last few years, but it is problematic, and I think does go back to maybe the point from the leading age folks that you just heard from, more communication about what we're doing, why we're doing it, how the process works, what the federal government requires would help with some of that conversation as well.
If I may follow up, yeah. But you heard from those providers, a couple of nursing homes, their long-term facilities, that it does create a perverse incentive. They report it, but they do with great reluctance because if it's been a situation that's been resolved, golly, it's just, you would think that somebody would say, oh, gosh, okay, you fixed this. Now, if there were a pattern to it, if it happened all the time, I could see stepping it up to a $10,000 fine or something like that. But if it's a one-time instance, it's been resolved, there was no harm, seems like we should have some kind of a spectrum that we judge those cases on rather than just jumping from a G to a J, for example.
And there is, and that may be what Lacey wants to comment on.
Just for 1 second, address what you said, Scott. So do you think those other states aren't getting those same calls that you're talking about from consumers and relatives and stuff like that?
Not at all. No, I think they are. They do probably get the same calls that we get. They run the same kind of.
That's what I'm saying. They're getting the same calls that you're getting, but yet if you look at the IJs in those states, they're significantly less. Do we agree on that? I mean, at least from what we saw?
Sure.
Okay.
Sure.
So I'm just saying, let's put that in context right there is those states are getting the same calls that you are. I would venture to say the nursing home industry is full of complaints from consumers or relatives or something just like that. But yet their IJ levels are significantly lower than ours. So I think we just need to leave it at that. Sure. Lacey.
So just to note, Leading Age did provide a very good overview through fiscal year 2024. The IJ and the amount of IJs cited by the KDAD staff is not something that most of you as committee members have not heard, especially if you're a Bethel committee member as well. So it's something that we have looked at. But so that being said, I have information for fiscal year 2025 that's not necessarily available to Leading Age. And as someone who's been watching this and looking at it, We are below the national average. I got to get my line item right here, but I printed out the charts. But it is something that Dawn and I have been watching. It's something that we started keeping stats on our survey staff on how many IJs a individual surveyor is calling, if they're calling them at the same places. We're keeping stats on our staff to make sure that some of those concerns that Bob talked about are not happening in our state. So the national average for identifying IJ is 4.2%, and we are at 5.1 currently.
In 2025.
Correct. Correct.
But we haven't been there in the other years. That 23 and 24 were way higher than this year. I mean, I was shocked to see only 8 and whatever it was on your figure in 2025, but we were in the 50s, 60s, 100s in the previous 2 years. I think that's where we're getting this rejection. You know, I mean, the complaints aren't just coming in from 2025. It was 2023, 24, where they were significantly higher, and you can look and figure it out, but I know they were significantly higher than the national average. So that's kind of what we're dealing with now, is the fallout from the past years.
Absolutely. And that being said, we can't go back and change the past, but we have listened to the Bethel Committee. We do keep track of that, and we do want to continue to improve and stay more in line with the national average when it's appropriate.
I do have some committee members that do have questions.
Can I had, before you, the one other thing about the punitive, about facilities calling something in and then us going out and investigate, I just wanted to clarify. So CMS, they revised the State Operation Manual, Chapter 5, which is an entire manual on how to do complaints for nursing homes for the most part. In that revision, it went from when a facility reported an incident or they self-reported, we used to have the option to not go investigate those. Now, because of the revisions to the State Operations Manual, regardless of the place in which the allegation comes in, regardless of who calls in the complaint, whether it's the facility, a family member, the ombudsman, me, no matter who calls it in, our staff's obligation to go investigate is now based off of solely how it is triaged. We do not get the option to no longer not go out when a facility reports themselves, because CMS took that option away in 2023.
Yeah, I cut in on Senator Thompson.
That's okay, Mr.
Let's
Chair.
let him finish, then I'll get to you and you.
You have a deeper understanding of this. So I'm just trying to get, so it sounds like your hands are tied by CMS to some degree, but are they tied with regard to developing a strategy that you don't have to use this block grid type thing? In other words, some kind of a spectrum from a single instance to a J. I'm just kind of curious. I'm trying to get my head around what the problems are.
The scope and severity grid is a required tool by CMS.
Okay, so your hands are tied to some degree. Is that fixable? I mean, if CMS, imposes this kind of thing, what kind of pushback do we have?
I think the bandwidth that we have is to kind of just roll the dice and play. So we can either meet the standards as we think that they're supposed to be met, and then kind of like we talked about, they do look back surveys. They give us a report card of how well we're doing. We have state performance standards that they look at every year. We can cite lower, we can do lower, but at the end of the day, regardless of how we cite, if it's a CMS tag that's being cited, our regional office and the CMS national office have the authority to go back and change any of my surveyor work and change it to the scope and severity that they think is correct.
Okay, that answers the question. Thank you. Thanks, Mr. Chair.
Representative Pickert.
Thank you, Mr. Chair. Lacey, hi. Have you guys considered using a third-party company for surveying to help you get caught up, or until you get enough staff? Wouldn't that take a lot of pressure off of everybody?
Yeah, no, and we actually have used a third party. Prior to COVID, we were using another party called Health Management Solutions, or HMS. And I work closely with my partners, so I can tell you when they were talking about Nebraska, they were talking about Dan Taylor. When they're talking about Iowa, they're talking about Vicki Worth and Linda Kellen. I have very good working relationships with most of the states who are the state survey director. I actually sit on the national board for the Association of Health Facility Surveyor Agencies. We talk frequently about the differences in our states, what's going right, what's going wrong, what we could do to be better, what's working for our state, what's not working for our state, those types of things.
So what do you think about that? Is it workable for Kansas?
Yeah, I think that there is opportunity for it. The thing that scares me is it is a steep cost. So the costs that we're looking at, or the budget that we're really looking at that we have to spend, is our vacancies. And I don't want to misquote, I have not gotten a quote from CertiServe, but we have in the past, just using what we were billed by HMS, we were looking at $30,000 just to start one recertification survey. And when you look at the total FTE got $60,000, that's 2 surveys for that money.
That probably requires a little more explanation. So Lacey described what our approach was with the surveyors. We figured out how much work we need to do to meet the standard and how many surveyors that would take given the number of facilities that we have in Kansas and the time to complete surveys. And then we said, well, to raise wages, we need to eliminate a number of positions and use that money redistributed among the current staff and the ones that we'd want to fill. So we've kind of cast our lot in that path to raise wages to try to recruit the state positions. So that means we don't have as much flexibility to do other things with that salary and wage money that's unspent because the positions are vacant. So we've kind of cast our lot down that path and over the year and a half it took us to kind of get all that all the way through Department of Administration, but we'll see how that plays out. But then if we're still short, I think that using an outside company to help either complete surveys or IDRs or other things you've heard about today is certainly on the table. We'll have to figure out how to finance it.
So just to give us a little bit of a timeline, I mean, if you do increase the salaries, how long do you think it might take? I mean, are you looking another year, or because you'll just keep getting further and further behind if you can't hire people? So
No, I think so. We made those changes the 1st of September, somewhere around 1st of September. So I think by the start of the calendar year in January, or when you're back in January, we can give you a better assessment of what luck we've had in recruiting, getting people in the training pipeline. You've heard about that today too, but getting the positions filled is kind of the first step, both with either registered nurses or other professionals that could do a generalist role.
because once you hire them, then they have to be trained.
Right. Then we're on a 6-month path to get them out in the field. Absolutely.
Okay. Thank you.
Representative Reeves.
Thank you, Mr. Chair. I would really like to see the multidisciplinary teams being used here and let's try to figure out this exempt, non-exempt situation. So Scott, you said that the nurses now are non-exempt. So, and we can't reverse that. So I understand that. And so if we widen it to include more of the multidisciplinary professionals, then we have to make that decision, right, about if they're exempt or not exempt, whether they're salaried or hourly employees. And I get all that. The thing that still kind of stumps me a bit is their license, whether they're licensed, currently licensed, or if they're, there's a social worker that's retired and is interested in doing this, they have to renew their license in order to do this job.
The only profession that has to keep their license current to be a part of the survey team is the registered nurse. Even a physician would not have to have their license current. CMS only, but that is why the registered nurse is a required component of the survey team.
The team. That makes sense. Thank you.
So we'd hire based on the qualifications or the training, not necessarily the licensure. Now, the licensure might make a difference in terms of the exempt, non-exempt evaluation, but not required for the role.
I have a question for Lacey. So Lacey, you said you're concerned. So how come we didn't hear all this concern about CMS and what they were going to do from these other states and the other testimony that we've heard? Do we have an inordinate fear of CMS, or I'm just trying to get my arms around it. I didn't hear that from any of the other testimony that we had about how they worried about CMS, breathing down their neck or we're doing something wrong. So could you elaborate on that?
I don't know that we have any other or any more interactions with our CMS regional office. I meet with them quarterly to go over where we are deficient in our workload in our surveys based off of the state performance standards. I do the work that I was contracted to do. I'm sure the other states are too, and I'm willing to look at where I can make that contract look different.
And how would that be?
I would probably make more gray area.
More gray area?
Yes.
So you feel like that there isn't enough gray area in the CMS contract for you to make the decisions that are best for the state of Kansas? Is that what you're saying?
When we're doing their work and we're citing their citations, that they're coming back and grading and reviewing and making sure that we did do it correctly, we're doing it to the expectation that they set. They're the ones paying for it.
And how do your contacts, your compadres in the other states, how are they dealing with that issue?
I will ask. I think that in other states there is some difference in opinions on what CMS's authority is. I think that also sometimes it kind of depends on your experience as the state survey director. The more years I'm in this role, the more confident I am to tell CMS, no, I'm gonna take this back and I'm gonna look and I'm gonna think about this. Admittedly, when I first started as the enforcement coordinator, it was very much if CMS asks you to do something, if they said jump, I need to say how high. That is not how I view it anymore. It is something that I have learned being a part of that national group and by working with people in other states. Missouri is a great example of tenure. Before Tracy Nykamp, who is currently their state survey director, there was Shelley Williams. Shelley was there for, I think, 25 to 30 years. Tracy's been there most of that tenure and continues on. I call her a lot to see what they're up to and what that experience that I'm missing might bring.
I'm very happy to hear you say that, because I think that is some of what the issue is going on in our surveilling and credentialing facility, is the fact that we're so afraid of what CMS may do that we're not able to have common sense and make decisions that are wrong by what their rules are versus the grace that you may want to give somebody else. For self-reporting or whatever variety of things. So I think that you're on the right track, but I think if I was any advice I would give you is continue on that track, because obviously we've got some real problems here in Kansas when it comes to the trust issue with the providers and with the KDADs and the LTSS and all that. So as you've heard, and I would guarantee you, the other thing I'll tell you is, I guarantee you that one little gal was right, was if they weren't afraid of retaliation, there'd be 50 of them here. And whether that's reality or perceived, it doesn't really matter to me. If people are afraid of retaliation from a government agency because of whatever, that does not set very well. Senator Thompson.
Thank you, Mr. Chair, and appreciate you standing for all these questions. And this is just what would be helpful for me and maybe the rest of the committee, I don't know. We had a number of potential options and solutions presented by some of the morning folks and even some of the afternoons. I don't know if Leanne or one of our researchers could compile a list of those options as potential solutions, but then also allow our folks from KDADS to take a look at that list and say, okay, here's where there's some fudge room. Here's where we could work together. Here's where it's just going to create a problem. I think that'll give us a starting point as to see what we can do legislatively to help. At least that would help me kind of get a better sense of evaluating what's possible for us to do, if that makes sense.
It does. I think, Senator, I think that's what we'll be coming up with here in just a little bit. I've got a few things. I know there's some other stuff around committee. Representative Bueller.
Thank you, Mr. Chair. And Scott, so one of the things that I heard, and I'm not going to go over plowed ground, but when it gets, you have the survey process, and then at the end of that, you have the IDR, and then the CMPs that are issued with that. And there were 2 points in the presentation today, and the point was essentially this, and I think this is a leading edge one, that says the high percentages of the tags are upheld. There's a low trust in the independence of the IDR statute, and in other words, low utilization. One of the other chart or presentations had Kansas at 100% upheld, and their independent I think research showed 91%, if I remember the chart correctly. So it's one thing to have a survey process that people don't feel good about, and it's another thing that the second part of that appears to be punitive. So what I would want to, or it could be, I don't want to accuse anything, but that's the way it felt to the people who were up here. So one of the things that I would suggest is we look at revising the amendment 39-947A or alpha to get rid of the current panel and look at an external IDR panel. So if that's, if we're to the point of recommendations, that gives us some place to look at. Here's what we currently have that's not working. Let's look at outsourcing the IDR process, and that would be one way to do that. So that was, I don't know if you have an opinion on it. Second part would be, I do applaud the work that you're hearing from people, and you're taking action on it. But I don't think, again, this is year 3 for me hearing the same thing over and over again. And so if after 3 years it's not working, we need to find another way to make it work. And the IDR process may be, or statute may be one way to kickstart that. And I've got some other ideas at the appropriate time, Mr. Chair. Thank you.
Very good. Scott, any response to that? It's okay.
I think that was very well put. I know the effort that I've tried to make, and we meet with the industry monthly as a group, and had some, and we've met with some individual providers that have raised similar concerns, and that when they come in, they say, I don't want to be here because I know because I'm here there's going to be retaliation, and I do my best to say, that's not going to happen, and if you think it does, then let me know, and I'll take action. So from a leadership perspective, I've tried to do that, but I think the IDR is an area where, you know, the team, Lacey's team that does that and then goes and recruits other people to try to fill in the panels. We're trying to meet the statutory requirement to do the IDR in the timeline that's required, and then we need to have people willing to do it. And when we don't get providers, or providers have to cancel, or whatever reason, we fill in the gap so we can do that and try to be as fair as possible. But the image of it, I won't argue with you about it. Regardless of the people that are doing it or the fairness that they try to approach, it just, you can't, that's swimming upstream just in the argument. So, but I think this changing the statute, we would appreciate, you know, if that's the direction the legislature wants to go, to have clear direction either in statute or by proviso, or so that we can make sure we're implementing what your direction is.
And I agree 100%. I think when it's made up entirely, which sometimes it is, of KDAD staff, you probably don't know that you're going to get a fair outcome whether you are or not. It's a perception issue. And maybe we expand the number of folks that are on it instead of, I think 3 is a very small number. It seems to me like it could be 6 or 7, 2 providers, 2 consumers, 3 KDAs, whatever. But yeah, agreed. Okay, go ahead, Scott.
Nope, that's all I had.
We're done with you for now.
Good.
So committee, just to start this off, just for these ideas, I've penciled down some as I just, and I don't really, we'll just go through them. So we heard a lot about the pharmacy provider fees. And I think that certainly needs looked into. You saw that they're charging pharmacy provider fees of $200 to $300 for using an out of their deal. Well, we hear from the pharmacists last week about how they're struggling, and I know I had a specific issue in town that the little gal was adamant. She almost got thrown out of her place because she wanted to use, and she was adamant. The guy that owns our local pharmacy was a friend of hers, and she was adamant, and she almost lost her place because they said, no, you're going to use ours, and she said, well, and she was very stubborn about it, and it was quite a deal. But I think that's one thing. Exempt employees, we've heard a lot of that. I don't know if it's just exempt employees, but it's dietitians and, it's kind of retired doctors, retired dentists, as part of the survey crew versus just an RN. I think that's IDR committee, that was kind of what we just talked about. One of the questions, a scorecard, I think that was kind of an interesting thing that we heard. It'd be interesting to hear from the providers about how they felt the survey went. Kind of a two-way street, a portal or something that they could send in and say, we felt it was a good, fair survey or not. I'm not saying that we should disregard or anything else, but just see what these folks have to say about our survey process, and if they do think it's fair and addresses the issues, or if they had time to do conflict resolution or explain their situation or something like that. So I don't think that's necessarily a bad thing either. The other thing that I was curious about was what the guidelines for the receivership money is. We were talking about $10 million. Can that be used for training purposes? And I know we are using it for some training purposes, but can it be used for expanded training purposes for survey and credentialing folks also, if we're up against a budget deal? So it seems to me like that needs to be fleshed out one way or the other. And so that's all I had penciled down here. You can either throw them in the trash or whatever you want to do, but that was my ideas. Representative Rivas.
Yeah, I would like to add to that list the idea about the waiver to give KDAD's deputies some authority to work with the fire marshal, because the example of the door with the fire code and all, that happened in our nursing home in our town too, the same exact violation. So that must be fairly common. But
I think it's very common.
Yeah,
with
fire marshal stuff comes up a lot.
Yeah, with child care facilities, all kinds of stuff. And I don't know, we've kicked this around in the legislature for quite a few years. I don't know what the deal is, but yeah, I can't agree with you more. I don't know the answer, but I think that something needs to be done. Agreed. Committee. Representative Orpeza.
Thank you, Mr. Chair. I would like to add something to the recommendation to kick around, especially since the wage is about $67,000 a year, which isn't that much compared to the private sector, of sweetening that pot, especially for bringing in a younger group of nurses and maybe offering paid maternity leave and seeing if that's an option to entice people to come and be a state employee.
I think we should look at the pay scale and all of that. So, yeah. Representative Bueller.
So thank you, Mr. Chair. During the first presentation this morning, we heard about raising the personal needs allowance, the daily rate to $72 a day with a COLA. just, I'd be curious is if we can get a fiscal impact of what that would look like prior to the next session. So I think at this point, that's the last one that I have. Maybe a question back. When we talked about the pharmacy provider, to be clear, we're talking about residents of the adult care homes have the ability to use their pharmacy provider of choice free from additional charges. That's what we're asking. Is that correct? Okay. That's okay. Thank you, Mr. Chair.
Representative Reeves.
I would like to add the issue about expanding the discharge reporting requirements when there is an involuntary discharge that the statute was given to us. I think this was Haley who gave us this information, the ombudsman, that we would need to expand the statute in order to require that the ombudsman be informed of these discharges, these involuntary discharges. I don't know if we've already said this or not, but establishing a true independent IDR process.
I disagree with Haley about needing more resources, but if there's 500 and some more hospitals come on board, I find that hard to believe that she can do that with the staff she did, but she said she could, so we'll see. Anything else, Representative Reeves?
I just wanted to add for the committee's benefit that the issue of discharge requirements being expanded has been a topic of legislation before. Two of them that came up in 2023 were Senate Bill 191 and then House Bill 2246.
There you have it. Thank you for that. Committee, anything else? Okay. Representative Pickard.
If we think of something overnight, can we bring it up tomorrow morning or sometime? My mind's kind of foggy right now.
Yeah, I know. It's difficult. That's why I write stuff down as I'm thinking about it, because at the end of the deal, I'm like, I'm just ready to get out of here. Well, if you think of anything else, holler at Leanne, holler at me, any other ideas or anything. But again, as I always say, doing nothing is not an option. We have some issues here in our state, and we have some opportunity here to make some better relationships between our providers and our agency, and we need to continue to do that. So with that, we're adjourned.